46-year-old male, Mr. Vettum Perumal, presented with unilateral reducible swelling since 1 year in the right groin region, which aggravated on coughing and exertion and reduces on lying down. There is no history suggestive of strangulation or obstruction, and probably it is a unilateral uncomplicated direct inguinal hernia.
Complaint is swelling in the right groin. What do you mean by groin?
So when the hip is flexed, the inguinal and femoral region touch together, and that region is called as groin.
Only complaint is swelling, no
Yes,
pain. What will be the first complaint in the case of hernia?
dull aching, dragging type of pain.
Dragging type of pain. Okay. Why did you ask coughing?
So because due to increase in intra-abdominal pressure, it may lead to hernia.
Swelling disappears on lying down. What does it mean?
So it means it's a sign of reducibility. So it favors to the direct inguinal hernia.
What is reducibility?
So the swelling, when it gets pressed, it goes into the abdominal cavity and disappears. And on strain, cough, or any kind of exertion, the swelling again appears outside
What
the
is the
abdomen.
difference between reducibility and compressibility?
fascia conjoint tendon,
spermatic fascia, cremastic
cremastic fascia, internal conjoint tendon, and fascia
fascia
transversalis.
whereas in case of indirect hernia,
Sir, it is skin, external oblique, internal oblique, and
Covering.
skin, external spermatic fascia, cremastic fascia, internal spermatic fascia, and extraperitoneal tissue.
What do you mean? Neck of the
neck
sac.
of the sac.
How to identify?
Neck of the sac is identified intraoperatively by the extraperitoneal pad of fascia.
Externally, extraperitoneal fat. It is the narrowest portion.
Narrowest portion.
Medially, inferior epigastric artery will be present. What is fractured myopectineal orifice?
Frochard's myopectineal orifice is an osteomyoaponeurotic tunnel which is bounded medially by the outer border of rectus muscle, superiorly by the arching fibers of.
What is the importance of myopectineal orifice?
It covers the defect of direct, indirect, femoral, and
So
operative.
all groin hernias are coming out through the myopectineal orifice. Okay, right. How to classify hernia clinically?
Clinically, it is classified to reducible hernia, irreducible, obstructed, strangulated, and inflamed hernias.
What is obstructed hernia?
Obstructed hernia, when the contents of the hernial sac gets obstructed, it is obstructed hernia, but blood supply is intact. And there will be features of intestinal obstructions.
So what are the clinical features of intestinal obstruction?
So colic, abdominal pain, vomiting, abdominal distension, absolute constipation.
What is obstipation?
So not passing flatus and feces.
Along with that, visible intestinal peristalsis also would be there. Patient will present with irreducible swelling in the groin with abdominal distension with VIP. Okay, right. How it occurs? Why strangulation occurs?
Sir, due to intestinal obstruction initially, there will be dilatation of the bowel,
Initially there is
irreducibility.
irreducibility, then
Irreducibility leads to congestion of the bowel and impedes venous circulation, and there will be
which
passage
part is initially affected?
neck of
Venous part is initially affected.
venous
So
pa-
venous return is
venous
initially
return is
affected. Why?
initially-
When compared to arteries, vein have thinner walls. That is why it is easily affected. So it leads to venous congestion. This venous congestion lead to
dilatation
obstruction of
and
the
congestion
artery.
dilatation of the bowel, which later leads to impedes the arterial supply to the bowel, and it leads to strangulation later.
Venous congestion causes the edema of the mesentery, which will compresses the artery, further causes the restricted blood supply to the bowel wall and gangrene.
Okay.
That's called strangulation.
Name some rare hernias.
Otherwise named hernias.
occlusion test?
Sir, after getting consent of the patient is asked to lie in the supine position, and after reduction of the content and occlusion of the deep ring, which is 1.25 centimeter above the mid-inguinal point, that is midpoint between AS, anterior superior iliac spine, and pubic symphysis, the patient is asked to stand up, and he is asked to turn to the other side and cough. If the swelling appears medial to the occluding finger, then it is inguinal hernia. But if the swelling does not find access on coughing, it is indirect inguinal hernia.
Why it is not coming out in a case of indirect inguinal hernia?
Because in indirect inguinal hernia, the course is through the direct inguinal. It initially enters the canal through the direct inguinal ring, deep inguinal ring, and then it comes out through the superficial inguinal rings.
Which hernia comes out through the deep superficial inguinal ring? Direct or indirect?
Both direct and indirect
Both
comes out
direct
through
and
superficial inguinal.
Indirect. Both are coming out through the superficial
Superficial
inguinal ring.
inguinal.
How to classify hernia according to the extent? What is bubonosil?
Bubonosil is when the content traverses through the superficial inguinal ring, and it is in the inguinal funicular. Funicular. It is lying just above the testis.
Testis, yes. Then
And complete hernia. When it comes out of the deep ring, superficial ring, and it reaches the bottom of the scrotum.
how do you differentiate between the congenital hernia and complete hernia?
Congenital hernia while initially the size will be up to the base of scrotum. It reaches the base of scrotum.
So both are base of the scrotum up to congenital hernia also up to base of the scrotum, complete hernia also up to base of the scrotum. Then how do you differentiate this? Audience are murmuring. How do you differentiate between congenital hernia in adults as well as the adult hernia, complete hernia? How to differentiate the both? How congenital hernia happens? Testis palpable complete hernia, whereas in congenital sac, testis within the sac. We cannot palpate the testis, okay?
Your diagnosis is hernia. How to investigate? Sir, எவ்வளவு நேரம் சார்?
Sir, you can take your time, but we have another case also. Two more presenters are waiting.
Okay. How to investigate?
Sir, in case of hernia, clinical diagnosis is the main mode of investigation, but I would like to do other investigations like routine investigation, which includes both blood and urine analysis. And for anesthetic purposes, I would like to do ECG and chest X-ray, and USG abdomen and pelvis, and USG of right.
What is the use of ultrasonogram in a case of hernia?
Sir, ultrasound in case of inguinal hernia, it is used to detect the post-voidal urine volume.
Post-residual volume of urine, okay.
And
Prostate enlargement, okay.
Prostate enlargement, to rule out any abdominal mass, or it is also used to find out the content of the hernial sac type, direct or indirect.
Bladder wall thickening also you can find out. Okay, right. How to manage? What is the treatment for this case?
Open or laparoscopy, Lycestin, tension-free.
Which one you will advise? Open or laparoscopy?
Open.
Why open?
Laparoscopy, it is learning course is difficult, sir, and maybe cost effective it won't be.
Eminent surgeons are available in your hospital.
And
You can choose the patient according to comorbid condition. So nowadays laparoscopy is very common in all hospitals. Okay, no problem.
Okay. What is herniaplasty?
Strengthening of the posterior inguinal canal by placing the mesh.
What mesh?
We can polypropylene mesh.
What is the
And
color of the mesh?
white color, sir.
What is the color of the Prolene material?
Blue,
Blue. Color of Vicryl?
violet, sir.
Violet. Okay.
Why you use proline instead of Vicryl for fixing a mesh?
Sir, Prolene is non-absorbable mesh, but Vicryl is absorbable.
Okay. Why you are using non-absorbable?
Non-absorbable mesh will cover the
Non-absorbable material.
non-absorbable material. It cover, if it is absorbable, it gets absorbed and defect will not be covered accordingly for a long time, sir. But non-absorbable mesh will cover the defect.
We are not talking about the mesh. We are talking about the suture material.
To hold the mesh in place.
Okay. What are the complications of hernia surgery?
Sir, intraoperatively it can lead to uh, injury to the injury to the vessels and nerves, and it may lead to hemorrhage. Um,
Which vessel commonly injured during the hernia surgery?
Inferior epigastric artery is commonly
Yes.
injured.
What is post-herniorrhaphic hydrocele?
After the surgery, due to infection of the mesh, the secretions are
Infection of the mesh is not
Infection of
hydrocele.
mesh is not hydrocele.
infection of the tissues.
It's not like that. Then what is hydrocele?
It is collection of fluid around in the covering of the testis, that is tunica vaginalis or
In between two vein, tunica vaginalis. Tunica vaginalis is a pouch of the peritoneum. Then why post hernioplasty hydrocele occurs? Now tell.
Tell me,
a
what are
post
the causes for recurrence?
recurrence. Uh, it may be patient factor, maybe the precipitating cause may not be corrected, and then the patient may be continue to
One, missing the sac.
missing the
Second,
sac.
using the faulty suture material. Third, without treating the precipitating cause, if you do surgery, there is a chance for recurrence. These are all the causes for recurrence. Okay. What is TAP? TAPP?
TAP is trans abdominal preperitoneal repair mesh repairs.
moves with deglutition and does not move with protraction of the tongue. The skin of the swelling is pinchable and the plane of the swelling is deep to cervical fascia. Lower border is palpable. Carotid pulsations are felt normally bilaterally. No neck nodes are palpable. Trachea is palpated in the midline. On percussion, there is normal resonance over the manubrium sternum. On auscultation, no bruit is heard. Other system examination, cardiovascular system, S1, S2 is heard, no murmurs are heard. Respiratory system, bilateral air entry is present. Central nervous system, no focal neurological deficit, no involuntary movements or tremors. Abdomen is soft and not tender. My diagnosis, this patient is a case of a non-toxic, non-malignant, solitary nodular goiter of the left lobe of thyroid.
Okay, go to previously, general examination.
Why do you ask about pulse in detail?
Sir, in thyroid, especially in case of secondary thyrotoxicosis, the cardiovascular system bears most of the brunt of it. The patient can have AF, auricular fibrillation, they can have congestive cardiac failure.
So normally in hyperthyroidism, everything is increased, like tachycardia, arrhythmia, like that. In case of hypothyroidism, bradycardia and failure will occur. So pulse rate, volume, character, everything to be recorded in your case sheet. So that's very important.
Why did you mention about tremor?
Sir, in primary toxicosis, even before swelling is seen in many conditions, the symptoms of toxicosis can be seen, sir. Tremors is one such symptom, sir.
Where will you look for tremor?
So we can look for tremor in the tongue and in the hands, sir.
In anxiety neurosis also patient will be having tremor. So how to differentiate anxiety neurosis from hyperthyroidism? Anybody? Sleeping pulse rate is very important. Sleeping pulse rate, that is normal in anxiety neurosis, but it is increased in thyrotoxicosis. Okay. What are the eye signs you look for?
Sir, we look for Von Graffies, Joffrey, lid retraction, lid lag, exophthalmos.
What is one graphy sign?
Von Graffi sign is lid lag, sir. Lid lag, sir. When the patient is asked to look downwards, the upper eyelid of the patient moves.
Okay, lid lag is one graphy. Yes. Okay, Stelbach sign?
Staring look, sir.
Staring look. Okay, Dalrympe sign?
Sir, absence of when the patient is asked to look downwards and turn their and elevate their eyeballs, there is absence of crease in the
Wrinkling.
Wrinkling is absent.
What is Mobius sign?
Mobius sign is inability to converge.
Okay, what is the first sign? What is the last sign in a case of thyrotoxicosis? Okay, last sign? Mobius sign. Mobius sign. Okay. What is Knopfziger test?
So Knopfziger's test, we stand behind the patient, sir. We ask the patient to extend their neck, and from above the supraciliary margin, we view the patient, sir. If we are able to see the pupils from there, it's positive, sir.
You didn't mention about the palm. Is there any change in the palms?
No moisture.
Hot moist palm is a characteristic feature of hyperthyroidism.
Yes, sir.
Lymph node.
Lymph nodes.
Okay.
So in retrosternal goiter, what sign you will look for?
Pemberton sign, sir.
What is Pemberton sign?
Sir, due to large goiter with extension retrosternally also, we ask the patient to lift their arms by the side and such that the
You
arm
ask
touches
the
the ear.
patient to raise the hands and keep it close to the ears. You wait for 3 to 5 minutes. Patient will present with congestion of face, and dilated veins will also be seen in the chest wall. This is Pemberton sign. Okay. Next. In palpation, you have to mention, I am palpating the patient from behind. Okay. Right.
So how do you do the plane of the swelling? What are the tests?
Sir,
You told about deep to deep cervical fascia. How to look for
test the deep cervical fascia by asking the patient to extend their
Extend
neck,
the
sir.
neck.
And if the swelling is deep to deep cervical fascia, it will become less prominent.
Less prominent. So next to deep cervical fascia, what will be the plane of the swelling? Deep to deep cervical fascia, deep to which muscles? Thyroid gland is deep to deep cervical fascia, also deep to
Strap muscles.
What are the
Muscles.
steps?
strap muscles. What are the strap muscles cover the thyroid gland?
Stylohyoid, thyrohyoid,
So what are the strap muscles? What are the strap muscles?
sternohyoid,
Superior omohyoid. Okay, right.
Omohyoid. How do you look for the test? Strap muscles test.
didn't tell us.
How do you know deep to deep cervical fascia? That is by extend the neck. And strap muscles, extend the neck and ask the patient to depress the chin against the resistance. That's for sternocleidomastoid. In addition to that, you can avoid the suprahyoid muscles by putting your tongue against the hot palate like this and ask the patient to depress the chin against the resistance. Thereby you contract the strap muscles. Its swelling is become less prominent. It is deep to strap muscles. So when you tell about the plane of the swelling, deep to deep cervical fascia, deep to strap muscles and deep to sternocleidomastoid, all three will be present.
What is Pisillow's method of examination of thyroid gland?
So it is a method used to examine inspectory examination of short neck individuals, sir,
Okay.
and in obese patients, sir. We ask the patient to interlock their fingers, place their thumb on the occiput of the head, and extend their neck, sir.
Okay. What is Logis method?
Sir, Lahey's method is a palpatory method, sir. In this, we use 4 fingers of one hand to push the thyroid gland to the opposite side, and it is palpated with the other hand, sir.
That is the method of palpation for unilateral lobe. What is Kreil's method?
So, Kreil's method is used to examine multiple small nodules in the
அவ்வளவுதான் இருக்கா?
gland, sir. We use the thumb of one hand to palpate, sir,
That
and
is the
while
method
asking
of
the patient
palpation
to
for
swallow.
solitary nodule.
Yes, sir.
What? రెండు question. What is Berry sign?
So, Berry sign is sir, absence of carotid pulse due to infiltration.
Why
into-
carotid pulse absent in Berry sign? That means carotid is absent. The carotid flow is absent to your skull, brain, everything.
No, sir.
Ah,
No, sir. The carotid sheath is infiltrated by the tumors, which prevents the pulsations from
So
being felt by
absence of carotid pulsation is Berry sign positive. Which carotid artery you are palpating?
where you look for palpation of carotid? And what is that artery? How many carotid arteries are there?
2, sir.
Two.
Two. You are palpating both arteries.
Both arteries.
Not simultaneously, sir. One at a
Not
time.
simultaneously.
There is 3: common carotid, external carotid, internal carotid. Which carotid you palpate? That's why sir asking.
Common carotid.
Common carotid at the level of C6.
C6.
vertebra.
Where
If
the
you want to palpate the internal carotid, where will you palpate?
Sir,
Inside the
oral cavity.
tonsillar fossa. Okay, right.
investigation.
So what is your diagnosis?
Sir, the patient is a case of non-toxic, non-malignant, solitary nodular goiter of left lobe of thyroid, sir.
But tell me differential diagnosis for solitary nodule. Well, 3 more questions.
Sir?
What are the differential diagnosis of solitary
solitary
nodular
nodule
goiter?
goiter.
SNG-யோட differential diagnosis சொல்லு. Thyroid swelling, thyroid cyst,
Colloid cyst, solitary nodule,
Simple goiter.
toxic adenoma, follicular adenoma,
Follicular adenoma.
non-dominant nodule of the multinodular goiter. What is the difference between solitary nodule and dominant nodule?
Sir,
Both are same or different?
solitary nodule is the only nodule in an otherwise normal thyroid gland, sir.
Dominant nodule is?
Dominant nodule is the only palpable nodule in case of a multinodular goiter where the other nodules are not palpable.
Okay, how to investigate this patient?
Sir, investigation, first we'll do a ultrasound of the neck, sir. Then we'll do a thyroid function test, following which we can go for a FNAC of the neck swelling, sir.
So what are all the conditions can be diagnosed by doing FNAC?
So in FNAC we can identify colloidal colloid goiter.
Colloid goiter.
We can differentiate between
All benign and malignant to be differentiated.
yes, sir.
But you can't differentiate the follicular adenoma from follicular carcinoma. Why?
Sir, infiltration can be seen only in a cut section, sir.
So,
just by
vascular invasion.
And capsular invasion not seen in the FNAC.
FNAC.
Okay. How to grade the AC? How many grades are there? What is
Two
Bethesda's
systems, sir.
classification?
Bethesda's and Thyroid, sir. Bethesda classification, we have 6 gradings, sir, in it.
Okay.
It's a thyroid, it's type 1 to type 6.
Okay. Non-diagnostic, number 1.
Non-diagnostic, benign, suspicion of atypia.
Non-malignant. Okay. Next.
Sir, atypia of with unknown specificity, and with malignant signs are present.
Suspicious of malignancy, finally malignancy.
Malignancy. Yes.
Okay. Any other investigation?
Sir, we can
Thyroid function test is important. Okay. In hypothyroidism, which level will increase? Hypothyroidism.
sir, hypothyroid T4 is decreased and TSH is elevated, sir.
What is subclinical hypothyroidism?
Sir, in subclinical T3 T4 is normal, sir. TSH is elevated.
What is T3 toxicity?
T3 alone is elevated, sir, but
Elevated. Okay. Right. Any other investigation in a case of thyroid?
So want to do a surgery for this case. What exam you have to do?
sir, an X-ray is necessary initially, sir.
X-ray then?
Or indirect laryngoscopy needs done, sir.
Flexible laryngoscopy. Flexible. What's the importance of laryngoscopy?
Sir, to assess the preoperative status of the vocal cord, sir.
Vocal cord,
And
number 1.
for documentation for ML purposes, sir.
Okay. Your case is non-toxic.
Yes, sir.
Saltary nodule. What is the management?
Sir, based on the FNAC report, we will proceed with management, sir. Since
FNAC comes as a benign.
if it is a benign, we will proceed hemithyroidectomy, sir.
What is chemithyroidectomy?
Sir, it is a surgical removal of one lobe along with the isthmus of the thyroid gland, sir.
Why do you want to remove the isthmus along with the lobe?
Sir, many times there might be microscopic infiltration.
No,
of
no, no.
No,
The
the
commonest
pathologist-
position for the occurrence of the nodule is at the junction between the isthmus and the lobe. That's why you have to remove the isthmus along with the lobe. What is total thyroidectomy?
So total thyroidectomy, we remove the entire both the lobes along with the isthmus, sir.
Isthmus. So you have done thyroidectomy. The report is papillary carcinoma of thyroid. How to manage?
So now we will proceed with total thyroidectomy, sir.
Completion thyroidectomy.
Completion
Completion
So after doing completion thyroidectomy, what will you advise? In a case of papillary carcinoma of thyroid.
How do you follow the case?
So they'll need lifelong T3 T4 supplementation, sir. And
Why do you want to give L-troxin?
sir,
So
Why do you
after
give
thyroidectomy,
L-troxin?
you have to give L-troxin.
yes, sir.
How much you will give?
How much dose we will give and why can you give?
Sir,
Replacement dose or suppressive dose?
There are three types
Suppressive
of dose: substitutive, supplement, and suppressive. What type of dose you will give the patient?
suppressive dose.
Suppressive dose.
Suppressive dose means how much?
What is meaning of that suppression?
So it is used to suppress the TSH levels.
Okay.
suppressing.
So it is a
Hypothalamic
TSH
axis.
dependent tumor. That is why you have to give L-troxin. Okay. What are all the complications of thyroidectomy?
Sir, hemorrhage, external angel nerve injury.
Hemorrhage. What is primary hemorrhage? What is secondary hemorrhage? What is reactionary hemorrhage?
So primary hemorrhage happens during the intraoperative period on table or
At the time of surgery, if there is bleeding, that is primary
Primary
hemorrhage.
hemorrhage.
What is reactionary hemorrhage?
so reaction hemorrhage is after 48 hours. We have
Due to release slippage of the knot or release of spasm. Then secondary
secondary happens in the postoperative period with 48
infection.
hours.
Okay. Then any other complication?
Sir, parathyroid, hypoparathyroidism can occur, sir.
Okay. How to differentiate parathyroid from the fat?
Sir,
How many parathyroid glands are present in our body?
4 parathyroid glands are present,
Okay.
sir.
What's the blood supply of parathyroid?
Superior thyroid artery supplies the superior two parathyroid, sir, and the inferior two are supplied by.
What is the color of the parathyroid?
It is brownish in color, sir.
Okay, accidentally you have removed the parathyroid. What will you do?
Sir, we can cut it into. We can mince it
You
into smaller
implant it
pieces
into
and
the
implant it in the brachialis
sternocleidomastoid
or
or
the SCM. Brachialis.
non-dominant forearm muscle.
Yes, sir.
Okay, how to differentiate parathyroid from the fat?
So when we drop it in NS or when we drop it in distilled water, fat will float whereas the parathyroid glands will sink.
Tell me the features of hypoparathyroidism.
So
Symptoms.
tetany,
What is the first symptom?
numbness.
Perioral numbness. Perioral. What is Chivostek V sign?
Chostek sign is on tapping of the facial nerve. It will elicit.
You tap in front of the tragus. You can see the twitching. Okay. What is Triceps sign?
Sir, on elevating on BP cuff, when we elevate the pressure, patient's hand will go for flexion.
Okay. Last question. What is thyroid storm?
So thyroid storm happens when there is a sudden release of free T3 into the systemic circulation, sir. It is a complication of FNAC.
So inadequate preparation is the cause for thyroid storm.
storm.
Okay. Very good.
Very good.
Thank you, sir.
Thank you, sir. I now would like to invite our chief guest chairpersons to distribute the token of appreciation. We'll conclude the session by honoring our chairpersons. Now I'd like to invite Dr. Meena Ranjini ma'am, Senior Assistant Professor, Department of General Surgery, Government Thoothukudi Medical College and Hospital, to felicitate our chairpersons. Thank you, ma'am and sir. Until we are moving to the next session of our CME, let's have a small interactive session.
So before that, let's thank our professor and eminent faculty, Sindhiraman sir, for this in this session. As you have witnessed, there was a bombardment of questions. The enthusiasm of the chairperson was more than that of you people, right? So we couldn't discuss the entire case in total. That was a bird's eye view, an eye opener. You would face your exams. What sort of questions will be asked in your exams? I request all students to be interactive, maintain silence, switch off your cell phones, and take the best out of this academic event. A lot of pain has been put into this organizing this event, and request you all to be interactive and take an active part in this CME. Thank you so much.
A very good morning to everyone present here. Shall we take a quick break from surgery? Here I am to share a few points about organ transplantation. This topic comes first because our institution has achieved a milestone in organ transplantation. The first ever organ donation happened in the year 1954 was of a kidney transplant between identical twins. One person can save up to 8 lives and improve the lives of up to 75 others through organ, eye and tissue donation. More than 1 million tissue transplants are performed each year, and the surgical need for tissue has been steadily rising. Corneal transplants, meanwhile, restore the sight of 50,000 people each year. India's donation rate is low. Only up to 0.01% of the people are donating their organs after death. The most uncommon transplant occurred in 2011 in Turkey, where a transplantation of a womb of a deceased woman into a 21-year-old woman who was born without a uterus. A medical procedure that transfers healthy bacteria from a donor's stool to a patient's colon to treat conditions like recurrent difficile colitis, irritable bowel syndrome, Crohn's disease, constipation, ulcerative colitis is termed as fecal microbiota transplantation, which is in living donors can donate more than kidneys. They can donate a portion of their liver, lungs, intestine, pancreas, uterus, blood, and bone marrow. Thank you.
Moving on to the next session, it is a great honor to invite respected Dr. Nagalakshmi Ma'am, Associate Professor, Department of General Surgery, Tirunelveli Medical College for the first session of the day on the topic salivary gland disorders. And the chairpersons for this session will be Professor Dr. P. Rajavel Murugan Sir, Professor and Head of Department of General Medicine, Government Thoothukudi Medical College, and Professor Dr. Selva Shekaran Sir, Professor and Head of Department of Medical Gastroenterology, Government Thoothukudi Medical College. We invite the speakers and the chairpersons onto the desk. Now I request the chairpersons to introduce the speaker.
Very good morning to all. For a person to be proud and happy, two things should happen. The first thing is the person's offspring should achieve something. The second one is the person's friend should achieve something. So I am very proud and happy to perceive the growth of my friend, Dr. Rakesh, as a HOD surgery, who along with the Nirmal sir is taking the Department of General Surgery to so many heights. So I wish you all the best and I am very happy. And to introduce a speaker, Madam Dr. Nagalakshmi, who is here going to deliver a talk on salivary glands. She has completed MBBS in Tanjore Medical College and MS in Tirunelveli Medical College. I will not reveal the year of completion because it will tell her age, so I won't reveal. Then she moved on to Tirunelveli Medical College as a senior resident, then assistant professor, associate professor in Tirunelveli Medical College, and then she moved to Kanyakumari, and then she came back to Thoothukudi. She was here for 1 year. Then she again went to Tirunelveli Medical College. She has published so many journals, so many articles in so many journals. So rather than this introduction of scholarly performance, so one thing needs the introduction. To introduce a human being, the character is important. So when you see you have to confront any enemy, so you have to buffer and you have to react. So two exertions are there. One is to retaliate. Another one is just to smile and laugh, right? So everything will be buffered. So the madam is a very good example of smile and laugher. She'll go on laughing and smiling at everybody, even at her enemies, even at her husband when the fight is happening. So that will dissolve and solve anything. So I think the introduction will be enough for madam. So we'll move on to the subject by the speaker. Over to you, madam.
Thank you, sir. சார் எல்லாரையும் பார்த்து சிரிச்சிடலாம், ஹஸ்பண்ட் பார்த்து சிரிக்கிறப்ப பயமாக இருக்குது சார். நீங்கள் அதை கரெக்டாக சொல்லிட்டீங்க. ஓகே, குட் மார்னிங். Okay, so today's objective is I am going to talk about general, all about salivary introduction, anatomy, disorders of the gland, surgical, clinical approach, and surgical aspect. So introduction, as you all know, salivary glands are four glands, major glands in addition to the minor glands, two parotid and two submandibular, sublingual and multiple minor salivary glands. So anatomy, I'm not going to explain. So important structures which run through the parotid gland are branch of the facial nerve, terminal branch of the external carotid artery that divides into maxillary and superficial temporal artery, retromandibular vein, and the intraparotid lymph nodes. So this is the anatomical picture. So this is the retromandibular vein which is formed by the junction of, by the union of superficial temporal vein and the maxillary vein that joins to form that, and that divides into posterior and anterior branch. Posterior branch joins with the posterior auricular vein, forms the external jugular, and the anterior joins with a common facial vein, facial vein forms a common facial vein, finally ends in internal jugular vein. And parotid duct is a Senson's duct, which is 5 centimeters in length and is opposite to the upper second molar tooth. So all are very, very, very small points, but everything is important. When a parotid case is kept for you, even a small question, if you answer, it will gain confidence in you, and also the number of questions asked and the answers will be increasing in your side. So it's very important. So submandibular gland is a paired gland and that lie below the mandible on either side. It has two lobes, superficial and deep. Watton's duct which drains into the anterior, this is the floor of the mouth. And anatomically the relationship is lingual nerve, hypoglossal nerve, anterior facial vein, facial artery, marginal mandibular branch of facial nerve. So this is the anatomy. And sublingual gland is lie on the superior surface of the mylohyoid muscle, separated from the oral cavity by a thin layer of mucosa. The ducts are the excretory ducts of Rivinus. The largest duct of the sublingual gland is Bartholin, and that joins with the Watton's duct. I will show you the picture. So here, these are multiple ducts, and everything, all these drain, and the biggest one joins with the Watton's duct, and that forms the that drains into the same side. Usually it joins and drains into the same side along with the submandibular duct. So minor salivary glands, about 800 lie under the mucosa. They are distributed in the mucosa of the lip, cheek, palate, floor of the mouth and retromandibular area. Also appear in oropharynx, larynx and trachea. So ectopic salivary gland tissue is the most common ectopic tissue, that is called Safney's tissue, and usually it can present as a pain or something. It's discovered by routine X-ray, and the treatment usually is not needed. Unless it has some inflammation and painful condition, it's not needed. It has to be differentiated from some dental problem mostly, and it can be detected by X-rays. An inflammatory disease of the submandibular gland, it can be acute, chronic and acute on chronic sialidosis. Acute infection can be both viral or bacterial. Viral, as you all know, mumps, usually it is bilateral. Other viral infections are extremely rare. And bacterial is the most common one. Usually the treatment antibiotics, and if the disease is not subsiding with the antibiotic, as you all know, parotid gland is under the cover of a fascia, deep cervical fascia. So usually fluctuation cannot be elicited in case of when the parotid goes for infection and pus collection, parotitis, abscess if it is there, and fluctuation cannot be elicited, but treatment is incision and drainage. So trauma and obstruction, most common cause is silolithiasis, and usually it is 80% happens in submandibular gland, and usually it is presenting as painful swelling in the submandibular area. And clinical findings is tender and be draining when the mouth is open. So inside the floor of the mouth we can see the duct opening inside the, on either side of the frenulum, and you can see the pus draining, and investigation is X-ray and treatment is surgical. So it can be the tumors are very rare in this glands, and usually 50% benign, and if it is clinical present, everything I will discuss in later slides. This is the parotid swelling. So this picture I have made, this is because it's a characteristic feature. This is lifting the ear lobule, see in front, below and behind the ear lobule. So most of the time the differential diagnosis is left upper second level of cervical lymph nodes. Usually in that condition the lifting of the earlobe will not be there. And another one important differential diagnosis is Watton's tumor of the parotid, where the tumor will be in the lower pole. So I will show you the pictures. So there are developmental disorders, they are extremely rare, agenesis and duct atresia and congenital formation. So this is an inflammatory condition, and I'm going to skip certain slides to emphasize on certain important aspects. So, Silosis is a diffuse enlargement of the gland due to fatty infiltration. It's caused by metabolic causes, presents as bilateral, diffuse, non-inflammatory, non-neoplastic enlargement of salivary gland, and it's asymptomatic. Most of the time we would have seen many people, even chronic alcoholics will be having bilateral enlargement of the parotid gland. So underlying cause can be treated, but usually it will be asymptomatic. And other disorders, granulomatous adenitis. So it's most commonly due to mycobacterial infections, sarcoidosis, castrate-resistant, and multiple causes are there. And tumor-like disorders, these are group of disorders. They are hard to diagnose, and there are any other, it's not under any other group of disease. Usually it can be siloadenosis, adenomatous hyperplasia, and multifocal adenomorphic adenomatosis. So there are certain degenerative disorders, and I have mentioned Sjogren's, benign lymphoepithelial lesions, xerostomia, and siluria. And coming to Sjogren's disease, is an autoimmune condition causing progressive destruction of the salivary glands, and it includes the lacrimal glands also. Presentation is xerostomia, this dryness of the mouth, oral cavity, and keratoconjunctivitis. They can also present with the pain and ascending infection. Females are most affected. Parotitis is most common. So these are primary, secondary, and other conditions. And characteristic feature is progressive lymphocytic infiltration, acinar cell destruction, and proliferation of the duct epithelium. So diagnosis by history, and treatment can be symptomatic on artificial tears and salivary substitutes or water. Fluoride to avoid dental caries can lead on to B-cell lymphoma. So xerostomia is nothing but dryness. So causes is maybe due to chronic anxiety and depression, dehydration, and anticholinergic Sjogren syndrome, and radiotherapy of the neck and head. All these conditions can be treated symptomatically. Siluria is opposite to the xerostomia. Here this is children, there may mentally ill patient and cerebral palsy patient, you would have seen drooling. Management is usually surgical. Here the bilateral submandibular gland duct reposition can be done, and sometimes gland excision can also be needed. And ectasis. Ectasia, you all know, it's dilatation. Here is a dissection of the parenchyma with the aseptic dilatation of the salivary ductules. Can be smooth, soft, and flexural, non-translumating swelling, and grape or cluster-like dilatation and silogram will be seen. Conservatively it is treated. So this is ectasis, showing the dilated ducts. So how to approach patient clinically? So before going for clinical examination, history is very important, then clinical examination, and then investigations. So history, so what is the common history? How is the swelling started? How it has increased in size over a small duration of the swelling? Is there sudden increase in size like that? Trismus, is it present or not? If it is present, usually trismus in parotid is due to infiltration of the underlying muscle. So if it is present, you have to, including the oral examination, parotid can also cause trismus. That is the point you should know. Pain, whenever there is acute or chronic inflammation, there can be pain. So what is the difference, the variation with the meals means, usually whenever there is obstruction, normal secretion of the duct cannot be maintained, and there, if it is due to infiltration of it also, there can be variation with the secretion from the gland can be varied with the meals. Is it bilateral or unilateral? Usually bilateral means bilateral autoimmune disease or any other conditions can be thought of, and dryness, dry eyes, all these already I explained. So clinical examination, inspection, so gland asymmetry, gland face and has to be examined, diffuse or focal enlargement, erythema, and maybe due to local inflammatory condition, and trismus as I told you, and medial displacement of the structures intraorally. So what do you mean by intraoral displacement? Usually when the deeper lobe is involved, the tonsils can be pushed medially, that can be examined intraorally. So cranial nerve testing, facial and hypoglossal nerve. So palpation, you should look for cervical lymphadenopathy, bimanual palpation of the floor of the mouth in a posterior to anterior direction. See, I have mentioned bimanual palpation for parotid, whereas in case of submandibular gland, it is bidigital palpation. So here you have to do bimanual examination. Partially the mouth should be closed and relaxed to examine the intraoral portion of the deeper portion of deep part of the gland. So you have to examine the duct and its whether there is any discharge from the duct also has to be examined. And radionuclide study is useful preoperatively to determine if the gland is functional. So coming to the submandibular gland, so common condition disease in submandibular gland is salivary calculi. It's common in submandibular glands. 80% radiopaque, 80% it is in submandibular. Can be single. Parotid stones only very less common is 20%. Sublingual stones are less than 1%. So you all know probable causes for submandibular gland calculi. So viscous nature of the secretion and calcium content is high, non-dependent drainage, and the hooking of the duct by the lingual nerve. All these are the common causes of submandibular calculi. So clinical features: painful swelling over the submandibular gland, enlarged tender submandibular gland and by manual palpation, and mealtime syndrome. So swelling appears after eating and resolving within 1 to 2 hours of eating. So how to investigate? Usually plain occlusal film can be taken, CT scan can be done, ultrasonogram, xylography, radionuclide study, and diagnostic cycloadenoscopy. So all these are not common. Usually we are doing ultrasonogram, and the CT can also confirm the stones. So this is the X-ray eliciting the picture of the stone within the Wharton's duct. So intraglandular, radiolucent or small stones can be usually missed. Other stones, whenever it is in the duct, it can be easily seen. And investigation, intraoral X-ray also. This is X-ray. So xylography can be done. This is a picture showing the stone in the duct. Xylography. Usually nowadays it's not done, but when the patient is symptomatic, we have to do next level of investigation to confirm the diagnosis. So this is a scopy, cycloadenoscopy. So you can pass through the duct and you can visualize, and if the stone is present, you can remove. There are so many techniques how to remove, I will tell you. So CT scan, large stones or small CT slices can be done, large stones can be seen. Also it can be used in inflammatory conditions. Ultrasonogram, usually it is operator dependent. So management, when it is less than 4 mm stone, Darmia basketing can be done. This is a picture showing the Darmia basketing through the duct. The stone can be removed. Or the greater stones, extracorporeal or intracorporeal shock wave therapy also can be given. Usually surgical removal is easy, and you can open the oral cavity, the floor of the mouth, the duct can be palpated, and you can do stone excision. And the commonly the cause will be the submandibular gland disease. So associated, we have to go for submandibular gland excision also. So this is the technique of removing intraorally the stone. And this is a picture showing the stone, and you are making the incision over the duct, and the stone is extracted. Cycloadenitis is inflammation, it's viral, commonly paramyxovirus, can be bacterial also. Acute cycloadenitis, usually there will be pain and there will be swelling of the submandibular gland, which is usually bimanually palpated, and tenderness over the submandibular gland region, can be dysphagia and trismus, and double chin appearance will be there. Pus will be seen extruding and oozing through the duct. So chronic cycloadenitis due to obstruction. And next is the sublingual salivary glands. Usually the common disease in sublingual salivary gland is ranula. Ranula, you all know, it's otherwise known as, meaning is frog-like. So it can be plunging ranula. Sublingual salivary gland tumors also, so I will mention. So ranula is a damage to sublingual gland. You all know it is draining along with the submandibular duct. So mucus extravasation cyst is a type of mucus extravasation cyst. Cystic translucent swelling will be seen in the floor of the mouth. It's a frog's belly appearance. Only it's called ranula. Can be resolved. It will be resolving spontaneously. Sometimes marsupialization or extraction of the gland. So these are the conditions, and this is a ranula. It's a fluctuant swelling, and it is brilliantly transluminant, and it is seen intraorally. This is the marsupialization means you have to do after opening the swelling. You have to open, and the edges are sutured. This is called marsupialization. And plunging ranula, it's a mucus retention cyst. So penetrates through the mylohyoid muscle. Dumbbell-shaped painless swelling in the neck. Can be soft, stick. Cervical approach is contraindicated, usually done orally. Aspiration of the saliva and removal of the sublingual gland is done. So this is a type of plunging ranula. You can see inside the oral cavity, and it's in the neck also. So minor salivary glands, there can be cyst and tumors from the minor salivary gland. So cyst I mentioned, and this is a commonly we see cyst in the lips. Usually patient will be coming, and it can be retention cyst or extravasation cyst. Coming to the salivary gland neoplasms. etiology is usually radiation exposure, smoking and viral infection, environmental factors and industrial exposure such as rubber manufacturing, nickel components and hair dyes. So this is the classification, and highlighting is malignant epithelial tumors and benign epithelial tumors. In benign, you all know pleomorphic adenoma is the most common one. All the other things, Warthin tumor also comes under oncocytoma. These are the other types of malignant. Only I am going to highlight on the common things. So this is the TNM classification. In the tumor, T staging is usually T1 is tumor of less than up to 2 centimeters. T2 is 2 to 4 centimeters. T3 is more than 4 centimeters. Coming to the notes, it's almost similar to the oral cavity malignancy. Submandibular salivary gland neoplasms, and 15% of the salivary tumors constituted by the submandibular gland. It's 50% benign and benign 95% is pleomorphic adenoma. 50% it's malignant. So pleomorphic adenoma, so incidence is 10% generally, and is a smooth, firm, bidigitally palpable, painless lump without any adjacent structure invasion. Usually it's benign, and its investigation is FNAC and CT. Treatment is removal of both superficial and deep lobes. See, in submandibular gland, whenever there is pleomorphic adenoma, you will be removing both superficial and deep lobes. So in malignant tumors, it's 50% malignant. Adenoid cystic carcinoma is the second most common malignancy. But in case of submandibular gland, is the most common tumor. Common in female, 5th to 6th decade, high affinity for perineural spread and blood spread to lungs and liver and bones. Microscopy, it's cribriform, tubular or solid tissue will be seen. So investigation, FNAC, and FNAC cell can also be done, CT scan and MRI if there is perineural invasion. Other tumors of the submandibular gland, mucoepidermoid carcinoma, acinic cell tumor, adenocarcinoma of the salivary gland, squamous cell carcinoma of the salivary gland, malignant mixed tumors. So coming to the sublingual glands, the tumors is extremely rare. Whenever tumor comes, it's usually mostly 90% it is malignant, present as rubbery swelling in the floor of the mouth, can be associated with the pain if it is high grade. Investigation is FNAC, punch biopsy or CT scan can be done. It's treated with en-bloc excision of the tumor along with the gland with the adjacent periosteum and neck dissection may be needed. Intraoral defect can be replaced by flaps. So minor salivary gland tumors, usually they are highly malignant, 10% salivary gland tumors and repetition only. So in malignant tumors less than 1 centimeter, we do excision with 1 centimeter clearance directly. If it is more than 1 centimeter, biopsy followed by wide local excision with the nodal dissection, and palate can be removed if there is infiltration and followed by reconstruction. This is a minor salivary gland tumor within the floor of the mouth. So coming to the neoplasms of the parotid gland, this is the classification. So it can be differentiated as epithelial and non-epithelial, can be classified as epithelial and non-epithelial tumors, and adenoma is the most common and occurs after 4th decade, men more common than women. Most salivary gland tumors are benign. Majority occur in the major salivary gland, that's parotid. Minor salivary gland tumors are, see, I am repeatedly insisting just for you to understand, not for so most common benign lesion is pleomorphic adenoma. Most common malignant lesion is the mucoepidermoid carcinoma. And risk factors, radiation, smoking is most commonly associated for in Warthin's tumor. Can be viral due to viral infection, industrial exposure, rubber manufacturing. And benign tumors is pleomorphic adenoma and Warthin's tumor. So most common benign tumor. If the tumor or swelling whichever is arising from the accessory lobe, it can be seen inside the oral cavity by examination of the oral cavity. It arises can be from the deep lobe, it's present as parapharyngeal mass. It can present with the diffuse difficulty in swallowing, and there will be snoring. So pleomorphic adenoma is the most common one, 3rd or 6th decade, 3rd to 6th decade, and female most common. Gland is parotid is most common. And facial palsy, whenever it occurs, it's probably due to malignant transformation. So treatment is excision of the tumor with the cuff of surrounding normal tissue to exclude the pseudopores from the tumor capsule. Enucleation is a capsule. So enucleation and excision, enucleation, capsular breach and tumor spillage can occur leading to local recurrence. And usually we do complete superficial parotidectomy in case of pleomorphic adenoma. So I will tell you some other points also. So this is a pathology. And Warthin's tumor is adenolymphoma or cystadenoma lymphomatosum. 6th decade, men more common. Risk factors: cigarette smoking and radiation. Gland is a parotid gland, usually from the inferior pole. And in this particular problem alone, the lifting of the ear lobule or the typical presentation of the parotid swelling cannot be seen. So painless low growing swelling, Warthin's tumor and oncocytoma, almost they will incorporate technetium 99, and this will appear as hard spots and radionuclide scan. Because in this oncocytoma and Warthin's tumor, there will be increased number of oncocytes. So malignant transformation is here is rare. So this is a pathology showing the oncocytes. Malignant tumors can be mucoepidermoid carcinoma, adenoid cystic carcinoma, acinic cell carcinoma, and salivary duct carcinoma. So mucoepidermoid carcinoma can be mucinous, tumor cells is mucinous, intermediate, and squamous tumor cells. So second decade following radiation exposure, gland parotid is most commonly involved. Soft form, painless mass. Can be classified based on the histology. Can be low grade, intermediate grade, and high grade. High grade lesions are locally aggressive with the bone, skin involvement, and nodal metastasis. So treatment: complete surgical excision with the void margin. Adjuvant radiotherapy may be needed for intermediate and high grade lesions. So adenoid cystic carcinoma, it constitutes about 10% of all salivary neoplasms. Tumor cells can be epithelial and myoepithelial cells. Perineural invasion is seen, it's very important. Fifth to sixth decade of life, it is female more common. The gland is a major and 2/3 cases minor salivary gland can be involved. Histopathology: tubular, cribriform, and solid in the order from best to worst prognosis. Clinical features: slow growing mass with the presence of numbness, paresthesia, or pain that is due to perineural invasion. And facial nerve palsy will occur in case of malignancy. Distant metastasis within 5 years of diagnosis. This is a pathology showing. Clinical features: usually there will be presence of numbness, paresthesia, pain due to perineural invasion. Facial nerve palsy will be there. And treatment: so radical surgical excision with or without adjuvant radiotherapy. Metastatic disease can occur, and proton ion and carbon ion therapy can be useful. And IHC immunohistochemistry shows ductal cells, the C-kit presentation, and myoepithelial cells also will be present. So acinic cell carcinoma, so tumor cells is acinic cells, 5th decade, most common in female. So gland involved is the parotid, slow growing, painless, mobile, salivary tumor, and the treatment is complete excision of the tumor. Recurrence can occur. And this is the immunohistochemistry. So carcinoma, X pleomorphic adenoma, this is a tumor which is arising from primarily or from recurrent pleomorphic adenoma. Tumor cells can be epithelial or myoepithelial cells with infiltration into the glandular and extraglandular tissue. 6th decade, woman most commonly affected. Gland is parotid gland. Rapidly growing mass, long-standing swelling going for rapid increase in size with the pain and facial palsy indicates malignancy arising from pleomorphic adenoma. Treatment is radical surgical excision without radiotherapy. Histopathology shows variable proportions of both pleomorphic adenoma and high-grade adenocarcinoma. It can be non-invasive, intracapsular, confined within the pleomorphic adenoma, or minimally invasive, such as a breach in the pleomorphic adenoma capsule, or can be widely invasive, invasion into the adjacent salivary gland and soft tissues. Salivary duct carcinoma is a ductal carcinoma, is a type of adenocarcinoma, can arise de novo or as a malignant component of carcinoma, ex pleomorphic adenoma, and resembles high-grade this is highlighted because this resembles high-grade mammary duct carcinoma because it's arising from the duct of the salivary gland. So less common but arising from the parotid gland. 6th or 7th decade, elderly men, aggressive, rapidly growing mass with the facial palsy, pain, and cervical lymphadenopathy can occur. So treatment: complete excision with the void margin. Total parodectomy along with neck node dissection is needed. Microscopically, it resembles high-grade invasive ductal breast carcinoma, shows androgen receptor and HER2 receptor positivity because it is resembling mammary tumor, mammary gland malignancy. So there will be androgen receptor and HER2 receptor positivity, making the possibility of target therapy in recurrent metastatic cases. Vascular and perineural invasion is also common. So investigation: ultrasonography can be done, and CT, MRI to know the extent of the tumor and erosion of the surrounding osseous structures and extraglandular involvement and metastatic nodes. MRI also can be done to differentiate benign and malignant neoplasms. PET scan for distant metastasis. So FNAC cytology is differentiate between inflammation versus neoplasm. FNAC is the important investigation to confirm the malignancy. gland system for reporting salivary gland cytopathology. So core needle biopsy can be done. It's usual to find out the immunohistochemistry in lymphoma and high-grade malignancies. Surgery with the microscopic margin of at least 0.5 centimeter, extent of resection, size depending upon the size, stage and grade of differentiation. Facial nerve should be preserved. If it is malignancy, most of the time can be sacrificed with the prior consent. And neck dissection, T3 and T4 lesions and high-grade tumors. Comprehensive neck dissection can be done in node-positive diseases. Adjacent radiotherapy for stage 3 and 4 diseases and perineural invasion, lymphovascular invasion. So, certain slides regarding operative surgery and extracapsular dissection, superficial parotidectomy, total conservative parotidectomy and radical. These are the types of parotid tumor excision. Superficial parotidectomy, if the tumor lies in the superficial lobe, a superficial parotidectomy should be performed with preserving the facial nerve. It's the most commonest procedure we are doing. And planning of the surgery depending upon the tumor histology and all. And the fatty faciovenous plane is preserved, and that is to identify the facial nerve and location of the according to the location of the tumor. And this is the picture showing anesthesia, usually general anesthesia. Incision is a modified Blair incision or Lacey's incision. So you have to elevate the flap within the subplatysmal level. Parotid gland has to be mobilized. Coming to the very important point in parotid, it's a facial nerve trunk identification. So first is the inferior portion of the cartilaginous canal called the Conley's pointer. The facial nerve lies 1 centimeter deep and inferior to this tip. And second is the upper border of the posterior belly of the digastric muscle. And tympanomastoid sutures can also be made as an identification point for the facial nerve trunk. Facial nerve usually it is superior to it, and the nerve stimulator can also be used in case of identification of the nerve. And so total conservative parotidectomy is a tumor involving the superficial and deep lobes across the Patty's plane. Complete removal of the suprafacial and subfacial parotid gland, usually with the preservation of the facial nerve, has to be done. And radical parotidectomy in malignant tumors with the extraparenchymal spread and facial nerve invasion. Removal of all the parotid gland, the entire parotid gland, and the elective dissection of the involved facial nerve branches as well as the structures involved. And usually most commonly masseter muscle. When it is involved, there will be trismus. And repair of the facial nerve can be done when the segment of the nerve is being removed. And reconstruction can be used either with the greater auricular nerve or sural nerve. And partial superficial, that is limited parotidectomy. Dissection is limited to only to a part of the gland. Facial nerve dissected and distally just beyond the pes anserinus. Relationship of the tumor and the underlying facial nerve should be visualized and it should be preserved. Expected complication is Frey's syndrome. And extracapsular dissection for benign parotid tumors to avoid facial nerve dissection with the small incision, the subcutaneous flap is elevated above the platysma. At the site of the tumor, fascia is incised and the tumor is dissected in extracapsular plane, visualizing the facial nerve branches. After excision, the fascia is sutured, and this is called extracapsular dissection. The complication, these are the complications. Frey's syndrome is a gustatory sweating, cross innervation of the dermal sweat glands by regenerating post-ganglionic parasympathetic nerve fibers of the auricular templar nerve. Common presentation, the sweating and flushing of the preauricular region whenever the patient is taking food. Starch or iodine can be used. And this to avoid that, we can use thick flap with subcutaneous fat, and temporalized fascia can be used, and extracapsular dissection has to be done. Careful closure of the superficial musculoaponeurotic system has to be done. Treatment is this. So submandibular gland dissection excision, it can be usually done in the transcutaneous approach, usually through the neck, and these are the anatomical relations. It can be either intracapsular dissection or extracapsular dissection along with the supraomohyoid neck dissection. So indication you all know. So anesthesia, general anesthesia, very important clinical point here is whenever you make the incision, should be horizontal skin crease incision 2 cm below the mandible to avoid injury to the marginal mandibular nerve, that has to be preserved. So anterofacial vein is ligated and superficial lobe of the gland is exposed, and deep fascia of the neck covering the gland is visible, and dissection has to be done and both lobes has to be removed. So complications can be injury to the marginal mandibular nerve, hypoglossal nerve and mylohyoid nerve. In the careful dissection, all these can be avoided. Thank you.
Thank you, ma'am, for the thought-provoking session.
almost covered each and every point of the salivary gland, both malignant as well as benign conditions. It is very useful to both the final year students as well as the young postgraduates. She almost covered every points, starting from the infection of the salivary gland and various benign condition, benign malignant tumors, and various surgical procedures adapted for the malignant salivary gland tumors. It is very useful to me and as well as the audience. Very congratulate, madam. Thank you.
Thank you, madam, for your wonderful session. It started with the anatomy and ended up in surgery. It was informative and elaborative session. See, the saliva is necessary for two important things in our life. So the number one, when you are hungry and you are seeing appetite, it will signals the incoming of appetite. The number two, the most important thing in our life, when you are attracted to opposite sex, right, your jullu will start. That is a drooling of saliva. That is also very important. So the saliva signals diet and infatuation, sign of infatuation. So you should know the disturbance in the salivation, and you should know the disturbance of salivary glands. Both these are very important. And you know, the most of the cases of salivary problems or any swelling will land up in physician. That is why I am here. You may wonder why what the physician is doing in a surgery CME. So most of the cases will land up in physician. See, even the inguinal hernia. I had one case of inguinal hernia yesterday. The patient came to me, sir, எப்படியாவது சரி பண்ணிருங்க sir. So what can I do? So the patient told, sir, I took tablet for 3 months, sir. The patient has gone to one quack. The quack has written some tablets. The quack has told that he will be all right with this, taking this tablet now. So I said, what is the tablet now? The tablet is Zingovit. So can Zingovit cure the inguinal hernia? Then I told them, so இதெல்லாம் சரியாகாது சார், எப்படியாவது பார்த்து பண்ணுங்க சார். ஏமா பார்க்காம கூட பண்ண முடியாதுமா, inguinal hernia surgery I cannot do it. So most of the salivary gland tumors may also come to physician. So this differentiation between the physician and surgeon is, as our Tala Ajit told, is a மெல்லிய கோடு, right? There's a difference between friendship and love. So when the physician becomes surgeon, when the surgeon becomes physician. So you should know, as an undergraduate, you should know when you should refer the case to surgery, right? So in a case of salivary tumor, right, that is swelling. So when the case is presented with extremes of symptom, extreme pain or no pain at all, in these two cases, you should refer to surgeon. Or if you suspect infection, you are giving antibiotics, the patient is not responding to your antibiotic, you can refer to surgeon. Or this swelling is rapidly growing, right? Or the consistency is somewhat doubtful, suspicious. It was some hard or firm like that, or rubbery in consistency. You can refer the case to surgery, right? And so to sum up, so the salivary gland is affected by two pathologies. One is infection, another one is a tumor. So let me check the understanding of the audience. Which is the most common benign tumor of salivary glands? Pleomorphic adenoma. Madam, you can be happy. Most common benign tumor in smokers? What things? Megan, you can still more happy, madam. So your session is successful. So thank you, madam, for your wonderful session. If audience can raise any question to the speaker. No question. Okay, thank you. Thank you for the opportunity. Thank you, Team Surgery.
Thank you, ma'am, for the thought-provoking session. With great esteem, I request the chairpersons to felicitate our honorable speaker, Dr. Nagalakshmi, ma'am. Thank you, sirs. Now I kindly request Dr. Dalton, sir, Assistant Professor, Department of General Surgery, to honor the chairpersons. you, sir. Once again, we express our heartfelt gratitude to the speaker and the chairpersons.
Before the next session, let's do a quick fact check, diving through some facts related to our very own Thoothukudi. The first is Thoothukudi as Pearl City. Many of us might know that Tooty is called Pearl City, attributed to its rich culture of pearl hunting. Pearl fishing was considered a coveted and tough fought sport back in the ages. Pearls themselves signify purity, wisdom, and resilience, just some qualities that you can see any person from Tooty easily possesses. The second is the journey of macaroons. In simple words, it is an European delicacy in ice. It was first brought to India by the Italian and Portuguese traders. It was substituted to suit the Indian taste buds with cashew flour and coconut. Next on our radar is the Kalugumalai Jain beds. It is an unfinished piece of rock cut architecture. It has 96 Jain inscriptions, making it the largest of its kind in the south of India. It also has a wing of temples, each so stunningly constructed in its vicinity. One you must all surely have in your bucket list. Last fact for now is about the coral reefs. Thoothukudi Islands contribute to a special little part in the Gulf of Mannar Islands. Lately, a proposal has been made to restore about 1 acre worth of islands in Tooty in an attempt to rejuvenate the coral reef. That's it for now. Let's move on to the next session.
Moving on to the next session on the topic peripheral vascular disease, the chairpersons are Dr. S. Saravanan Sir, Associate Professor, Department of General Medicine, Government Thoothukudi Medical College, and Dr. C. Saravanan Sir, Assistant Professor, Department of Radiology, Government Thoothukudi Medical College. With great admiration, I invite the speaker of the session, Dr. Rajesh Sir, Professor and Head of Department of Vascular Surgery, Tirunelveli Medical College. I kindly request the chairpersons to introduce the speaker.
Good morning. Good morning, everyone. First, hearty congratulations to the surgical team headed by Rakesh sir. Now coming to the speaker. Our speaker today is Dr. Rajesh sir. He is a specialist in general surgery and vascular surgery. His medical school is from Stanley Medical College MBBS, and general surgery also is from Stanley. He has done his MCH from MMC and has received gold medal for best outgoing student in vascular surgery. His special trainings are from Sri Chitra Institute, Trivandrum, Jains Institute, Bangalore, and Nizam's Institute, Hyderabad. He has done many national presentations like problems in revascularization
is always operator dependent, so always better to go with a imaging like a CT angiogram. The main advantage is it gives a clear picture, but if the patient's urea creatinine is very high, we can't subject them for CT peripheral angiogram. You can subject them for MR angiogram with a non-contrast MR angiograms are nowadays available, so you can subject them for color Doppler is always peripheral angiogram, operator dependent. So previously they are using imaging gadolinium contrast angiogram that can give rise to very high nephrogenic fibrosis. We can't subject them for nowadays we are using peripheral angiogram non-contrast technique you can subject them delineate the disease. MR angiogram. So with a non-contrast in a diabetic patient MR angiograms are nowadays available, so you can if the patient has a mildly elevated creatinine you can subject them for so previously they are using or a DSA gadolinium direct puncture of the femoral artery and rise to nephrogenic fibrosis. And nowadays the main advantage is you can limit the non-contrast technique as well as you can do a selective angiogram. So and in a diabetic hydration and all things are necessary. If the patient has a mildly elevated subtraction angiogram, you can subject them. And if the patient has got a conventional angiogram or a creatinine values, that is a direct puncture of the femoral artery and carbon dioxide angiogram. So this the main advantage is you can limit the contrast dose as well as you can do a selective angiogram. We can inject carbon dioxide and prior hydration. All things are necessary before in a negative shadow. Digital subtraction angiogram. Even do an intervention. If the patient has got a carbon dioxide angiogram, creatinine values, so we can subject them for carbon dioxide angiogram. Assessing the case, we can whether it may be so either instead of atherosclerosis medium or we can TAO carbon dioxide and get the age criteria. If it is less than 50, don't diagnose a TAO. We can even do an intervention with the carbon dioxide angiogram. That means gruel and sclerosis means hardening. After the vessels assessing the case, we can harden whether it may be either this process atherosclerosis or a TAO. Age of onset so will be more than age criteria. If it is factors like hypertension, diabetes, smoking, dyslipidemia, obesity, all contributes to it. Come from the Greek word it is a proximal disease. That means gruel and level of vessel means hardening. Large vessels are involved and calcifications are common in hardened atherosclerosis. During the you have to think about the age if the patient is especially the age of onset, you have to think about non-atherosclerotic causes like hypertension, diabetes, smoking, dyslipidemia, obesity, all contribute to aneurysm and mostly it is a proximal and level of vessel in large vessels are involved and calcifications are common in suspected for even a popliteal entrapment. So you have to think about the if the patient is especially with a non-smoker, you have to think about non-atherosclerotic causes like and TAO sometimes in a age patient it's a definition of TAO. It's a chronic inflammatory and thrombotic radiation non-atherosclerotic in a segment patient you have to suspected for even a popliteal entrapment primarily involved especially infrapopliteal and infrabrachial with a non-smoker medium size evaluate for this predominantly young male patient. TAO it's a definition of TAO. It's a chronic inflammatory etiology is a the vessel lumen is getting narrowed by the thickening of the media vasculopathy primarily involved in the infrapopliteal and infrabrachial. It is medium size and small size predominantly young male phenomena which happens. So that the results are also equally relatively bad. The main etiology is a the vessel lumen is main criteria to diagnose a thickening of the media that is intima as well as media. Here and the pathology is totally another one is a Olian criteria. So the age of onset will be less than 50 phenomena which happens. So that the results are also equally for relatively bad smoking. And mostly it is an infrabrachial. There are two main criteria to diagnose the upper limb involvement like that is a Shinoya's criteria. Absent radial pulses will be there and also another one is a Olian thrombophlebitis. So the age of onset will be and another criteria is a Olian criteria. Here the age of onset should no risk factors for 45 atherosclerosis and history of tobacco use and mostly it is an infrabrachial or infrapopliteal always exclude the upper limb involvement like autoimmune disease and absent radial pulse and also exclude the proximal source of emboli like a cardiac source or and another criteria is a Olian criteria. Here the age of onset should be less than 45 and should have a consistent and distal angiographic findings and exclude always exclude the diabetes and autoimmune disease and hypercoagulable status like and also exclude the proximal source of emboli like a cardiac source or Allen's test source from other checks the integrity of the proximal arterial tree should be included and angiographic findings should have a consistent there will be a corkscrew angiographic findings or a spider wire calcification will be absent in the spine, ulcers, migratory superficial trauma, acute phase, intermediate phase, and chronic phase. Checks the integrity of the palmar arch. And procedure in acute phase or an intermediate phase, there will be a corpus to collaterals or a spider wire. Chronic phase, if you try a revasculation, the main finding is a calcification will be absent in the. So having diagnosed whether they are TAO or an atherosclerosis, you should have a comprehensive treatment plan. So if you do a like a medical management and procedure in acute phase or an intermediate phase, it is medical management always in a TAO. You should advise the patient. If you try a revasculation, the chances of success are using all forms of workout. So having diagnosed whether they are consultation with a psychiatrist, you should have a comprehensive treatment plan. And these are like a medical management nicotine and receptor blockers, which can help to medical management always in addiction. TAO, nicotine replacement therapy like nicotine chewing gums are available, using all forms of to the patient. And you can have a consultation with a psychiatrist for the smoking cessation. Start the patient if they are on statins, nicotine receptor blockers, which can help to they have overcome the nicotine addiction. It has also got replacement therapy like nicotine chewing gums are available. Patient can be given to the patient claudication and pain as well as next you can also it helps in some patients in a critical limb ischemia. Statins like treat the atorvastatin or rosuvastatin, diabetes also they have got a pleiotropic effect. So it all these patients also gotten and will have a severe rest pain can help in. So the pain management forms a significant component in vascular practice. So you have to give also it helps in some patients in critical limb ischemia and sometimes and also give treat the hypertension. Even epidural anesthesia for pain should be taken under control. And spinal cord stimulation is also the option available. Will have a severe rest pain and medical management. So the pain management forms a significant component in vascular practice. So you have to give adequate NSAIDs, opiates, antidepressants can be tried, and sometimes give and previously epidural anesthesia for come across pentoxifylline and spinal cord stimulation is also the option available. So nowadays and medical management limitedly available nowadays. Now in claudication we can try with the prefer silostazole, which is more effective. It's a phosphodiesterase inhibitor and it's a vasodilator as well as previously we come across pentoxifylline. It's a hemorrhagical agent. Patient's ejection fraction is very low. It has can precipitate limitedly available nowadays. So always use with caution. Prefer silostazole, which is more effective. It's a calcium channel blockers can be tried. And it's a vasodilator as well as an claudication. You can go for a conservative management, not be used in like a supervised exercise training failure. Like 30 to 40 ejection fraction is very low session. It can precipitate 3 times in a week can be given. Always use with caution. Based on the imaging prostaglandins can be tried and calcium channel blockers can be tried. Imaging you can classify the disease. Claudication you can go for a conservative management like a supervised exercise training like 30 to 40 minutes per session for three times in a week can be given. If the lesion is very small or a small stenosis based on the imaging task A and if it is a longer stenosis imaging you can classify the if it is a longer much longer more than 10 centimeters it is just on previously we type D is task is a transatlantic total occlusion of a vessel statement. So if it is a small occlusion is very small or you can go for an endovascular. If it is a long occlusion and if it is a surgery. So that's a protocol we used to follow. If it is a longer, this is a newer concept, it's evidence-based revascularization and plan concept is that total occlusion of a vessel. Completion given if it is a small occlusion Wi-Fi criteria, we can go for an endovascular for a diabetic. If it is a long occlusion, you go for a surgery wound. So that's a protocol we used to follow. Foot infection and we can categorize newer concept. It's a evidence revascularization and nowadays this is a newer classification which has come up. It's a global limb anatomic staging system. This is a Wi-Fi criteria. Previously we used to follow this task and now it's a newer based on the wound ischemia as well as foot infection based on the we can categorize whether it's in the iotoiliac or in the femoral nowadays it's a newer so the concept is classification which has come up. It's a global limb anatomic staging system. It's a glass that comes under previously we used to follow this task and now it's a newer that goes under category classification that is available based on the occlusion whether it's in the iotoiliac or in the femoral popliteal. So the concept is almost the if the patient has got a critical limb ischemia or a rest pain, it's our duty to revascularize category 1. These are the available options like surgical options that can go for an endotomy or a bypass or an extra anatomical bypass. So in an endotomy we used to open the artery and remove the part of the patient has got a critical limb ischemia or a rest pain, it's our duty to revascularize the media behind. These are the available options like surgical options. You can go for an endarterectomy or a bypass. Close with either a vein patch or sometimes synthetic patch. So depends on the endarterectomy. We used to open the artery and remove the part of total common femoral as well as a part of the media. Disease is limited to the common femoral artery alone. And this you can go for a femoral endarterectomy. So it gives a very good result. Close with either like a vein patch or sometimes synthetic patch, or sometimes you can go for a this endarterectomy combined with a bypass procedures can be done. So it's a common femoral endarterectomy. If the occlusion is disease is limited to the common femoral artery alone, go for a this you can go for a femoral endarterectomy. Synthetic graft gives you have got two types of graft. That's a Dacron graft as well as a PTFE grafts are available. Endarterectomy combined with a bypass procedures can be done. Bifemoral bypass, or else if occlusion is so severe, called Y graft or a bifurcated graft, you can go for a resection and anastomosis with the synthetic graft. You have got two types of graft. That's a Dacron graft as well as a PTFE grafts are available for replacing the femoral segments. So iontofemoral bifemoral bypass is some bypass procedure. So called Y graft or a bifurcated graft. For the femoropopulated segment, you can use a vein as a conduit for doing an both the limbs to the because vein is to the either natural and resistant to the femoral segments. And even go up to the pedal vessels like distal if the posterior tibial can be approached. For the femoropopulated segment, you can use sometimes if the iliac or as a conduit and the patient ejection fraction is very low, you can go for an extra anatomical bypass resistant to infection is there. And right to left even go up to the pedal vessels like this is also another case posterior tibial can be approached by this. Ejection fraction was only 20 to 25% or badly diseased and the patient ejection fraction is very low. Aorta, you can go for an extra anatomical challenge and from this patient mortality will be right to left. So in order to avoid that, we can place a graft from axillary artery. This is also another case and which bypass graft ejection fraction was only 20 to 25%. You can to salvage graft. So always clamping the open surgery is have a challenging challenge and gives a gratifying result. More. So in order to avoid it also has a associated graft from axillary artery as well as the mortality and nowadays what we are femoral to advocating or mostly the patient preference is so more towards an endovascular. Always a open surgery is very much challenging and gives a gratifying result. In the femoral segment, it also has a go for a plain balloon angioplasty over here as well as a mortality. And nowadays, what we are advocating or mostly the patient preference is more towards an endovascular. So this is called kissing balloon like an angioplasty you can use. So approach is through both femorals. In the femoral segment, you can go for a plain balloon angioplasty over here, simultaneous fashion. And it is you can go approach iliac as well as these are the latest advances which has come called kissing balloon technique, diagnosis as well as intervention. Approach to IVUS is an intravascular ultrasound, cutting balloons, scoring balloons are dilated in a simultaneous fashion. Vascular lithotripsy, bioresorbable stents and atherectomy devices are there. These are the latest advances which have come across in the intravascular diagnosis as well as intervention. IVUS is an intravascular ultrasound and gives cutting balloons, scoring balloons, cryoplasty, burden, and calcium measurement, stent measurement, bioresorbable stents using an atherectomy devices are there. So it reduces the contrast as well as we can do time saving and limited complications are there. And gives the main limitation is availability and cost factor is there, and calcium measurement, stent measurement, everything can be done. Scoring balloons using an intravascular ultrasound disrupt the plots. So it reduces the contrast as well as time saving and limited complications are there, which is also available nowadays. Main limitation is availability and cost factor is there. It theoretical advantage of reducing the scoring myointimal hyperplasia. So following an intervention, they are prone to reocclude. So to prevent the reocclusion, when the vessel is newer techniques has come up, like this is a cutting balloon, which is also available nowadays, as well as drug-coated balloons like coronary artery stenting. We have got a paclitaxel and reducing the coated myointimal hyperplasia. Balloons are there. So following an intervention, they are prone to reocclude as well as reduces the to prevent the reocclusion. The newer techniques has come up like cryoplasty. Main issue with the superficial femoral artery stenting extending. The stents we have got a paclitaxel and king because of the balloons are there. Biomechanics so involved by improves the patency as well as reduces the occlusion rates. In order to overcome that, so we have got a main issue with the superficial femoral artery deploying it in the femoral and popliteal segment. King because of the even if you are flexing the knee involved by the chances of flexion of fracture and stent thrombosis are less with this newer in order to overcome that we have got a and flexible always like after an intervention even after putting a stent when it in the femoral and popliteal segment it is a nightmare to re-intervene after an if you are flexing the knee putting a stent the chances of stent fracture and stent thrombosis are less with this newer generation stents now in the way and this always especially the patient intervention after putting a stent when it gets we can opt for it is intravascular nightmare to re-intervene after an intervention waves are emitted and so in order to overcome that we have got a bioresorbable and medial calcium now in the way again have this especially the patients with a heavily calcified vessel posterior tibial artery we can opt for an intravascular lithotripsy and get a good revascularization. Waves are emitted and atherectomy devices like breaks the medial the intimal and medial calcium and you can have a so good results like this most of the time we come across if the vessels are there distally we can go for a revascularization and get a good revascularization. Sometimes if the angio is very bad like atherectomy devices like which there is no revascularization below and make a way occluded segment it is only a faint antitibial is seen. Most of the time the options we come across lumbar the vessels are there distally we can go for a pedicle free flap sometimes thrombolysis the angio is very bad prostaglandin infusion here stem cell therapy there is no revascularization there's a distal venous arterialization and pneumatic compression only therapy. A faint so sympathectomy previously used to go for a open sympathectomy available nowadays we can do a chemical lumbar sympathectomy metal minimally invasive thing that is available thrombolysis and prostaglandin infusion you can use thrombolysis and an option there's a distal venous arterialization and pneumatic compression therapy. So sympathectomy previously used to go for an open sympathectomy especially nowadays we can do a chemical cardiac failure that's a minimally invasive thing that is available especially with and you can use thrombolysis and an option therapy is one which is available you can use we can harvest the bone marrow and you have stem cells and centrifuge infusion with caution especially it can precipitate cardiac failure so it should not be used in a patient especially with poor check for the results later on and pneumatic compression or orthosis devices that is we can harvest the bone marrow claudication stem cells and for centrifuge with critical limb ischemia and this omental pedicle free flap area that is supposed to be anastomosed to the and check for the available artery and transfer and pneumatic compression or orthosis devices that is helpful in a claudication previously if the vessels are not available only the vein may be patent this omental pedicle as a last surgical resort sometimes we can go for a distally available artery and transfer anastomose tunnel in the vein graft over the distally available vein over here and previously if the vessels are not available it helps only the vein may be patent so and promote the angiogenesis surgical resort so sometimes we can use a synthetic or a vein graft for venous arterialization we can anastomose deep vein arterialization vein graft over the nowadays distally available vein over here even endovascular and so as a last resort if the limb is non-salvageable the patient is going for septicemia as a last resort you can go for a vein graft for a and distal artery how to decide the level of amputation like nowadays check for the pulse status if the femoral pulse is 12 you can go for a so as a last resort if the limb is non-salvageable the patient is going for septicemia as a last resort you can go for an amputation the stump will not decide the level of amputation like investigation before doing an amputation is if the femoral pulse is felt but it is not widely available mostly BK will heal but TCPO is pressure if it is below millimeter of mercury 70 millimeter of mercury to heal the stump will not heal so the ideal investigation before doing an amputation is a TCPO2 but it is not widely available whether it is a claudicant or critical limb ischemia TCPO2 is more than 50 so claudicant we can manage some conservatively the wound is identify and reduce to modify the risk factors and evaluate the extent of the local ischemia and comprehensive treatment plan like whether it is medical management or critical revascularization and so claudicant we can manage some conservatively identify and reduce to modify the Department of General Surgery and evaluate the extent of the local ischemia and comprehensive treatment plan like medical management, revascularization and psychological support are needed.
Thank you very much.
Thank you for the opportunity, the Department of General Surgery and
As a radiologist, do you
Thuthukudi
expect
Medical College
any
and Professors Rakesh and my dear friends
venous
and
ultrasonogram
seniors.
to be done in such patients?
Yes, definitely. Yes,
Thank you very
before
much.
revascularization,
on time.
especially in a femoral popliteal segment, mostly often we used to go for a venous graft. So, in order to check the patency of the vein as well as the deep, deep venous status, before revascularization, especially Doppler is indicated. Femoral popliteal segment.
Thank you, sir.
Mostly often we used to go
nicely
for a
elaborated the
venous
difference between
graft.
atherosclerotic
So,
narrowing
in order
and
to
TAU.
check the patency
Thank
of
you.
the
It will be very
vein
much
as well as the
helpful
deep,
for our
check the
PGs.
deep venous status, definitely venous Doppler is indicated.
So thank you very much, sir.
You have nicely elaborated the difference
except the
between
last 10
atherosclerotic
minutes,
narrowing and
the
TAU.
first 20
Thank
minutes
you. It
are
will be
allotted
very
for
much
medicine
helpful
department.
for our PGs.
He has emphasized the importance of medical management in a patient with peripheral vascular disease. So thank you very much, sir. It is the peripheral vascular disease and the coronary artery disease. 10 minutes. They are the very first 20 minutes are allotted for medicine department. He has emphasized the importance of medical management in a patient with PVD patients are having CAD. Actually, and 20 to 40% the peripheral vascular disease and the coronary artery disease, PVD. They are very once you diagnose PVD, just like our HODs of both have to screen for because coronary artery disease. Otherwise, to 60% die before going PVD for patients are having CAD. And worldwide, and 20 to 40% of the patients, the leading cause for these kind of cases. So once you diagnose PVD, preventable or at least we can postpone the coronary artery disease. Otherwise, the patient will die before going for critical ischemia. You have to screen and for worldwide the diabetes and the leading cause for posting any case of PVD. You have to it is actually preventable cardiac evaluation for all the patients, death of the patient. 60% so once you diagnose PVD means so on the table there is a chance of death. So and you have to keep the blood sugar in posting any case of PVD. You have to go for pre-operative cardiac evaluation adequate dose of statin, at least minimum 20 milligram of statin, or many times we need a 40 milligram of statin so that we can stabilize the vulnerable clot. Keep the blood sugar in the target level. We have to advise the patient put on for looking for any adequate dose of hair loss, at least minimum 20 milligram color change statin, or many times we need a 40 milligram in the medicine department so that we can stabilize the reflexes, peripheral reflexes of diabetic patients very periodically. Otherwise, the patient on the table for looking for any. Thank you, sir, hair loss, for emphasizing the importance of doing color change, ankle brachial index, and toe brachial index. In the medicine department, you have to check the many slides on reflexes, peripheral reflexes of diabetic importance of medicine periodically. Otherwise, you will miss the patient on the table many times. Any question? Thank you, sir, for emphasizing the importance of doing ankle brachial index and toe brachial index. Thank you very much. And putting many slides on medicine, emphasizing the importance of medicine.
I kindly request the chairpersons to felicitate our speaker, Professor
Any question
Dr.
from the
Rajesh.
audience? If no question, we can close the session. Thank you very much.
Thank you, sir, for the detailed session on peripheral vascular disease. With great respect, I kindly request the chairpersons to felicitate our speaker, Professor Dr. Rajesh, sir. Thank you, sirs. Now I kindly request Dr. Anish sir, Assistant Professor, Department of General Surgery, to honor our chairpersons, Dr. S. Saravanan sir and Dr. C. Saravanan sir. Thank you, sirs. Now I kindly request Dr. Anish sir, Assistant Professor, Department of General Surgery, to honor our chairpersons, Dr. S. Saravanan sir and Dr. C. Saravanan sir.
little brain teaser for you all in our little break. Let's play jumbled words. I expect active participation from you all. There are simple rules. We'll display the word. Whoever is able to catch the word first, kindly stand up and answer. If you answer correctly, you can get a treat from the comparing brain teaser for you all in our little break. Let's have a warm up jumbled words. I expect active participation from you all. There are simple rules. We'll display the word. Whoever is able to catch the word first, kindly stand up and answer. If you answer correctly, you can get a treat from the comparing desk. From the next question, I expect any one of you to stand up and answer so that you can collect your treat. That's right, it's hernia. From the next question, I expect any one of you to stand up and answer so that you can collect your treat. Any of you? Yeah, the right answer is Mirzi syndrome. You can come in front and collect your chocolate. Any of you? Shall we move on to the next word? Yeah, the right answer is Mirzi syndrome. You can come in front and collect your chocolate. Yes, the right answer is Aclasia cardia. Kindly come in front and get your chocolate. Shall we move on to the next word? The next one? Yes, the right answer is Aclasia cardia. Yeah, the right answer is Telvaxine. Please come in front and collect your chocolate. The next one? From the next time, kindly stand up and answer. Yeah, the right answer is Telvaxine. Please come in front and collect your chocolate. From the next time, kindly stand up and answer. Yeah, the right answer is claudication. Yeah, the right answer is claudication. The right answer is Marjolin ulcer. We move on to the next word. Anyone? The right answer is Marjolin stand up and answer? We move on to the next word. Anyone? We move on to the last word. Can anyone stand up and answer? Yeah, the right answer is Linitis plastica. Thank you. We hope you had a good break. We move on to the last word. Yeah, the right answer is Linitis plastica. Thank you. We hope you had a good break.
Good morning to everyone gathered here. We warmly welcome you all to the third session of today's Surgifest CME.
Before we begin, we would like to introduce ourselves as your hosts for this stimulating session. My name is Lakshada.
And my name is Mahir.
Without any further ado, let's get into the session. For all those who look forward to a discussion on soft tissue sarcomas, the wait is
Before we
finally
begin,
over. We would like to introduce ourselves as your hosts for this stimulating session. My name is Lakshada.
Department of Surgical Oncology.
Without any further ado, let's get into the session. For all those who look forward to a discussion on soft tissue sarcomas, the wait is finally over. We now like to introduce our esteemed chairpersons for this session.
Dr. Sundaran sir, Head of Department of Surgical Oncology at Government Medical College and Hospital, to discuss with us about
Dr.
soft tissue
Rita
sarcomas and
Hepsirani
their
ma'am,
management.
Head of Department of Ophthalmology at Government Thuthukudi Medical College. We now like to introduce our esteemed chairpersons for this session.
We are privileged to have Dr. Paulan sir, Head of Department of Orthopedics at Government Medical College. We now invite the chairpersons to introduce Dr. Sundaram
Rita
sir to the audience.
Hepsirani ma'am, Head of Department of Ophthalmology at Government Thuthukudi Medical College and Hospital.
We are privileged to have such distinguished professionals with us today. We now invite the chairpersons to introduce Dr. Sundaram sir to the audience.
Department of General Surgery for this wonderful CME. Now the speaker is Professor Sar Sundaram. He is now presently working as a professor in HOD Department of Surgical Oncology, Tirunelveli Medical College. And thanks to he has completed his MBBS General Surgery at Madurai Medical College, and now the Surgery, Madurai Medical College. Sundaram. He has now completed his MCH, HOD Department College, Surgical Oncology, Tirunelveli various institutions. Has completed his MBBS, Kanjipuram Regional Cancer Institute, Madurai Medical College, and Rayapeta Hospital, Surgery, Madurai Medical College. He is presently professor in HOD. Completed his MCH, special interest in head and neck, breast, and in various institutions like Kanjipuram Regional Cancer Institute. நான் வந்து as ஆர்த்தோ HOD ஹாஸ்பிடல் 98 ல இருந்து வர்க் பண்றேன். எந்த கேஸ் ஒரு ஒபினியனுக்கு திருநெல்வேலிக்கு அனுப்பினாலும் சார் சுந்தரம் சார் நிறைய அனுப்பியிருக்கோம். இதனால சுந்தர் சார் பார்த்துட்டாருன்னு வந்து 98 ல இருந்து ஆர்த்தோ HOD ல இருந்து நீங்க 98 ல இருந்து வர்க் பண்றேன். எந்த கேஸ் ஒரு ஒபினியனுக்கு திருநெல்வேலிக்கு அனுப்பினாலும் சார் சுந்தரம் சார் so much of experience. We are very eager to இதனால சுந்தர் சார் பார்த்துட்டாருன்னு thank you. வந்து 98 ல இருந்து so 2015 ல இருந்து நீங்க வர்க் பண்றீங்க. அதுல இருந்து நிறைய கேसेस சார் பார்த்துட்டாருன்னு வரும். I must thank with so much of experience. We are very eager to medical college for three things. Talk, sir. Thank you.
First is they have made me brush up on sarcoma after a long time. A very good morning to all of you. Second is I must thank I have listened to two wonderful lectures before of my medical college. So I learned a lot from them. First is they have made me brush up on sarcoma, and you know recently superstar Rajinikanth has had some I have listened to two wonderful lectures of aortic aneurysm my presentation. So such is the I learned a lot from them. Vascular surgery, vascular, it's very exciting surgery in the future. And you know recently and third is superstar Rajinikanth has had some a few tidbits about aortic aneurysm. And so such is the development in vascular surgery, scrambled words, absolutely brilliant. These and third is I was just spelling out those letters. No, a few tidbits came out. So such is the brilliance of the youngsters. Hats off to you all. Last scrambled words, absolutely so brilliant. These students. It's a very rare tumor. Among malignancies, it is just about 1%. By that time, the answers came out. Solid so such is the brilliance of the youngsters. And hats off to you all. See the prognosis of this cancer, sarcoma. So sarcoma is a very rare relatively among malignancies. It is just about 1% of all. That is, if it is diagnosed early, it is eminently curable. If you, whereas if it is see the prognosis of this late diagnosis, sarcoma, these patients invariably they die of their disease. Relatively two extremes. So what is the etiology of sarcoma? It is eminently curable. Whereas if it is any other cancer, late diagnosis, very little about patients invariably they die of etiology of cancer. Why it happens, we do not know. But there are some associations with so what is the etiology of sarcoma? The APC gene is associated, and in any other cancer, the NF1 gene is associated. The etiology of patients with RB1 mutation, but there are some associations with the genes like they develop desmoids. The APC gene is associated, and as you all know, long-standing lymphedema like in filarial. Similarly, patients with RB1 mutation, such patients are exposed to radiation, they develop long duration of that chronic lymphedema. And they develop, as you all know, long-standing lymphedema, like in the mechanism is that lymphatics they proliferate along with this angiogenesis when they have and the edematous long duration of that chronic lymphedema, they develop immune system sarcoma. So the mechanism is that these lymphatics they proliferate along with this and another etiology is radiation. And the edematous cancers they have very good lessening of the local, for example, lymphoma immune system. And some so it is predisposing them to when they are exposed to radiation. And another etiology is radiation. And you know some cancers they have very good prognosis. Survival like for example lymphoma after 10 years or so the median latency is around 10 years. They develop exposed to radiation in the field earlier radiation. And so they are sufficiently certain their survival is there specifically related to this median latency is around 10 years, and they develop sarcoma. What is the mechanism of these patients developing? So the sarcoma when they are exposed to tumors are specifically related to this radiation, like RT-induced sarcoma. They happen around the penumbra of what is the mechanism of these patients? You know, the radiation field has got sarcoma when they are exposed to RT. Just brush up your physics. Exposed, RT-induced border areas, they happen around the penumbra exposed to radiation, but they have, you know, the radiation field has incomplete DNA damage, and the damage is not complete. Just brush up your when they try to repair, so they go in for sarcoma. Border areas, RT-induced sarcomas, they have exposed to radiation, but they have poor prognosis. Incomplete DNA damage. The damage is about which we do not know is when they try to repair whether the trauma is actually bringing the attention of the patient they have relatively or the trauma is the cause of the swelling. We do not know that. etiology many about which we do not know is with the trauma. Whether the trauma is actually bringing the attention of the patient to that swelling, or the trauma is the cause of this swelling. And certain chemical agents, but many are known to cause sarcoma, like hepatic angiosarcoma after post-parturition. Some patients develop desmoid tumor. And certain chemical agents of the are known to cause sarcoma, like hepatic angiosarcoma, they happen in the extremities. Exposure and around 38% intra-abdominal. So coming to the distribution of the sarcoma, 65 years. So 45% of the WHO has classified soft tissue tumors as benign, and around 38% intermediate, that is locally aggressive intermediate, like desmoid. Median age is around 65 which are rarely metastasizing. So the WHO has classified soft tissue tumors as benign despite excision and intermediate, but they very rarely intermediate like desmoid. They are fibrohistiocytic tumors, rarely now called as aggressive fibromatosis. They cause and then the swelling categorical malignant, but they very rarely from one area to other. They are fibrohistiocytic tumors. What is now called sarcoma present, and then is the categorical malignant. Half of the cases present tumors which spread from one area to other, less than 5 centimeter in size. So how does sarcoma present? T stage or the TNM staging. About half of the cases present, there is a history of trauma. Less than 5 centimeter in size, but with the recent rapid growth. So when do you suspect sarcoma in a swelling? As I said, there is a history of trauma with the swelling. Many times it is painless, but with the recent rapid growth. So when do you suspect sarcoma onset swelling, which is growing relentlessly, presenting to you with the swelling of the extremity? If at all there is much pain, it might be due to the neurological fairly recent onset swelling, or a neurovascular structure relentlessly, which is there without causing much pain. If at all there is much pain, it might be due to the such may be the neurological symptoms at being compressed. Sometimes the patient may present with the symptoms of the because of which the patient is having distal neurovascular deficit. So such may be the symptoms. So the differential diagnosis, sometimes the patient may present lipoma is otherwise called metastasis, like bone mets, ubiquitous tumor. So it is present here, there, everywhere. So the differential diagnosis, so that is one of the differential diagnoses. Lipoma is otherwise called as sarcoma, and a good CT scan can differentiate between the lipoma and so that is one of the differential diagnoses of a image-guided sarcoma biopsy. And a good CT scan can differentiate between the lipoma sarcoma from a pure lipoma. And then the second image-guided myositis true-cut biopsy. So that is has got two components, the inflammatory component as well as the calcification part, pure lipoma. And the calcified then the second differential diagnosis, what is called as osteoid. It is in an orderly fashion, the histological pattern as well as orderly fashion calcification osteosarcoma. And so the calcified myositis, what is called as ossificans, it gets better in an orderly fashion. So this is also provoked by orderly fashion compared to vigorous sarcoma, physical exertion. And the myositis ossificans, it gets better. So coming to this is also provoked by. So what are the imaging vigorous for which area? Physical exertion. In head and neck, CECT is almost equivalent to MRI. So coming to imaging, CECT is better. So what are all the imaging to choose for which area? Is in head and neck, CECT is almost equivalent to MRI. Whereas in abdominal structures is better as well as air, water, because MRI is. But many times you obscured by the motion artifacts. MRI is being done for moving tumor, abdominal structures. Actually, as well as air, water scan is better for such many times you see in private practice. And regarding MRI is being done for definitely the MRI scores over actually CECT because CT scan is better for imaging as well as intra-abdominal tumors. Better delineation. And regarding extremities, definitely the MRI scores over CECT because of its three-dimensional has it got a role as well as in diagnosis better delineation of the relationship PET CT is indicated as of now only for recurrence and response assessment to neoadjuvant. Has it got a role in diagnosis or metastasis? Also, when you suspect metastasis indicated as of now, only want to know whether recurrence and response assessment to neoadjuvant tumor therapy. Some sites which cannot be also when you suspect metastasis in some imaging you want to know whether you can use PET CT. Tumor there. Some sites which cannot be for distant definitely image with the conventional investigations imaging modalities. So commonly the order of investigation is from chest X-ray to CT chest. Generally and for distant metastasis, what are all the investigations that are used? So commonly because the order of investigation is from chest X-ray to CT chest. You expect the metastasis to be in the lung parenchyma in case of retroperitoneal tumors. So commonly because sarcoma spread by hematogenous route thorax, you expect the metastasis to be in the lung parenchyma and abdomen is useful for assessing the distant liver. So lymph nodal metastasis is relatively rare in thorax sarcoma, and with certain histologies like epithelioid is useful for assessing the distant. So we don't do lymph nodal metastasis. Lymph nodal metastasis can also be identified in CECT. With certain histologies like epithelioid, RMS, is the first preferred. So we don't do larger all these lymph nodal metastasis can also be identified, and it causes less radiation. And of course, you are not going to do any curative treatment for such patients. Because if the metastasis is larger one, done, you can easily identify normal, and then you do CT radiation to identify. And of course, you are not going to do any curative treatment for such metastasis. So and also in areas where around the heart, you may not be able to pick up lesions to identify. In such smaller situation, a CT scan visits and cross-sectional imaging where you can around the heart you may not be able to pick up lesions. Has got a limitation. It cannot definitely identify a CT scan with its cross-sectional imaging less than 0.5 can identify those mets. But again, CT scan has got a limitation. Coming to the next important identify issue in sarcoma, biopsy less than 0.5 centimeter. Put the imaging before and biopsy later. Whenever you coming to the next important our tendency issue in sarcoma, go in and biopsy. Take a biopsy. So I have deliberately put the imaging before do the imaging biopsy later. And then do the whenever biopsy. You see a swelling for as a surgeon causing tendency is alterations in the imaging because of biopsy. Biopsy because of hematoma that can occur first and then do the biopsy. So you have to do a fear of biopsy only after alterations in the imaging because of the most accurate method is incisional biopsy that can occur, but because you can target the area and get the biopsy from only after relatively non-necrosed area. The best method is so that you get the proper incisional biopsy. But generally, because you can target the area, image guided the biopsy from a relatively non-necrosed area. The image guidance so that you get the proper makes report. You to take biopsy. But generally, what we do is image guided better preserved tissue. There are two components. Second is the image guidance the area makes from where the take biopsy from relatively. So these two better important factors are there in image guided. Advantage you don't image guided coordinated biopsy. From where the excisional biopsy can be, it should not be done in lesions which are bigger than 3 important factors are there in what about FNAC? It's relatively simple, painless, coordinated biopsy. Not have any, it can be excisional done as an outpatient procedure. It should not be done in lesions which are bigger than 3 relatively simple procedure. But what about FNAC? Is only indicated in case of recurrence, not have any, or when you plan for neoadjuvant chemotherapy. That too, it is not very useful because the coordinated biopsy is only indicated in case of recurrence or when you plan for neoadjuvant varieties of sarcoma there. It is very few are useful because coordinated biopsy gives you the exact histopathology of the sarcoma. Histology, you need to have varieties of sarcoma there, and very few are responsive to chemotherapy and cytogenetic studies. That subset of frozen section has no role of tissue which is obtained only because of the relative rarity of IHC and cytogenetic studies. The pathologist may not be experienced in frozen section has no role the tumor histology and as well as the IHC cannot be done rarity of these tumors. Because the pathologist may not be experienced in identifying but definitely the tumor histology and assessment of the margin cannot be done in the frozen section. So there are certain rules for biopsy diagnosis. As I said, it's only done after imaging. Assessment of the margin status once who does the excise the tumor. Surgery later on because he can. There are certain rules for biopsy. As I said, it's only done after imaging. Accessible along with the surgeon who does the and it should surgery later on because be representative tissue along the biopsy site. 4 to 6 course and the scar should be accessible along with the definitive surgery. And it should be image guided to avoid necrotic tissue. There should be at least 4 to 6 whenever you do open biopsy, you should not raise a flap. Biopsy. You should not, and it should be image guided to avoid tissue planes unnecessarily. And you have to have perfect whenever you do open biopsy, to prevent you should not raise a flap. Future you should not dissection of planes by this hematoma. Violate tissue planes unnecessarily. And if at all you keep and a drain, you have to have along this incision to prevent future dissection of planes by this hematoma. Pathology report of a biopsy. There should be no drains, and if at all you keep a drain, it should be along this histology of the tumor so that it can be excised. There are some 50 different so what do you expect from the pathology report of a biopsy? Certain types have got certain propensities for histology of the tumor or radiation. As I said, there are some. So you need to know the histology. Different sarcoma types of the tumor should be known. Certain types have got most important in sarcoma more than the size is the grade of the tumor, etc. So So the grade is decided based on the mitotic index, degree of and third, the most important in sarcoma, and more than the size, is the grade of the tumor. So the grade is decided based on the mitotic index, degree of necrosis, etc. And you can do cytogenetic analysis. If the pathologist insists, you need to do the IHC, immunohistochemistry study. After diagnosis of sarcoma, what we do is staging. And you can do cytogenetic analysis, which used to ask in all CMEs. Why do we stage after cancer? Diagnosis of sarcoma? What can we do is answer? Why do we stage cancer? I say this is an important question which I used to ask in all CMEs. Why do we stage cancer? Can anyone answer? So generally we stage cancer to know the exact extent of the tumor. Then the patient will be asking about the prognosis. What is my chance of surviving? So generally we have to give out a prognosis to know the exact extent of the tumor. So as the patient will be asking about the prognosis, what is my chance of surviving? Already, so you have to give out a prognosis. We do no longer do surgery upfront. Previously we used to do surgery. So as you know, in breast cancer, neoadjuvant chemotherapy and then do surgery. Disease is already locally advanced breast cancer. We do no longer do surgery upfront. Which one? Previously we used to do surgery. You need to know the exact stage of chemotherapy and then do surgery. And next is to compare, to decide the various centers and when to give which one first. You need to know the exact stage of the that he is curing all cancers. And next is to compare you might be treating various centers stage 1 cancer, treatment whereas in some other center the results may be very poor because they are treating a lot of someone might claim that he is curing all cancers. So for that purpose you need to have a staging system which is universally acceptable. Whereas in some other center the results may be very poor because they are treating a lot of stage grade cancers. First. So for that purpose you need to have a staging system which is universally acceptable. And the system that is being followed staging is unique in that it incorporates the grade 1, grade 2 and grade 3. First, the higher the grade, the worse the prognosis. See the grade if it is and so the all system that is low grade tumors are stage 1 irrespective of grade size. The tumor may be 20 centimeter in size or it may be 5 centimeter. Higher the grade, the worse it is only stage 1. So right? All low grade tumors high grade stage 1 irrespective of the size. The higher may be 20 centimeter in size or it may be 5 centimeter in size. Size is also incorporated. Still, it is only stage 1. Disease right? With the lymph node high grade as you grow stage go to the higher grade. This is the latest size is also incorporated. And all and there is no staging for visceral and metastasis. There as you know the stage 4 is this is the latest disease which has spread to the visceral metastasis staging. And there is no staging for visceral and proper to which I have been called. As you know, the stage 4 is the liberty that disease which has spread to the visceral tell about the etiology as well as the evaluation. So coming to the management, whenever the localized disease is there, it is eminently curable. But it is locally advanced, liberty to potentially curable. Briefly tell about the etiology as well as rarely evaluation. So whenever the localized disease is there, it is eminently curable and it is locally advanced area potentially curable. Surgery is the prime modality of treatment, rarely curable. But still here also nowadays neoadjuvant chemotherapy is we are very happy that still remarkably area where surgery is the prime modality of treatment. But still here also nowadays they had aggressive fibromatosis which is usually remarkably surgery. Previously we used to do wide local excision for such diseases. But of late they had aggressive fibromatosis recurrence rate usually treated with surgery. Even if you give wide local excision for such diseases. So but of late nowadays neoadjuvant chemotherapy is being tried rate is very and high. 2 such patients even if they were able to spare their limbs these patients tend to because of the neoadjuvant. So in such cases nowadays neoadjuvant chemotherapy is being tried and 2 such patients we were able to spare their limbs the tumors because of the regressed very well with the because it was situated somewhere in the axillary region and they are on neoadjuvant chemotherapy. So whenever they come in this neoadjuvant chemotherapy as far as aggressive fibromatosis very well being given as long as the disease responds. So they are on neoadjuvant chemotherapy. So whenever they responding and starts growing again, chemotherapy as far as aggressive fibromatosis is being given. So the margin is based on the disease histology. For example, this dermatofibro starts responding and starts growing again. We will do for this. It has got some tongue. So the margin is based on the disease histology. For example, this dermatofibro. Whereas for other protuberance, it is around 1 centimeter. It has got some tongue and for well-differentiated liposarcoma, it can 3 centimeters of marginal excision is. Whereas for other sarcomas, it is around 1 centimeter. So what is the limiting factor for your wide excision? Well-differentiated nearby neurovascular, even a marginal excision is that is the major neurovascular bundle. If it is nearby, you may not be able to. So what is the limiting factor for your wide excision? So nearby neurovascular patient may have to end up with losing the major neurovascular. So for such cases, we try not be able to sacrifice that. And for low-grade lesions, the patient may have to end up with losing the limb. For example, if a sciatic nerve is coursing through a liposarcoma, well-differentiated liposarcoma, and for low-grade lesions, you can opening that bivalve the tumor. For example, if a sciatic nerve is coursing through a liposarcoma, usually not acceptable with other justified in soft tissue opening that liposarcoma. And suppose in other cases, if a vascular or the this is, for example, the femoral artery is coursing through the tumor, it is completely encased by the tumors. We can do a resection of the femoral artery. Cases, if a vascular or for example, the femoral artery is coursing through the tumor, chemotherapy is completely encased by the tumor. You can do a resection of the femoral artery, high grade, and you can do more than 10 centimeter in size. Certain histologies like the neoadjuvant chemotherapy and angiosarcoma for lesions and pre-op radiation are high grade and more than 10 centimeter in size. It can be given certain histologies like those mentioned, especially RMS, and you cannot make an oncologically and pre-op radiation irrespective of the histology without sacrificing the limb. Whenever the tumor is too pre-op and you think that you cannot make an oncologically acceptable limited and the lesser field without sacrificing the limb. Exposed to radiation, pre-op response to RT because the target volume before surgery is good because of the intact vascular supply. And therefore the dose exposed to radiation and the response to RT when do you do before surgery in a locally advanced of the intact vascular supply after and therefore the dose will also be limb salvage surgery is the aim in case of extremity when sarcomas. Do you do surgery in a locally advanced there are certain terminologies like radical chemotherapy. So radical resection is limb salvage surgery is the aim in case of extremity another such is amputation. Radical. There are certain terminologies. Wide local resection is not called a. So radical resection is one. Whenever the tumor is confined to one compartment. For example, the flexor compartment of the thigh. Wide local excision is not called a radical resection. Radical amputation is amputation which confined to one compartment. For example, the flexor compartment of the thigh. There is a disease in the leg. Compartmental resection. AK amputation. Radical amputation is an amputation which is done. This is an algorithm joint above the disease site. For example, if there is a disease in the leg, for low grade AK amputation, whatever it is, the margin of excision may be. This is an algorithm. I don't know whether and you are able to see it from there. If it is so, as I said, for low grade or whatever it is, the margin is very close. It is acceptable. Low because it is low grade and even it's going to grow again. If it is margin positive, whereas for other sarcoma type, you have to do a wide local excision. The margin is very close. It is acceptable 1 centimeter because it is low grade and it's going to grow again very slowly. If it is negative margin, no. Whereas for other sarcoma type, you have microscopically positive margin. You aim for 1 centimeter. For high-grade tumors, again, if it is negative margin, you have to know the histology. If there certain chemosensitive tumors like Ewing sarcoma and rhabdomyosarcoma, you have to give neoadjuvant chemotherapy and again, then you have to know if the response is good. You can do chemosensitive tumors like Ewing sarcoma and rhabdomyosarcoma. You have to give neoadjuvant chemotherapy and exercise without causing much morbidity. If the response is good, you can do first limb salvage. If it is around 5 to 10 centimeters, whereas for other sarcoma preoperative, if it is less than 5 centimeters, you can exercise without causing much morbidity. If it is more than 10 centimeters, first again neoadjuvant. If it is around 5 to 10 centimeters, you can consider preoperative chemotherapy or radiation sarcoma for surgery. In retroperitoneal sarcoma, you cannot have much of again margin chemotherapy. So whenever previously we never used to insist on biopsy for retroperitoneal sarcoma. Now you cannot have much of these sarcomas are also sensitive to chemotherapy to some extent. We never used to insist on biopsy for retroperitoneal sarcoma. Now that you take a these sarcomas are also sensitive to chemotherapy to some extent. The best example is GIST. You can always give imaginary there is that will downsize the tumor. You take a coronary biopsy to identify heroic resections, multi-organ resections, etc. for GIST. But nowadays you can always the response is very good. That will downsize the tumor. Can easily be previously we used to do a CT scan. Heroic even after 2 multi-organ resections, etc. for GIST. Courses of but nowadays when the response is very good in this response can easily be thereby you will know that these patients are doing well and you can for other things you do that way you will know that these patients are doing well and you can continue the imatinib till the response flatters and then you can do surgery. So coming to the metastatic for other things you do a resection and subject the patient has got some pain or bleeding RT. You can give palliative RT. You can do palliative metastatic disease for fungating for where the patient will be suffering from has got some pain or bleeding. You can give palliative RT. Resect, but it can do palliative resections for fungating tumors. So I'll go with the patient will be suffering from photographs of smelling surgery that has been done. It's a large retroperitoneal mass, but it can only be CT scan images showing almost the mass. I'll go with the one half of the abdomen. Photographs of our and CT angio has been done to assess the large retroperitoneal mass relationship to the CT images showing almost the mass occupying. This is another patient. Sorry for not. And CT angio has been done to assess the of the patient. She had one huge fungating MPNST in the axillary region. This is another patient. Sorry for not camouflaging the identity of the patient. Section of the limb along had one huge fungating MPNST in the axillary region. Of course, we can do heroic surgeries like this, but the survival of the patient will be of the limb along with the scapula and the part of the clavicle. This is a CT scan of that patient. Of course, we can do heroic surgeries like this, but the survival of the patient will be only in months. You can see the huge tumor occupying the medial CT scan of that patient. This is another case limb salvage surgery of the resected the tumor with the 1 centimeter you can see the huge tumor occupying the medial neurovascular structures. And this is we did a limb salvage surgery. We resected the tumor with the 1 centimeter margin, preserving the neurovascular sarcoma is a very rare disease. This is the post-operative. Our experience with sarcoma is fairly limited. So, but it is a commonly mismanaged. Sarcoma is a very rare disease. So you need to know, as in our experience of the sarcoma is fairly limited. The first attempt is the best attempt, but it is so commonly mismanaged your disease. So decision making based on most of the cancers knowledge that is there. The first attempt is the best attempt. Our aim is so you have to rely on your what is decision making based on the latest knowledge that is there. First do know how. So our aim is subjecting himself or herself to surgery from primum non-nausea. You cannot just like that do botch up. First do no harm the surgery. So whenever the patient is subjecting based on himself or herself, you do the surgery from you. You cannot just like that do and botch up the surgery. So based on principles, you do the
orbital sarcoma, sir.
Thank you. Definitely. So orbital sarcoma, as you know, RMS we have seen rhabdomyosarcoma. Definitely. So some liposarcomas have also been seen from the RMS we have seen. The problem is they invariably present in a very late stage. Liposarcomas have also what they usually require is craniofacial resection. The problem is they invariably brought one case I think that was and what they usually require is craniofacial resection. Yeah. You had also brought one case I think orbital excentration along with the craniofacial resection. The tear very difficult to treat, but so with the present requires orbital excentration along with the some patients may be salvageable, but definitely they will very difficult to treat. But with the present chemotherapeutic agents, some patients may be salvageable, but definitely they will lose their vision.
Some cases, doubtful cases when we are in
difficult to
medical
treat.
college. So one time one patient with proptosis with visual acuity 6/12 with massive swelling in the cheek area diagnosed as adenocarcinoma in the maxillary. So one time one patient extending into the orbit with invasion of inferior oblique and inferior rectus massive swelling in the cheek area for actually maxillectomy with extension. So I have a doubt because the patient is having the invasion of inferior oblique and inferior rectus muscle. Good vision. So we plan for actually maxillectomy with extension. Medical board. So I have a doubt because the patient all the things were done, biopsy done, everything done, but we didn't do the we presented the case to the sir. Again, we medical the biopsy and sent for receptors. We missed positive. All the things were done. Biopsy also the finding is the growth is engulfing the globe. It is not penetrating or infiltrating for receptors. He only teaches me. So in MRI also the finding is the growth is engulfing chemotherapy globe. The next not penetrating or infiltrating itself. The swelling disappeared. The patient feeling very happy. Like a medical miracle. Finally, sir told chemotherapy will melt like an ice. After the first chemotherapy itself, the swelling disappeared. The patient feeling very happy. Like a medical miracle. The time we are told and the step-by-step approach like an ice. Sir told no. So I presented the conference do no harm to the patient. Whenever you see the surgeons, we timely approach and the step-by-step approach. So before that, proper evaluations and do no harm to the save the life. Whenever you see the surgeons suffer under swelling, the tendency to remove it. So before that, proper evaluation. patients and that will save them. Thank you, sir, for wonderful presentation.
Thank you.
What about the incidence of comparison of carcinoma and sarcoma, your experience, sir, in your center?
As I said, they constitute only 1% of the cancers, solid tumors. So 99% carcinomas, 1% sarcoma.
Then same question about the incidence of synovial sarcoma, sir.
Even lesser, even lesser. Among the commonest sarcomas, you know, liposarcoma, pleomorphic sarcoma, these are all the common sarcomas. Synovial sarcoma, even lesser. But again, synovial sarcoma is also sensitive to chemotherapy. So if at all it is going to be a big size near neurovascular structures, you can always try neoadjuvant chemotherapy first and then do surgery. It's evolving. The treatment in sarcoma is evolving, sir. There is what was once the standard has now become obsolete. Things like that because of the better chemotherapy and better understanding of the disease.
Whether students understood or not,
I don't know.
Synovial sarcoma, when we get a extremity tumor, sir, your talk will be very useful, sir.
Definitely, sir.
Whether student understood or not, it will be useful at least.
I hope
chairpersons, definitely. You must ask the students what they understood.
The postgraduates, I think it will provoke them to read more about sarcoma. I think it's a disease which is, we have to make the treatment tailor-made to the patient, each patient. It's not like one size fits all, it's not like that. So, as Madam rightly pointed out, the patient presenting with a big tumor in the face, definitely he's a gone. That is what our thinking will be generally. But when the tissue says that it is one particular type of disease, especially lymphoma, with chemotherapy they respond very well. And the patient, they have a better prognosis. So our idea should be to properly understand the disease based on the latest tests that are available and do whatever that is required and make the treatment standardized to that particular disease. Thank you again, the surgery department, for giving me this opportunity. I think this is the second time I'm coming here. It's a wonderful place that you have.
Thank you for the intriguing session, sir.
I now request the chair speaker.
I now invite Dr. Arjun Sir, Assistant Professor of the Department of General Surgery in Government Thuthukudi Medical College and Hospital, to felicitate the chairpersons.
Now we'll have a 2-minute session with several interesting facts on breast cancer awareness.
The new elephant in the house of cancer since the 90s has been CA breast. From being the 4th most common cancer among women in India, now it has become the most common cancer among women. Some studies say that 1 in every 28 Indian women are at risk of developing CA breast. Why pink ribbon? The pink ribbon stands as a sign of optimism for the affected individuals and a sign of altruism for the supporting ones. This year's Pink October's theme is no woman should ever face breast cancer alone. This emphasizes the requirement of self-help groups and support to the women who are fighting with the cancer, as well as the survivors for developing their livelihood. Different parts of India see various named societies and organizations that empower women in their fight, and this emphasizes the requirement of more such self-help groups in every nook and corner of India. And as I mentioned earlier, no woman should ever face breast cancer alone. Thank you.
We hope you enjoyed the previous session. Now, let's move on to the 4th session of today's Surgifest CME. We'd now like to introduce our esteemed chairpersons for this session.
Dr. Mercy Rodrigo Ma'am, Head of at Government Thoothukudi Medical College and Hospital.
Dr. Arasi Rajesh Ma'am, Head of Department of Pathology at Government Thoothukudi Medical College and
We are privileged to have such distinguished professionals with us today. In accordance with this month's theme, we proudly present our speaker for this session, Dr. Kamalan Vijay sir, Professor of the Department of Surgical Oncology in Tirunelveli Medical College, to discuss with us about the approach to breast cancers.
we now invite our chairpersons to introduce Dr. Kamalan Vijay Ma'am to the audience.
So good morning everyone. I am very much delighted to introduce our esteemed speaker, Dr. Kamalan Vijay, Madam. Madam has completed both her MBBS and MS from Tirunelveli Medical College. And she has served as Assistant Professor in Tirunelveli Medical College and then Associate Professor in Thiruvarur Medical College and Thoothukudi Medical College and finally Tirunelveli Medical College. Presently, now she is working as Professor, Department of General Surgery, Tirunelveli Medical College. Madam has published multiple journals and research studies on rectal prolapse, resection and anastomosis, intestinal obstruction, acute appendicitis, and we are fortunate to have Madam to speak on this important topic, approach to breast disorder, which is highly relevant to our practice. We welcome you, ma'am.
Thank you, madam. Thank you. Really, from my heart, I thank the Department of General Surgery to ask me to present this topic in this forum, and the chairpersons. And coming to the approach to breast disorders, mostly the patients are much worried about fear of malignancy and fear of life and fear of recurrence, and what are the important presentation the patient will be presented to you in your day-to-day practice. So it may talk, the objectives are about the history, clinical features and investigations, and it is classified into benign breast diseases and carcinoma breast, and treatment and how to follow up a patient with a carcinoma breast. So in the history you have to ask, depending upon the age group, we can categorize certain diseases are common in particular age group, and about the menstrual status, premenopausal or postmenopausal, and presence of lump or pain in relation to the menstrual cycle. If it is related to the menstrual cycle, usually it is a benign one, and discharge from the nipple, whether it is various type of discharges are present, serous, serosanguinous, greenish and bloody discharge and milk discharge. And about the trauma, why? Because traumatic fat necrosis also one of the differential diagnosis of carcinoma breast. So we have to diagnose or differentiate carcinoma breast from the traumatic fat necrosis. And other features, fever and all are common in the mastitis and breast abscess. And we have to ask the history related to the bone pain, jaundice, breathlessness and headache because of the presence of distant metastasis. So what are the common clinical features? The patient may be presenting either with a lump, pain, discharge from the nipple, or changes, that is retraction of the nipple, and sometimes there will be skin changes. So apart from this, some local symptoms like breast mass which is fixed to the chest wall or the skin, and some skin changes like redness, dimpling and pudgy orange, and the regional nodal involvement, axial lymph node or supraclavicular or internal mammary node enlargement. This internal mammary node enlargement is diagnosed only by the radiological imaging. So before whatever may be the presenting symptoms, whenever a patient come to you, you have to go for triple assessment. In that, clinical breast examination is very much essential, and then we have to advise for imaging, either ultrasonogram depending upon the age group, and the mammogram in high risk individual even if it is a younger age, And the pathology, nowadays core biopsy, true cut biopsy is a standard of care. And we must diagnose more than 99% by doing the triple assessment. So coming to the benign breast disease, by doing the triple assessment, we have to categorize whether it is a benign or malignant. As you all know, what are the features of benign and malignant that you read in the books. So benign disorders are derived from minor aberrations of the normal process of development subject to cyclical hormone related and involution. So it is classified as ANDI. So breast, it is divided into 3 stages: early reproductive stage, mature reproductive stage, and involution stage. So in the normal process, in the early reproductive stage, lobular development. So aberration is fibroadenoma. Disease is the giant fibroadenoma, which is more than 5 centimeter in size. And the stromal development, this is adolescent hypertrophy, this is aberration. And disease is the gynectomasia. And nipple eversion is the normal process. Aberration is the nipple inversion. So when there is any nipple retraction, we have to know whether it is a benign or malignant or recent retraction of nipple. And in the mature reproductive age groups, cyclical changes of menstruation is the normal process, where aberration is the cyclical mastalgia. And the involution phase, lobular involution. In this age group, cysts are more common. So what are all the presentations in the benign breast disease are? Patient will be presenting with breast pain and nodularity. This breast pain is usually associated in relation to the menstruation. So it follows the menstrual cycle, and there will be the cyclical nodularity. Normal breast is either it is soft or granular in palpation. So the cyclical nodularity appears 1 to 2 weeks prior to the onset of menstruation. So in the mastalgia, it is classified into cyclical and non-cyclical mastalgia. Cyclical mastalgia occurs as a result of hormonal imbalance due to high caffeine intake and low dietary essential fatty acids, and it also may due to water retention or psychoneurosis. Non-cyclical mastalgia, there will be trigger spot. We have to identify the trigger spot on clinical examination, and tree syndrome, it is the costochondritis. So how to treat the patient we present with breast pain? We have to identify whether it is a cyclical or non-cyclical mastalgia, and we have to differentiate as malignancy in early we can go for systemic chemotherapy also. One word about the gynecomastia breast. It is a male problem. There is in that risk factors, modified risk male patient came to non-modified risk factors and genetic factors also may play a very role. Other if you suspect carcinoma breast, gynecomastia, we have to palpate and relevant investigation upon the patient presenting symptoms, and we have to classify into early breast cancer and locally advanced breast cancer and risk factors, modified risk factors, TNM staging, non-modified risk factors, and genetic factors also may play a very role. In if you suspect carcinoma breast, we have to do triple assessment and relevant investigation upon the patient presenting symptoms, and we have to classify into early breast cancer and locally advanced breast cancer and metastatic breast cancer. And TNM staging is by AGCC 8th division. So molecular biology is very much important in predicting the prognosis of the carcinoma breast. It is classified into luminal A, B, basal type, HER2 new enriched and clauding low. If the mitotic index is very low, it has good prognosis. If it is high, Ki67 has poor prognosis. These are all the diagram presentation of locally advanced breast cancer. This is the skin ulceration. This is the same patients. There will be asymmetry of the breast. And this is the nodules with some changes and the bloody discharge from the nipple. And apart from this, investigations, triple assessment, then mammogram, unilateral mammogram, apart from the salient features that is given in the book depending upon the architecture and the calcification. Other findings are skin thickening and trabecular or stromal thickening and axial lymphadenopathy. And bilateral mammogram to serve to assess the known primary tumor, to rule out the presence of multifocal and multicentric disease, and synchronous bilateral cancer or contralateral metastasis can also be studied. What is multicentricity? If the second breast cancer outside the breast quadrant and the distance between the two first lesion is more than 4 centimeter, it is multicentricity, which is essential to decide if the patient for breast conservation surgery. And multifocality, the same cancer in the same quadrant as the primary lesion, but the distance between the two is less than 4 centimeter. So a biochemical survey, chest radiograph, bone scan, abdominal imaging, and core needle biopsy, that is true cut biopsy, to know the molecular status and histology and to differentiate in situ and invasive, and punch biopsy or full thickness skin biopsy in case of inflammatory breast cancer, and PET CT is useful for the detection of malignant breast tumors and to follow up a patient and to stage the disease to differentiate locally advanced breast cancer from a metastatic breast cancer. Whether any MRA there is a role, it has a precise estimation of residual tumor than mammography and ultrasound, and we can follow up the patient with MRA if they suspect to neoadjuvant chemotherapy. Bilateral MRI can also be used to assess the additional foci of cancer and therapeutically what is the response of the patient to the drug. And even if the mammogram is occult, then we can go for PET CT. So there are certain points in AJCC TNM staging. The lobular carcinoma in situ is a high-risk benign lesion, not a cancer. And the T categorization, multiple synchronous tumor is documented using the letter M. And the prefix Y is used to denote the post-neoadjuvant chemotherapy status. And the satellite nodules in the skin must be separate from the primary tumor to categorize as T4B. And the pathological complete response, that is absence of tumor cells in the resected breast specimen and the node taken for during the surgery. And inflammatory carcinoma remains classified as inflammatory carcinoma after neoadjuvant chemotherapy even after complete remission. Microinvasive T1MY, if it is less than or equal to 1 millimeter, and the tumors more than 1 millimeter or less than 2 millimeter should be rounded as 2 millimeter. The tumor size should be measured in nearest millimeter. So workup for metastatic breast cancer, early breast cancer, that is stage 1 and 2, need metastatic evaluation if the patient is symptomatic or if the serum alkaline phosphatase level is high. And the contrast enhanced CT of the chest, abdomen and pelvis and isotope bone scan are used for locally advanced breast cancer. PET cancer to rule out metastatic disease. So treatment of breast cancer, it is a multidisciplinary team. It includes a surgeon, radiologist, pathologist, radiation oncologist, medical oncologist and a plastic surgeon. Apart from that, breast care nurse, psychological counselor and genetic counselor is mandatory to form a multidisciplinary team. So now in recent guidelines, even for early breast cancer, they subject the patient for neoadjuvant chemotherapy to tackle the micrometastasis. So neoadjuvant systemic therapy consists of chemotherapy, targeted therapy or hormonal therapy prior to surgery. Indications for neoadjuvant chemotherapy are in locally advanced cancer T3, T4 with N2 and N3 disease to downsize the tumor. In early breast cancer, to downstage the tumor to facilitate for breast cancer surgery and HER2 positive tumors, triple negative breast cancer and premenopausal women less than 50 years of age and patients with axillary node metastasis. So surgical management will be aimed to remove all the disease in the breast and axilla with negative margins, no tumor cells on the cut margins, and DCIS 2 millimeter margin is a safe margin. So in early breast cancer, options are mastectomy or BCS. So mastectomy in large tumor in relation to the size of the breast, and if it is a multicentric disease, patient with diffuse microcalcification on mammogram and local recurrence following breast conservation surgery or patient's preference. So in modified radical mastectomy, we can remove all the entire breast along with the nipple areola complex, and we have to remove the level 1, 2 and 3 axillary lymph nodes. Is there is any role for skin or nipple sparing mastectomy? Yes, there is option in ductal carcinoma in situ. If the tumor is 1 centimeter away from the skin and if it is more than 2 centimeter away from the nipple, we can go for skin and nipple sparing mastectomy. In that case, the breast should be reconstructed using autologous tissue flaps or fat silicone implant. Breast conservation surgery, now the margin of clearance 1 centimeter. Suppose if there is a dirty margin or a near margin, we have to go for a revision of margin, that is cavity shave, and it should be done along with radiation therapy. So breast conservation therapy is breast conservation surgery and radiotherapy. So it is contraindicated in multicentric tumors and tumors with lymphovascular invasion and patients with collagen disease and ankylosing spondylosis. And oncoplasty means we have to reconstruct the breast either using a local flaps or readjustment of the breast tissue if they go for breast conservation surgery or by distant flaps. So what are the surgical options for the locally advanced breast cancer? It's a neoadjuvant chemotherapy followed by modified radical mastectomy, and some cases if they depending upon the criteria we have to go for conservation surgery and radiotherapy to be followed after surgery and adjuvant systemic therapy. So what are the advantages of neoadjuvant chemotherapy? Earlier initiation of systemic therapy, we can assess the response, whether it is a complete response, partial response, or it is a stable disease or the progressive disease, and micrometastasis can be tackled, and combination drugs for better response, and we can able to see the tumor reduction both in the primary as well as the regional site. When will you assess the patient? 3 weeks after the administration of second cycle of neoadjuvant chemotherapy. This is the criteria. Then in neoadjuvant chemotherapy, the chemotherapeutic regimen followed are AC, FAC or ECC. And radiotherapy, the objectives of the radiotherapy is broad coverage of the chest wall and the skin. We have to include the undissected nodal basin, including the indel mammary, apical and supraclavicular node. We have to minimize the lung and heart radiation. Indication in locally advanced breast cancer following BC and after MRM, if the tumor size is more than 5 centimeter, There will be preoperative, there will be skin involvement and with lymphovascular invasion, and grade 3 and axillary node positive for metastasis. This is APBI, that is accelerated partial breast irradiation. If the woman 50 years or older with T1 disease and negative resector margin with a margin width of greater than or equal to 2 millimeter, invasive ductal carcinoma and no lymphovascular invasion and hormone receptors positive. In this, the radiation dose is minimized for the normal tissue. So hormone therapy, tamoxifen aromatase inhibitors depending upon the menopausal status of the patient, and targeted therapy in HER2 positive tumors, either trastuzumab or pertuzumab. And the risk of reference score can be studied by using Oncotype DX, Prosigna PAM50 and Mammaprint 50, and it is used for assessing and whether to plan for a chemotherapy in case of early breast cancer. And it classifies into low if the score is below 18, moderate if it is 90 to 30, and high after 30. And liquid biopsy, the circulating tumor DNA can be studied. And post-operative follow-up, you can follow the patient every 3 months for 3 years and every 6 months for next 3 years in a case of early breast cancer. And in a locally breast cancer, we have to follow 3 to 6 months for 5 years and then every year. Mammogram for contralateral breast, and we have to do mammogram. And metastatic breast cancer, it is a palliative treatment, improving the quality of life, and bony metastasis can be tackled, whether you have to radiotherapy and bisphosphonates can be given. So in local regional recurrence are common in inflammatory breast cancer and advanced breast cancer. So to conclude, if for a benign breast disorders, if the patient came to you with the presence of pain or nipple discharge and lump, other skin changes, we got to rule out malignancy from a benign tumor. So significant challenges in diagnosis and management, multidisciplinary approach involving the chemotherapy, surgery, radiotherapy and adjuvant therapy for a patient with established cancer, and supportive care may play a. Thank you for everyone.
Thank you, madam, for the excellent presentation. It was very elaborate. You covered each and every aspect of not only surgery, but you covered even all the pathological aspects like the molecular pathology on which the treatment is based nowadays. I would just like to add that having a frozen section also helps in the management of malignant breast lesions, especially for evaluating the margins in breast conservative surgeries or evaluating the sentinel lymph nodes so that axillary dissection can be avoided. Thank you, madam. It was very nice listening to you.
Thank you for the crystal clear explanation, madam. You just reminded me of my UG lectures. I am a student of Madurai Medical College. In those days where much importance were given to the clinical examination. Now we have this triple assessment, like we have clinical examination, imaging modalities as well as pathology. Thank you, madam. Really nice.
Thank you so much for the wonderful session, ma'am.
I now request the chairpersons to felicitate the
I now invite Dr. Kaliamal ma'am, Assistant Professor in the Department of General Surgery at Government Thoothukudi Medical College and Hospital, to felicitate the chairpersons.
I now pass on the mic to Tarunika, who has prepared an engaging game to entertain you all.
Good afternoon, everyone. Before moving on to the next session, let's see how well we are connected to our roots. So the rules of this game is pretty simple. We will be displaying the English terms for some medical conditions and you will have to guess the Tamil words for the same. So let's move on to the first word. Varicose veins. Does anyone know the Tamil word for varicose veins? Anyone stand and tell the answer to collect your treat? Anyone? Okay. The answer is Virisural Sirai Noi. Did anyone guess it right? Okay, moving on to the next word. Fistula. Yeah, got the answer. Anyone? Okay. Good answer. Hydrocele. The Tamil word for hydrocele. Please stand and answer. Okay. Please stand and answer if anyone wants to guess. The answer is Virai Veekam. Moving on to the next word. Parotid swelling or salivary gland swelling. Any guesses? Okay. Anyone can answer. Okay. Yeah. The answer is Umirneer's. What's that? Surappi Veekam. Okay. Did anyone guess it right? Pilonidal sinus. Any guesses? The answer is Aarthulai. Thank you.
Good afternoon, everyone. Let's do the next session of the day. Approach to obstructive jaundice. Now I invite the chairpersons of the session, Dr. Sivanapandian sir, Professor of Department of General Surgery, Government Tirunelveli Medical College Hospital. Now I invite Dr. Lakshmi Devi ma'am from the Department of General Surgery, Tirunelveli Medical College Hospital.
I now invite the speaker for the session, Dr. Prabhakaran sir, Associate Professor, Department of Surgical Gastroenterology, Tirunelveli Medical College. Welcome, sir.
Good morning, all. I'm glad to invite my friend, Dr. Prabhakaran, to deliver a lecture on approach to obstructive jaundice. And he did his MBBS in Tirunelveli Medical College. He's my batchmate, and MS in Government Stanley Medical College, and did his MCH in Surgical Gastro in Madras Medical College. He was a recipient of Professor Venugopal's Gold Medal, District Surgeon Dr. R. Shanmugam Memorial Endowment Award, Dr. U. Mohan Rao Prize, Iredi Ammal Ziauddin Endowment Prize, Madurai ASI Khan Gold Medalist, IMA National President Appreciation Award, and Hindu Marutva Natchatram Award. And right from his UG days, he is a very studious person. And even during our UG days, he used to have a long size note with dedicated pages for each and every topic. And his notes was very popular, not only in our batch, and subsequent batch students also used his notes, and it was very informative. And I think because of his busy practice, he is not able to publish, and otherwise he would have become a Raja Mahendran of Tirunelveli and Kanyakumari. Over to you, Prabhakaran.
Thanks for your nice words, Sivanu Pandian. At the outset, I thank the organizers, especially Professor Rakesh and his organizing team, for inviting me to talk in this topic in front of the august audience. And respected chairpersons, seniors, and my dear friends, this is a very common topic. It's useful to you all as undergraduate and postgraduate, and it's an easy and simple topic too, and it's a mathematic topic as I used to consider and used to teach my students. Nothing much to understand. It's a logical thinking. As a whole surgery is a logics, and if you apply logics, it will applicable to this obstructive jaundice easily. Before going to the topic, and there's a little bit anatomy, and you all know thorough about the anatomy. I don't want to go details in much slides. It's a single slide for anatomy. You all know it's a right hepatic duct and left hepatic duct joined together form the common hepatic duct. And after the cystic duct joining, it's called as the common bile duct. And the common bile duct is having its supraduodenal, retroduodenal, and infraduodenal, and intrapancreatic and intraduodenal portions. And ultimately, it is enter the duodenum through the ampulla of Vater. You all know that. And the CBD diameter is about 8 mm, and the MPD diameter, I used to teach my students to remember these numbers: 4, 3, 2, 4 in the head, 3 in the body, and 2 in the tail. So this is the diameter of the pancreatic duct, and anything beyond that appears as a dilated one. And coming to the CBD, I add on a small point to the students that just add a millimeter for every decade after 50 years in the CBD diameter, which is normal. So beyond 50 years, don't consider this 8 millimeter as a normal, and for a single decade, add a single millimeter as a normal limit. And isolated mild dilatation of the CBD particularly in the elderly, particularly in the post-cholecystectomy scenario is normal. Don't consider this as an abnormal one, and don't evaluate with sophisticated investigation, waste the money. So it is a mild CBD dilatation, particularly post-cholecystectomy status, is normal always. And always don't remember to consider choledochal cyst if there is disproportionate dilatation of CBD. Remember, the CBD is dilated, the intrahepatic biliary radicals are not correspondingly dilated, and the GB is not distended. If in that scenario, if that is the CBD dilatation is there, then think of choledochal cyst. But remember how to differentiate the age-related CBD dilatation and the choledochal cyst. Consider if it is an age-related dilatation of the CBD, it won't be complicated with the stones, remember. The choledochal cyst always is having its own complications like stone formation and malignancy. So if there is a dilated CBD with the CBD stones in situ, without any without a GB stones, consider choledochal cyst always, and the treatment modality change. So think of choledochal cyst always if there is disproportionate dilatation of CBD. And coming to the physiology, again it is a boring topic. Bilirubin metabolism, you all must know. If the examiner is rough to you, that they will ask about this bilirubin metabolism. And to add on a small point, the biliary secretion is about 600 to 1000 ml, because you must know this, because whenever there is a bile leak, remember to fix it is a high fistula, low fistula, you must know what is the normal secretion of bile is. So 600 to 1000 ml is normal secretion, and the 75% is contributed by the hepatocytes, and the 25% contributed by the cholangiocytes. You must remember that. And the bile secretion stops if the pressure inside the CBD is more than 35 millimeter of mercury. So any obstructive jaundice, the pressure is more than 35 millimeter of mercury, the secretion stops, and the normal pressure you must know is about 15 to 25 millimeter of mercury. Also read about liver function test and the Vandenberg reaction. Whenever the examiner asks you the Vandenberg reaction, you must understand there is no good relationship with you from the examiners. They are going to dig you, and remember, be careful in the further examination. As far as myself is concerned, knowing this Vandenberg reaction and all is a biochemistry, are basic non-clinical people's area, and it's not must to know about this Vandenberg reaction and all, but we can assume the mentality of the examiners by if they have the Vandenberg reaction and all. And as far as myself is concerned, as a surgeon, you need not know about this Vandenberg reaction, but remember, to pass the exam, we need to satisfy the examiner. And to come to the proper topic, jaundice. Remember, jaundice is not a disease, it is a symptom, and it is not at all a disease, it's just a symptom. So our area is obstructive jaundice. When you suspect obstructive jaundice, if the patient is having jaundice associated with the pruritus and associated with clay cholesterol, think of obstructive jaundice. So jaundice with these symptoms associated with us, think of obstructive jaundice. Suppose think of pain. If obstructive jaundice is diagnosed now, and if it is associated with the pain, what is the diagnosis? What is the diagnosis? The patient is having obstructive jaundice, classical features of obstructive jaundice with pain. It's maybe a cholangitis, and it is the chance for cholelithiasis is more likely. Cholangitis is common in which condition? Is a carcinoma which is associated with cholangitis, or a stone associated with cholangitis? Why there is cholangitis incidence is more common in stone and not in malignancy? In periambulary carcinoma or carcinoma head of pancreas is not associated with cholangitis unless you intervene with the ERCP or some other procedures. But cholelithiasis is associated with cholangitis. Why? Because there is a biliary enteric communication is possible in cholelithiasis, not in malignancy. It is a constricting obstruction. There is no way to communicate the enteric system to biliary system in a case of malignancy, whereas in stone disease, there is always a stumbling obstruction, there is intermittent obstruction, there is always a possibility of communication between the biliary enteric bacterial entry. That's why the cholangitis is more common in stone disease. So the pain, if it is associated with obstructive jaundice, always think of stone disease. And yes, obstructive jaundice diagnosed. And if this obstructive jaundice is associated with the fever, then what is the diagnosis then? We have diagnosed obstructive jaundice. Now if it is associated with fever, what is the diagnosis? It is called as Charcot's triad, and the diagnosis is pure cholangitis. So we can assume that the obstructive jaundice is going one step ahead with the complication of cholangitis. And then, yes, cholangitis is there, obstructive jaundice is there. If it is associated with hypotension or CNS depression, then what is the diagnosis then? Obstructive jaundice you have diagnosed, complicated with the cholangitis also you have diagnosed, and then if it is associated with the shock and mental suppression, then what it indicates? What is the difference between why to differentiate all these cholangitis and this pyogenic cholangitis, which is the diagnosis? If the Raynaud's pentad is there, the diagnosis is pyogenic cholangitis. Why I want to stress on this is you have to intervene. You have to intervene some other form, otherwise the patient will go for a renal failure and the patient will die with a sepsis. So whenever the patient is having cholangitis, that's a Tokyo criteria. Then if it's a mild cholangitis, it is dealt with antibiotics, but moderate to the severe cholangitis, then we have to intervene. We have to drain the biliary system in some form, either in the form of ERCP or in the form of PTBD to cure the patients. Otherwise, the patient will go for renal failure and sepsis. So, if Raynaud's pentad is there, this diagnosis is pyogenic cholangitis or a toxic cholangitis. Yes, so obstructive jaundice is diagnosed. Now, the intermittent jaundice with associated with pain. What's the diagnosis now? It's a stone disease now. So why there is intermittent jaundice in biliary stone disease? Because of this tumbling obstruction. What do you mean by this tumbling obstruction? In a stone disease, what will happen? Either the stone may pass, or what will happen? There is a ball valve mechanism. The stone will go and impact in the distal CBD. The CBD will get dilated. Because of this looseness, the stone will get flowed, and the ball valve mechanism, the jaundice will get relieved. So this is why this intermittent jaundice in a case of stone disease. So the tumbling obstruction is characteristic of biliary stone disease. Right. Having diagnosed the stone disease classically with all these findings, now we will move on to the malignant part. If the obstructive jaundice is associated without any pain, notice the diagnosis then? It is a malignancy, not periambulary, it is a malignancy, right? Painless progressive jaundice, think of malignancy always, right? So it is malignancy, and malignancy most of the time is associated with weight loss and dyspepsia. So the associated findings you should have in case of malignancy is dyspepsia and weight loss, right? Again, there is a painless progressive jaundice, but the jaundice is getting relieved on and off with the history of melena. What is the diagnosis? It's a classical case of periambulary carcinoma. So periambulary carcinoma is painless, progressive, with waxing and waning features. And not periambulary carcinoma, I can say it is an ambulary carcinoma, because periambulary carcinoma includes distal CBD cancer, which cannot slough off, which includes the pancreatic head of the cancer, which 2 centimeter diameter, within 2 centimeter radians, which cannot slough out. Only the ambulary cancer can slough out. So we can very specifically say, if there is waxing and waning history is there in the case of obstructive jaundice, think of ambulary carcinoma. Why I want to stress on this is, nowadays, the ambulary carcinoma, even we are managing with ambulectomy. Whipples is not the answer for all periambulary carcinoma. It is ambulary cancer, and satisfy the criteria to do ambulectomy, then we can reduce the morbidity of Whipples procedure. That's why we want to stress about the ambulary cancer, always associated with the history of melena, and there is a decrease in the jaundice level. Yes, now obstructive jaundice. Clinical examination is going on. The GB is palpable. What it indicates? Suppose GB is palpable in a case of obstructive jaundice. What it indicates? It is not due to stones. Don't say it as a malignancy. It is not due to stones. Why the GB is not palpable in a case of obstructive jaundice due to stone disease? One, the GB is not virgin. Remember, too distant. To distend the GB, we need 2 factors. One is persistent obstruction of distal CBD, which is not there in this cholelithiasis. There is tumbling obstruction. On and off the stone obstruction is going and coming down. So it is not a complete obstruction. 2, and the GB is not virgin enough to distend. Even if there is distal obstruction with the impacted cholelithiasis, GB cannot distend because GB is fibrosed because of this chronic cholecystitis. So this is the 2 reasons why the GB is not palpable in a case of stone disease. So that is the Courvoisier's law. What is Courvoisier's law then? Right. Always don't forget to say the Courvoisier's law. This is the catchy word I used to teach my students, that in a jaundice patient, if the gallbladder is palpable, it's not due to stones. Of course, there are exceptions. In a jaundice patient, remember, in a jaundice patient, if the gallbladder palpable, it is not due to stones. Can you repeat? If the gallbladder is palpable, it is not due to stones. Don't remember these golden words. This is very helpful in examinations as well as in your career, entire career. So then painless progressive jaundice without distended GB. Suppose GB is not distended. What is the diagnosis then? It is a painless, progressive, What's no GB? What is the diagnosis then? It is some obstruction which is proximal to the cystic duct. That's why I used to say surgery is a logics. If you are logical enough, you can diagnose the conditions very well. So there is no GB distension. Think of proximal cholangiocarcinoma. And having said all these clinical scenario, now the theoretical part. What are all the benign cause, what are all the malignant cause, all you must know. But you must know the common things are always common. The stone disease, which is obstructive jaundice, and choledochal cyst complicated by choledocholithiasis. That is another common reason why there is obstructive jaundice. And the less common causes, of course, there is a Merici syndrome, post-cholecystectomy, biliary stricture, chronic pancreatitis induced distal CBD stricture, and pseudocyst with compression, extrinsic compression, and hydatidis compressing externally as well as intrabiliary rupture, and TB lymph nodes obstructing externally, and biliary atresia, of course, in the newborn child, and primary sclerosing cholangitis. All these causes, as you must remember, as a completion sake. And coming to the malignant part, the most common area are pancreas carcinoma, that is more common, periambulary carcinoma still more common, and gallbladder cancer with CHD obstruction present as obstructive jaundice. Of course, the prognosis is bad. That too you can consider, and hilar cholangiocarcinoma. And the less common conditions with obstructive jaundice is liver metastasis and hepatocellular carcinoma, and metastatic portohepatic nodes from other primary malignancies. These are all the common causes. Of course, there are numerous classifications are there for the slide varlama paru. Somebody to of course, there are numerous classifications there for obstructive jaundice. This Benjamin classification, but I don't rely on these classifications because there is no way useful as far as practical management is concerned. So just read about this for theoretical purpose only. And there are difference between benign and malignant. There is all for importance for undergraduates, and ultimately we need to diagnose a case of obstructive jaundice. What is the cause it could be? What is a benign or a malignant? So age is important, whether progressiveness important, is a fluctuant jaundice or not is important, and the intermittent or recurrent jaundice, all these things, the small points carry a value for a diagnosis, whether it's associated with pain, whether it's associated with GOO, whether an history of melena and distended GB is there or not, whether GB mass is there or not, and pancreatic mass, and of course all these will help to assess the level of obstruction. So these clinical points will help you to arrive at a diagnosis. So ultimately, after the clinical examination and the history, these are all the possibilities as for the undergraduate and postgraduate PGs are concerned. Because in the super specialty, this intrahepatic cholangiocarcinoma and other causes of obstructive jaundice are there. But as far as undergraduate and postgraduate is concerned, obstructive jaundice due to stone disease, obstructive jaundice due to benign biliary stricture, especially in the post-cholecystectomy situation, and obstructive jaundice due to malignancy, most probably a periambulary carcinoma, or most probably a proximal cholangiocarcinoma, have to tackle in examinations. Right. So what next? This is the history. This is the findings. This is the now you are in the area how to proceed, how to approach this case of obstructive jaundice is the topic proper today. So what this the first and foremost investigation is an LFT. So having diagnosed this as an obstructive jaundice clinically, and having diagnosed the level of obstruction to some extent clinically, now we move on to the investigations. LFT is the first and foremost investigation. So what you are going to say in LFT? The first thing is we can confirm the obstructive jaundice, yes. Then, of course, the liver function test, the term is misnomer. Only the albumin and the prothrombin time assess the function. All other things will not assess the function. So the entire term liver function test is a misnomer, and all other tests will assess the injury part or obstructive part of the biliary system. So this is, you have to interpret the LFT. And the one investigation is important in LFT is alkaline phosphatase. So think you have to assess to interpret the alkaline phosphatase level. So elevated alkaline phosphatase more than 3 times, almost it is due to obstructive jaundice. However, if that is less than 3 times of the normal, upper limit of normal, think of other reasons too. It is not due to obstructive jaundice alone. So even it can be elevated in any type of liver disease, even it's a hepatitis or hepatocellular damage, it can elevate the alkaline phosphatase, but less than 3 times that of the upper limit normal. And even it is elevated in mildly in the case of pregnant women and young adolescents with rapid bone turnover. All these patients have mild elevation, but remember, if it is elevated more than 3 times, then consider obstructive jaundice unless proved otherwise. And this is a small interpretation. Elevated ALP and bilirubin in disproportionate with ALT and AST. AST also elevated, but in disproportionate elevation of alkaline phosphatase, think of cholestasis, think of obstruction. And elevated alkaline phosphatase without bilirubin elevation or without enzyme elevation, then what do you think about it? It's a tumor infiltration, something infiltrating the parenchyma and causing this elevation of alkaline phosphatase. That is, any granulomas or any tumors which infiltrate the parenchyma of the liver, think of the elevated ALT without much elevation of hyperbilirubin level and transaminitis. And the third scenario is elevated ALT, AST out of proportion of alkaline phosphatase. Then think of hepatocellular damage purely in viral hepatitis. Remember, in severe form of hepatitis or fulminant hepatitis, the enzyme levels are more than 1,000, but alkaline phosphatase remains less than 3 times of the normal. So think of hepatocellular damage in such situations. So elevated alkaline phosphatase along with elevated ALT and AST, then the situation is a confused one because it's a mixed pattern. Gross elevation of ALP more than 3 times, obstruction. Gross elevation of enzymes with a mild elevation of ALP, then it is due to some hepatocellular damage. Or if it is mixed, then there is a dilemma. There the help will come from the R factor. You can calculate the R ratio. Remember what is this R ratio is? You can calculate this as a simple formula. R factor is ALT value, actual value, divided by the upper limit of normal to the particular lab, which is divided by ALP value, which is divided by the upper limit of normal, the ALP value. So if it is more than 5, it is definitely hepatocellular. If it is 2 to 5, there is mixed pattern. If it is less than 2, it is always cholestatic. Remember, so if there is a mixed pattern, where there is not much of elevation of alkaline phosphatase more than 3 times, but if it is associated with ALP, AST and ALT elevation, then use this R ratio to find out in what side it is inclined to. It is towards the cholestatic side or it's towards the hepatocellular side. So R ratio is always important in this situation. Okay, having interpreting this LFT, now what next? We have diagnosed this case of obstructive jaundice. Now we move towards our area. It is obstructive jaundice classically based upon clinical examination and biochemical. Now the next investigation should be always ultrasound abdomen. Don't skip. Why ultrasound abdomen is important? Suppose there is a classical obstructive jaundice. You do an ultrasound. There's a gross ascites, the multiple liver metastases. What is the need of other investigation, further workup and spending money of the patient? So always screen with ultrasound whenever the patient having obstructive jaundice, and if these gross findings are there, no need to proceed further. We can move on to the palliative side. So ultrasound is a screening modality. Of course, there is a limitation. It's operator dependent, and it detects a level of obstruction almost in the 90%. And distal CBD we cannot assess by ultrasound much because the gas will obscure the distal CBD. And we can assess IHBRD, and we can assess any lesions, hypo or hyper or echogenic lesions in the liver, and ascites and nodes, multiple nodes we can assess in the ultrasound. So what next? What next? Ultrasound done, which is suggestive of obstructive jaundice. We can assume the level of obstruction by GB distension and all. And now the road will be shown by the LFT and USG findings. Based upon LFT and USG findings, we can proceed. I will say these are all the options in front of us: CT, MRCP, ERCP, and US. I used to find from PGs that they will do all investigation, routine, ultrasound, CT, MRI, whatever investigations available in the hospital, they will do. So that is not the criteria. What investigation to do? To do CT or to do MRI based upon LFT and ultrasound finding. Right. So if GB is distended, simple clue, if GB is distended, what is the first investigation then? It's a CT always, because you must know if the GB is distended, the obstruction is in the distal CBD level. In the distal CBD level, most probably it is a pancreatic obstruction. So triple phase CT with the pancreatic protocol is the ideal investigation modality if the GB is grossly palpable. So okay. So what is triple phase CT? You must remember, examiners may ask you that what is triple phase CT with the pancreatic protocol. You must see arterial phase, late arterial and pancreatic phase, and portal venous phase. All these things you can read and you must be able to answer in the exam. And the CECT triple phase can detect the nature of the lesion and the level of obstruction accuracy with accuracy of 90%, and we can differentiate to some extent benign and malignant, and it gives a roadmap to proceed and relations with important vascular structures to assess whether it is resectable or not. And of course, there is a limitation to diagnose a stone disease, because stones can be assessed only in 10% of the cases in CT. So CT is not the workup plan for if you suspect choledocholitis. So CT, we can assess the resectability. Is a case of periambulary carcinoma. We can assess the distended pancreatic duct and CBD, and hypodense mass in the head of the pancreas. You can assess in the hilar cholangiocarcinoma, locally advanced head of the pancreas. All these things we can assess. We can assess the resectability in a case of with the CT. Welcome, Dr. J.Lal sir, for this August auditorium. And then, with the help of the CT, we can also look for the complications of obstructive jaundice in the form of cholangitis, in the form of gastric outlet obstruction, in the form of secondary biliary cirrhosis, whether there is any portal hypertension is there or not. All these things can be assessed to some extent by CT. So, if the GB is not distended, what next? If the GB is distended, I said there is a CT is the first investigation of choice. If the GB is not distended, then always MRI with MRCP is the investigation of choice, and the T2 weighted image is always helpful, because T1 is helpful to assess the anatomy, T2 is assess the pathology, and ducts above and below the obstruction we can assess, and it is preferred in a case of choledocholitis, in a case of benign or malignant strictures, in a case of cholangiocarcinoma, and the anatomy of the biliary tree is better delineated by this MRCP. These are small examples. It's a case of MRCP with the periambulary cancer. It's another case of fusiform dilatation of CBD with the choledochal cyst. In a case of choledocholitis, a multiple filling defect of the dilated CBD. And another case is hilar stricture with the first not duct separation, and the second case with the ductal separation. So all these things can be delineated well in a case of MRCP. This is a case of malignancy, head of the pancreas first case. In a case of benign chronic pancreatitis induced obstruction. See the difference? It's an abrupt cutoff in the distal end of the CBD. In a case of malignancy, it's a fusiform. There's a slow narrowing in a case of distal terminal, in a case of chronic pancreatitis. I welcome our Dean, our Thoothukudi Medical College, for this Surgifest conference. Welcome you, sir. So these are all the benign and malignant causes of obstructive jaundice, and the next investigation will be the ERCP. Whether to do ERCP in all cases of obstructive jaundice. Clearly remember, there is no diagnostic role of ERCP nowadays, only therapeutic role. If you want to do a sphincterotomy and relieve the cholangitis, do a ERCP and sphincterotomy, and it's an invasive investigation. If you want a biopsy, you can do that. If If you want the brushings to assess the stricture, to assess from benign or malignant, you can do that. And then complication is always there, 5 to 10% of complications, and mortality is there. So it is not a preferred investigation for diagnosis. Of course, if we need a therapeutic role also, then we can do these investigations. And the next step is the role of cholangioscope in obstructive jaundice. If there is a dilemma, whether it is a benign or a malignant biliary stricture, then always do a cholangioscope and do brushings and do a frozen section biopsy. And if it is malignancy, proceed as a malignant biliary stricture, or if it is a benign, consider as a benign biliary stricture and proceed. So in that way, cholangioscope will help. What is the role of EUS then? Endoscopic ultrasound in obstructive jaundice. Always there is a role, not for all cases. We couldn't differentiate a benign from a malignant mass in the head of the pancreas. What we can do, if it is a benign mass, we have to do a drainage procedure. If it is a malignant part, we have to do a resection procedure. We need to decide. So in that situation, we need an endoscopic ultrasound guided FNAC. In such situation, it will be helpful. And in some cases, whether there is a distal CBD obstruction is due to tiny stones, or it could be due to malignancy. In such situation also, endoscopic ultrasound is very helpful, because MRCP, we can't assess the distal CBD tiny obstructions. So EUS is helpful in such specific situations. And role of tissue diagnosis, not recommended in upfront operable cases. If the patient is operable, don't proceed with try to establish with the tissue diagnosis. So only when planning for a neoadjuvant therapy or a palliative setup, you need some tissue diagnosis. So preoperatively, we can take biopsy inside doing endoscope, endoscopic ultrasound, FNAC, cholangioscope, and ascitic fluid cytology. These are all the way we can try to fix the diagnosis pathologically. So having said that, now you all know is that the obstruction could be in the upper level, in the GB cancer or hyalocholangiocarcinoma, or in the mid level due to GB cancer, carcinoma, or Merici syndrome, or it could be a lower level due to CBD stones or a periambulary carcinoma or pancreatic malignancy. So these are all the level of obstruction the PG should say in the exam. And of course, the staging laparoscopy is always helpful, and many times it will avoid the major laparotomy. So in which cases you have to subject the patient for staging laparotomy. In 25 to 30% of patients with GB cancer, it upstage the laparotomy. Diagnostic lab will upstage and avoid laparotomy. So gallbladder cancer and pancreatic malignancy, particularly in body and tail malignancy, and rarely in small periambulary carcinoma, this diagnostic lab is always helpful. So do a diagnostic lab, particularly in GB cancer and body and tail malignancy. So how to prepare a patient with surgery? Hydrate well. So doing surgery is not a major thing, but prepare the patient with good hydration and correct the coagulation defect and diuresis if necessary, and address the sepsis. Always do all these things before going and doing a surgery. So when is this preoperative biliary drainage is another question during the routine examination. So when will you do preoperative biliary drainage? Suppose the management gets delayed for some other reasons. If the patient's comorbid is more, we need to delay the surgery for some time. Do a preoperative biliary drainage. Or if severe cholangitis is there, you need to wait for the cholangitis to settle. Do a preoperative biliary drainage. Or intense pruritus. So these are all the three indications commonly say in the textbooks. So intense pruritus, severe cholangitis, severe comorbidities in which the patient cannot withstand the major surgery. In such situations, do a preoperative biliary drainage. So definitive treatment. Coming to the treatment part. So definitive treatment for the malignant, try to cure always with a radical surgery. If not possible, try to resect at least. If not possible, try to bypass. And if not possible, try to do a stent. Even if it is not possible, leave it alone without doing any harm to the patient. So this is the management principles for the patients with the malignant obstructive jaundice. So radical resection, carcinoma of the pancreas, Whipple, and periambulary carcinoma, again Whipple, and distal CBD cancer, Whipple, and CAGB is a radical cholecystectomy, and hyalocholangiocarcinoma, excision with hepatectomy. So without hepatectomy, managing cholangiocarcinoma, it is harmful. And palliation in the form of endoscopy or percutaneous or brachytherapy, these are all the way we can manage. And these are all the management for benign obstructive jaundice. The students to note, the CBD stone, ERCP stenting with laparoscopectomy is the guideline. And single stage laparoscopic assisted choledochal exploration is what we are doing now. It is next area. And lap chole with intraoperative ERCP is another, because ERCP followed by lap chole, we need two different sessions. So better to do a lap chole with combined post-operative ERCP, that will be fine. If the endoscopist cannot remove the stones endoscopically, then always we will have the laparoscopic port, do a laparoscopic CBD exploration. And choledochal cyst, always you need excision when the hepaticojejunostomy, and benign biliary stricture with a doubt to rule out malignancy, excision of the biliary tree. And if it is a post-operative biliary stricture, do hepaticojejunostomy. If it is a Merici syndrome, in simple cases is a simple cholecystectomy. In a complicated cases, sometimes may need excision of the extrahepatic biliary tree too. So what is Whipple's pancreatic duodenectomy? Sometimes the examiner may ask the steps of the Whipple's procedure. Its indications is a malignant periambulary carcinoma, CA head of the pancreas, and mucinous cyst adenoma head of the pancreas. And in only one benign condition, Whipple is acceptable is CCP, that is chronic calcific pancreatitis with doubtful head mass, where we cannot rule out malignancy. In such situations, we can do a Whipple's procedure. What is Whipple's procedure? Remember this diagram, and this is the area we have to reset. That is a reconstruction part. So that is a discussion is over. I want to say some case scenario we managed recently for the past 3 months. So this is the case number scenario 1. Students must note, it's a 65 years male. You must be able to tell the diagnosis. 65 male, intermittent jaundice, 1 month duration, associated with the fever, rigor, chills, and associated with the right hypochondrial pain, and clay-colored stools, and associated with the vomiting. What's your diagnosis? What's your diagnosis in this clinical scenario? It's most probably a CBD stone. Yes, so on examination the patient is ectric and all other findings are normal, and the LFT shows this is the bilirubin level of 7 with alkaline phosphatase level of 456, and all other parameters are normal. Again, it is suggestive of choledocholithiasis. Right, ultrasound says there is no IHBRD. GB, there is a multiple calculi. CBD is dilated with multiple stones. What is the diagnosis again? It is a choledocholithiasis. So what to do? The next investigation, as I said, if the GB is not distended, is always MRCP if you suspect stone disease. This is the classical MRCP findings of that particular patient. Mild IHBRD, GB is contracted. Remember the classical point to say it's a stone disease, and the multiple stones in the GB, and dilated CBD, multiple stones in the in-step ladder pattern, and the maximum size about 10 into 9 centimeter. So this is diagnosis is cholelithiasis with the choledocholithiasis. The management is laparoscopic CBD exploration. That's what we follow nowadays. This is the port position of that particular patient. And so this is a position for laparoscopic CBD exploration. In what case you have to do a laparoscopic CBD exploration, I will come later, and we have to do a wholly divide the cystic duct, but should not remove the GB, because GB will be useful for retraction, and always do a choledochotomy just above the duodenum, and with the help of the nephroscope we used to enter the CBD, and with the help of the basket or some other gadgets we will remove all stones which is the distal CBD, and we can clear the proximal CBD also. We can assess the entire CBD tree proximally and distally, and we after removing the stones we can keep a stent inside, and we will close the CBD primarily. This is a laparoscopic assisted CBD exploration. To summarize, what is the management for choledocholithiasis? So painful obstructive jaundice with intermittent history, yes, stone disease is possible. GB is not palpable, add on to the diagnosis, and and LFT ultrasound MRCP suggestive of cholecystolithiasis. The criteria to management: if the duct size is small, less than 1 centimeter, subject the patient to ERCP, clear the stones, do a laparoscopic cholecystectomy. That is the classical management we used to follow. And if the CBD size is mid-size, that is between 1 to 2 centimeter, then always what we do is a laparoscopic assisted CBD exploration, as I showed now, and that is the with the primary CBD closure if you are doing in an open case, you have to do a T-tube, otherwise we can do a stent and primarily close. If the duct is large, we have to do a CDD. Anybody can explain why you have to do a CDD if the duct size is large? If the duct size is more than 2 centimeter, why can't we do a CBD exploration as we did earlier? So the problem is the CBD will act as a GB. The CBD is dilated. There will be some amount of stasis will be there, and there is always the stone formation. The CBD is possible, so always better to do a CDD. And the second scenario is 52 male, you must be able to say the answer: painless progressive jaundice, clay color stools, pruritus, loss of weight, loss of appetite, and there is alcohol and smoker. What is the diagnosis? It is a malignancy. You can't say it's a cholangio or periambulary carcinoma. It's a malignancy. So now look at the findings: ECOG status zero, icteric, supraclavicular node negative, and palpable GB on palpation of abdomen. And the LFT finding shows gross elevation of alkaline phosphatase with a bilirubin level of 15. And OGD says bulging emboli. What is the diagnosis now? Any obstruction is a malignant obstruction distal to the cystic duct junction. That is a most probably a periambulary carcinoma. Ultrasound is corroborative. Mild dilated IHBRD, GB distented, and 12 mm dilated CBD. Now this is a CT finding is a grossly dilated CBD. With you can assess all these findings. You can assess the vascular involvement. The vascular structures are free. And MRI, you can assess the double duct sign clearly. And this is the classical case of periambulary carcinoma. We proceeded with the Whipple's pancreatectomy, and nowadays we are doing Whipple's pancreatic surgery with laparoscopic mobilization. This is the case we did recently. The diagnostic laparoscopy shows there is no evidence of metastasis. It's a grossly distended GB. We can resect the gastrocolic omentum and enter the gastrocolic vessels, and we can ligate the gastrocolic vessels and do the cauterization, and all steps are similar to our open Whipple's procedure. This is the laparoscopic Whipple's pancreaticoduodenectomy done in this last month. So we are doing the mobilization part with the laparoscopically and the reconstruction part openly now. So the third scenario, so we have dealt cholecystolithiasis, we have dealt periambulary carcinoma. Now the third scenario is 36 years male, painful progressive jaundice, clay color stools with pruritus. What is the diagnosis?
Sir.
Then
We are running short of time. Please.
Finish. We'll finish. It's over. And there is no comorbidities. Now the diagnosis again with the palpable GB. The pancreas, you can assess the CT, and it's about less than 180-degree involvement of the vessels. So if it is less than 180-degree involvement, it's always considered as a borderline pancreatic malignancy, and always subject the patient for chemotherapy before doing a Whipple's pancreaticoduodenectomy. Is another case of Whipple's, and see ahead of the pancreas. And to summarize, periambulary and carcinoma of the pancreas is a painless progressive jaundice. LFT, ultrasound CT will suggest. And resectable case, do a Whipple's pancreaticoduodenectomy. And the borderline resectability, always subject do a US and biopsy to prove the malignancy. And later on do a Whipple's procedure if it is stage is reduced. And the case scenario 3, this 17 years old male. Another case is a case of chronic calcific pancreatitis with a small pseudocyst in the head of the pancreas, which obstruct externally the CBD, in which we did a laparoscopic phrase procedure, and in that way the extrinsic compression of pseudocyst which compresses the CBD got relieved, the obstructive jaundice is relieved. Now this is a laparoscopic phrase procedure we did recently in Tirunelveli Medical College. So to move on, this is the entire duct is explored, and the reconstruction part we did open pancreaticojejunostomy. To summarize CCP, remember, is the management CCP with the distal CBD obstruction, LPJ with the CDJ is the treatment, CCP with the head mass and the phrase procedure, and CCP with the doubtful head mass, always it is a Whipple procedure is the treatment scenario. I will skip the case 4. It's a cholangiocarcinoma. Of course, cholangiocarcinoma, the treatment. So this is always remember, cholangiocarcinoma, the treatment is, if it is a type 3 cholangiocarcinoma, it should be combined with some sort of liver resection. If the left lobe is involved, left hepatectomy. If the right hepatic duct is involved, this right hepatectomy. This is the case. We did left hepatectomy with the help of CUSA, and we can reduce the blood loss by CUSA. This is a case we did recently in last month. This is a case of cholangiocarcinoma with the left hepatic duct involvement. So left hepatectomy along with extrahepatic biliary excision. So to summarize cholangiocarcinoma, the treatment is proximal type 1 and 2 excision of the extrahepatic biliary with hepaticojejunostomy. Type 3 always combined with the hepatectomy, and type 4 always do a PET and do a liver transplant. That is the only option. And another last case, this choledochal cyst with CBD, distal CBD obstruction. We did laparoscopically. The laparoscopic excision of the choledochal cyst with hepaticojejunostomy, which is done by open method with a small incision. This is the choledochal cyst with a young girl, young boy, Nishant. Recently we did laparoscopic mobilization to hepaticojejunostomy with extrahepatic biliary tree excision. So these are all the management different scenarios I want to stress upon the UGs and PGs. So take home points. One is define jaundice and confirm it is an obstructive jaundice by clinical and history taking, and appropriate investigation, as I said, whether to go for a MRI or CT, and look for complications, whether the cholangitis or adjacent organ involvement, and preoperative optimization is always important, and treatment always try to do a curative procedure. If not possible, do a palliative procedure. Thank you so much. With this, I will take this opportunity to invite you all for a gastric cancer, which we planned on October 23rd. It's that we are going to say what is new in gastric cancer by eminent faculties. Invite you all for this meeting on October 23rd at TVMCH. Thank you so much. Thank you so much for this opportunity.
Thank you very much, sir. That was an elaborate and in-depth presentation about obstructive jaundice. Thank you very much, chairpersons. I would like to invite the chairpersons to honor the speaker. I invite Dr. Dhanapalan, Assistant Professor of Surgery, to honor the chairpersons.
Now let's move on to the inauguration session.
Surgery is a art where precision meets purpose, a field where knowledge, skill, and compassion converge to heal and transform life. It's not just about mastering technique, it's about mastering the ability to restore hope one incision at a time. Distinguished guests, speakers, professors, batchmates, juniors, today I, John,
And me, Gladys.
take great honor and immense pleasure to extend a cheerful welcome to you all. Your presence makes us very happy. Welcome to the Surgifest 2024, the 9th annual Continuing Medical Education and Mastery 3rd Live Workshop.
And now, friends, please join us in giving our distinguished guests a cordial welcome. Firstly, let's welcome our Dean, Dr. G. Sivakumar, Sir, to Surgifest 2024. Sir, please take the dais.
Now, we welcome our Vice Principal, Dr. V. Kalaivani Ma'am, to Surgifest 2024. Ma'am, please take the dais.
Now, we welcome our Medical Superintendent, Dr. R. Patmanabhan, Sir, to Surgifest 2024. Sir, we request you to take the dais.
Next, we welcome our Deputy Medical Superintendent, Mr. P. Kumaran, Sir, to Surgifest 2024. We request you to take the dais.
Next, we welcome our Resident Medical Officer, Dr. J. Silas Jaimani, Sir, to Surg 2024. Sir, we request you to take the dais. Now, we welcome Dr. Rakesh Fernando, Sir, Professor and HOD, Department of General Surgery, Surgifest 2024. Sir, please take the dais.
Next, we welcome Professor Dr. G. Nirmal Kumar, Sir, from Department of General Surgery, to the Surgifest 2024. Sir, we request you to take the dais.
At this moment, we will honor our rich culture and tradition with the Tamil Taival. I kindly request everyone to stand up as we pay our respects to Tamil goddess. I request the audience to remain standing for the surgeon's prayer.
Surgery is more than just a skill. It's a blend of precision, dedication, and compassion. Now let's call upon our registrar, Dr. Meena Ranjani Ma'am, Senior Assistant Professor, Department of General Surgery, for surgeon's prayer.
Oh God, I am a surgeon. Give me the steady hands to hold the knife and to cut precisely. Give me the sharp eyes to look into the field of surgery. Give me clear mind to make correct decision on table. Give me a shrewd assistant and an efficient nurse to work with me. Let me have good relationship with my patients and their relatives. Let their relatives know that I am doing the very best I can do to the patient. Let their family have confidence in me as they wait outside my consultation. Let them not be excited while I work on the patient inside the theater. Some people say I am the greatest surgeon. Some others say I am next to God. But I know to my heart I am a mere mortal working with knife, and you are the greatest healer of all. Oh God, bless me, serve humanity with piety. Thank you.
I request the audience to take your seat. Thank you, ma'am. Now it's my privilege to invite Professor Dr. G. Nirmal Kumar, Sir, from Department of General Surgery to deliver the welcome address.
A very good afternoon, one and all. This is a very short and crisp inaugural function. And I take much pleasure and extend a very warm welcome to all of you who have gathered here for this much anticipated Surgifest in Mastery, proudly presented by the Department of General Surgery. Last month we had a discussion whether to proceed with this year's CME or not. But then we thought this mastery. A live workshop is always a hallmark in the history of TKMCH, so we proceeded with this in a very short time period. So I take much pleasure and privilege in inviting the dignitaries on the stage. Dr. Sivakumar sir, Dean, Government Thoothukudi Medical College, whose leadership and vision have been instrumental in shaping the direction of our institution. We are honored to have you, sir, in our midst, and we thank you for your unwavering support to our department. Next, I would like to welcome our Professor Dr. Kalivani Madam, Vice Principal, Government Thoothukudi Medical College, whose dedication to excellence in education has greatly contributed to the growth and success of our academic programs. We are deeply grateful for your presence and continued engagement, ma'am. Thank you. I also welcome our Medical Superintendent, Dr. Padmanabhan sir, Deputy Superintendent, Dr. Kumaran sir, and RMO, Dr. Silas Javmani sir, who are three strong pillars of our institution, and they extend their help whenever we go as a department. Thank you very much, sir, and we welcome you for this function, sir. I am honored to welcome the most respected and renowned professionals whose expertise and dedication have shaped the modern landscape of surgical care as today's speakers. We are having eminent speakers, and we are happy to have them in our midst. Each of them bring with them a wealth of knowledge, experience, and innovative thinking that is certain to enrich our understanding. I would also like to warmly welcome our dear faculty members of TKMCH and the nearby college faculty members, and they are our backbone of our learning community. Your commitment to excellence in medical education continues to inspire us all. And of course, I extend a heartfelt welcome to our postgraduates of TKMCH and nearby colleges and the undergraduate students for this CME. You represent the future of surgery, and it is wonderful to see so many of you here eager to learn and engage with the latest development in the field of surgery. Heartfelt welcome to all the delegates, both who have come offline and online, and I also welcome our benevolent sponsors for this event. Once again, I thank all of you for being here and making this event a success. We look forward to a day filled with learning, collaboration, and inspiration. Let's pioneer the new horizons in surgery together. Thank you, one and all.
Thank you, sir, for your warm words and hospitality. Before we proceed, let's begin this auspicious event by lighting the Kuthuvelakku, a traditional symbol of knowledge, wisdom, and prosperity. I invite our esteemed dignitaries to come forward and light the lamp, marking the commencement of today's event with hope, positivity, and the spirit of enthusiasm. Next, we have the felicitation session.
I request Dr. Rakesh Fernandez sir, Professor and HOD, Department of General Surgery, to felicitate our Dean, Dr. G. Shivakumar sir.
Thank you, sir. Now I request Professor Dr. G. Nirmal Kumar, sir, from Department of General Surgery to felicitate our Vice Principal, Dr. V. Kalaivani, ma'am.
Thank you. Thank you, sir. Now I request Dr. N. Devanathan, sir, Associate Professor from Department of General Surgery to felicitate our Medical Superintendent, Dr. R. Padmanabhan, sir.
Thank you, sir. Now I request Dr. H. Bretzi Priscilla, ma'am, Associate Professor from Department of General Surgery, to felicitate our Deputy Medical Superintendent, Dr. P. Kumaran, sir.
Thank you, ma'am. Now I request Dr. Sumati, ma'am, Associate Professor from Department of General Surgery, to felicitate our RMO, Dr. J. Silas Jaimani, sir.
Thank you, ma'am. We have our Vice Principal, Dr. V. Kalaivani, ma'am. She has been in the college by guiding us in numerous programs and events. She has always encouraged students to give their best. She makes the task of running the college seem smooth as she silently and effortlessly manages this mammoth task. Her unwavering commitment to student development and academic integrity plays a crucial role in shaping the future of our medical professionals. Ma'am, we are privileged to have you with us today. I now invite Dr. V. Kalaivani, ma'am, to share a few words with the audience.
Respected Dean, sir, Medical Superintendent, Deputy Superintendent, RMO, the HOD of Surgery, the Professor of Surgery, and other faculties from various institutions, and postgraduate students and UG students. A happy good afternoon to you all. So we are attending the Surgifest program from yesterday as well as today. So we have seen a live workshop yesterday. So it is very useful for postgraduates as well as the undergraduate students. And today is also all the programs are going on very well. I congratulate the HOD of surgery and other faculties of the surgery department and the students for organizing such a wonderful program for the upgradation of knowledge of our UG as well as PG students. It is also more informative for us, for other faculties also, what is going on in the new surgical interventions. Thank you for the great arrangement. Thank you, one and all.
Thank you, ma'am, for enlightening words. Now, we have our Dean, Dr. G. Shivakumar, sir. He has been a backbone to our college by handling matters in a calm and efficient manner. He is a keen observer who responds rather than reacting. He is a very humble person who is easy to get along with. He truly sets an ideal role model for all of us to look up to. His visionary leadership has been a pivotal in advancing medical education and fostering a culture of excellence at Thoothukudi Medical College. It's my distinct honor to invite our Dean, Dr. G. Shivakumar, sir, to give the presidential address. Let's give him a warm welcome.
Respected Vice Principal, Medical Superintendent, Deputy Superintendent, Resident Medical Officer, HOD of General Surgery, all the professors, faculties, eminent speakers, postgraduates and students, very good afternoon to one and all. CME, a continuous process of learning, and General Surgery has conducted this 9th annual Surgifest, and for the past 3 days we are seeing this workshop. Yesterday I was watching the workshop here, well organized one from two well-known centers. We are seeing the live workshops, and today all the topics that are covered were excellent, and the lectures which I heard now was also going on well. In the morning I was watching the YouTube, the link from which I saw all those speakers and our students presenting the cases, and it is a well conducted one. I congratulate the Department of General Surgery who are wholeheartedly organized in a very good manner, and the surgery is an evolving process, we all know, from the ancient days till today, and most of the time it is a treatment that is a definitive one, and it is evolving, and the modern methods we are coming across. We saw in all these years, and yesterday we saw the excellent laparoscopic surgeries that have been done with clearly without a bloodless field. We are seeing it was a treat to watch, and I was watching it. So whoever all attended, I think they would have been enlightened, and all the aspects of surgery have been covered, from basics, from anatomy, physiology, and nutrition, everything. And then today, when I came and saw the previous speaker was speaking about what we expect, the preoperative preparation, which is very, very important, and has highlighted, which makes a main point in the outcome of the patient. That is stressed very well, and because not only the intraoperative procedures they are doing, it is the postoperative care that is very, very important too for the patient's welfare to outcome of the surgical procedure. Preoperative preparation and the postoperative care is very, very important, and it has been dealt very well. I congratulate the speakers and everyone, and I wish them once again for giving me this opportunity. Thank you all. Thank you.
We express our heartfelt gratitude for your words, sir. Now, we would like to take a moment to celebrate the remarkable achievements of our talented students. We will be honoring the medal winners from the recent examinations conducted by the Department of General Surgery, both from our postgraduate and undergraduate programs. Their hard work, dedication, and excellence have brought pride to our institution. The gold and silver medals for postgraduates are sponsored by Dr. Vasan sir, former professor and HOD, Department of General Surgery, on honor of his sister, Ms. Shyamala. Now, I invite the dignitaries on the stage to give away the prizes. I kindly request the medal sponsorer, Dr. Vasan sir, to accompany us on the stage for prize distribution.
It is with immense pride that we recognize two exceptional postgraduates. Dr. Leena Rajan has earned the prestigious gold medal. On behalf of Dr. Leena Rajan, I call upon our Chief, Professor Dr. G. Nirmal Kumar sir from Department of General Surgery to receive the medal on her stead.
the faculty of the different departments of our institutions and all the faculty of the different departments of our institution and the neighboring institutions for having presence. And over the last 2 days, yesterday and today, eminent faculty, I should also like to thank two premier institutions from Coimbatore have rendered GEM hospitals and gateway clinics who shared their surgical skills yesterday through live workshops. There was a non-stop endeavor to be here with us to teach the undergraduates. On this occasion, I would also like to thank two premier institutions from Coimbatore, GEM hospitals and gateway clinics who shared their surgical skills yesterday through live workshops. There was a non-stop live streaming for nearly 8 hours yesterday, which we enjoyed to upscale our skills. And I also like to thank the undergraduates and postgraduates who are gathered in large numbers here. And without your participation, this CME would have been meaningless. And I thank you for maintaining a perfect silence and taking part in all the interactive sessions. Thank you so much. A special thanks to the students and CRMIs who volunteered themselves to be the master of the ceremony, to receive and honor the guests, and to do the hospitality services. Thank you all. Let me not forget the backstage managers. Mr. Peter, who was with us for the last 2 days, live streaming all the live surgeries yesterday and doing a wonderful job with this audiovisual treat today. Thank you, Mr. Peter, and your team. And Mr. Isaac of Wonder Balloons, who has created an appropriate ambience for us to have this CME. And of course, the NSK caterers who are waiting to fill us with a sumptuous lunch. And I also like to acknowledge the services of our computer personnel, Mr. Suresh, who has done this 500 connections for us today and yesterday, and Mr. Subramanian, our electrician, on all the crystal workers who were with us over the last 2 days, helping and cleaning up the mess. I shouldn't forget the donors. A lot of them, couldn't mention everyone, and the sponsors, especially LNR Pharma, who has sponsored the files, Torrent Pharma, Capital Pharma, and Aristo, who have been sponsoring the snacks all through this day and yesterday too. Thank you so much. A special note of thanks to our Vasan sir, retired professor and former HOD of the Department of General Surgery, for sponsoring the gold medal for the postgraduates and silver medal also, and Dr. Srinivasan sir from Koilpatti for having sponsored the gold and silver medal for the undergraduates. Last but not the least, it may seem inappropriate, but it could also be an injustice if I don't thank my own blood. As the ethos in the Department of General Surgery has been, it's not the king, but the kingdom. It's not the cult, but the culture. Kings may come and go, but the culture and the kingdom will remain, will persist, and will prevail. The embodiment of what you have been witnessing over the last 2 days, yesterday and today, is the hard work which has been brought forward by my department, sweating, toiling, tail and tooth over the last 2 days to make this occasion a grand success. Thank you, one and all. And on this occasion, I would like to register my deep appreciation and gratitude to our Dean Sir and the Department of Medical Oncology, who have sponsored a new laparoscopic set for us. And yesterday, when the Dean was with us, he was asking me about, do you have this quality of equipment in your department? I said, yes, we got it 1 week back and you sponsored it. Thank you so much, sir. We have got a 4K laparoscopic set for our department,
And on this occasion, I would like to have Professor of Medical Oncology, Gandhimati Madam, on stage, and request her along with our Dean to declare open the new laparoscopic set. Welcome, Madam. Thank you, sir. Thank you, madam. Please stay, madam. As a token of appreciation, I request Professor Nirmal Kumar, sir, to present a bouquet to the Dean and to Professor of Medical Oncology. Thank you all for your patience. Thank you so much.
Thank you for the gratitude, sir. We kindly request you to stand for the national anthem. Next, move on to the next session.
Now we'll move on to the next session by Dr. Jayalal sir on approach to scrotal swelling. I request the chairpersons, Dr. Angel madam and Dr. Srinivasagan sir, to chair the session.
Moving on, the chairpersons for the upcoming session. Approach to scrotal swelling are Dr. Angel Violet Ma'am, Associate Professor, Department of Anesthesia, Government Thuthukudi Medical College. Welcome, ma'am. And Dr. Srinivasagan Sir, Chief Civil Surgeon in Sathu GH and former Assistant Professor, Government Thuthukudi Medical College. Welcome, sir. I humbly request the chairpersons to occupy the dais. And it's our pleasure to invite respected Professor Dr. J.A. Jayalal Sir, Professor and Head of the Department of General Surgery, Kanyakumari Government Medical College for the session on the topic Approach to Scrotal Swelling. We invite the speaker onto the dais.
We now request the chairperson to introduce our speaker.
Good afternoon, one and all. I first congratulate Cadbury Color Clad Surgery team and the HOD Surgery along with our other faculties for successfully conducting the 9th annual continuing medical education and the 3rd live workshop. I welcome Dr. Jayalal Sir. Sir graduated from his MBBS from Tirunelveli Medical College, did his MS in Stanley Medical College. He is a recipient of the Best Doctor Award from the Kanyakumari District Collector and Government of Tamil Nadu. He has received the Best Teacher Award from the Tamil Nadu Dr. MGR Medical University and the National IMA. He has received the Best Rotarian Award from the Rotary International. He has received the IMA Best State Secretary Award consecutively for 3 years, 2010, 2011 and 2012. He is a recipient of the Best Surgeon Award for doing maximum surgery for HIV patients in Kanyakumari district. He has received the Paul Harris Fellow of Rotary Award, and sir has also received the Paul William Alexander Fellow of Wise Women. He is an eminent and efficient leader and very good speaker. I have attended sir's session in infection intercepted CME, sir. It was very elaborate and the points were very practical. Welcome, sir, to enlighten us.
Thank you, madam. Thank you, chairpersons and dignified colleagues. It is my honor and pleasure to be in the midst of Tuticorin Medical College surgical faculties. It is my special thanks and gratitude to the professors and the faculties of the Tuticorin Medical College for inviting me once again to this prestigious medical college and hall. I have a lot of my own classmates serving here as colleagues, so it is always a pleasure to coming to Kanyakumari and being with you at this moment. So the topic today I am going to discuss with you is how to approach a scrotal swelling when a patient comes with a swelling in the scrotum and what we are going to do. I will be talking with few things on the anatomy and what are the differential diagnoses are in front of us and how do you are going to approach. May not be able to talk all the issues, but it will be more intended for the undergraduate students level. But this is one slide I just want to know because this is one of the very commonly asked questions in the MCQs and the examination. What are the layers of the stomach or layers of the scrotum? We take the skin. The second is a dartas fascia and the muscle, which is a subcutaneous one. This is very important and it is very peculiar to the scrotum because it has a peculiarity to contract and relax. Thereby, it helps in the preservation of the temperature of the testis. And whenever we know when you are putting a coffee, when you are taking, when it's a hot coffee, when you are putting in a plate, in a wider plate, it gets cooler very quickly. The similar pattern when you are going towards a cool area, the dartas muscle will contract and it will keep the testes very close to the abdomen. And when you are in a hot area, the dartas muscle and the fascia will relax so that the surface area is more heat is evaporated and the less heat is there inside and the temperatures will be maintained. So that is a very important layer which we see in testis scrotum, which is the rugosity is maintained. The third is external spermatic fascia, which all of you know that it is a continuation of the external oblique abdominis. And then you have a cremastic fascia coming from internal oblique. Then you have an internal spermatic fascia. Then you have a tunica vaginalis. The tunica vaginalis has two layers. One is a visceral layer, one is a parietal layer. So this is two layers are more important when we talk about the hydrocele. And this visceral layer and the parietal layer in between the accumulation of the fluid is going to be constituted. Then we have a layer which is there on the tunica albuginea, which is a covering. So when you say the layers of the scrotum. Now coming to the testes, we know this is an anatomy of the testes. We have the tunica albuginea, which produces the septae inside. And within each testate, you have a seminiferal tubules. So you have a head, you need a body, a tail, and that you must know the origin and insertion or the end of the vas deferens as it starts from here, goes through the deep inguinal ring, superficial inguinal ring, and goes and joins with the seminal vesicle and opens into the prostate urethra, because this origin and insertion is particularly important. Next important structure, what you are going to see is the spermatic cord, and this is a very, very important diagram which shows the layers of the spermatic cord. And as you are dealing with the spermatic cord, and we know the outermost, we have external spermatic fascia in this cord. Then you have internal spermatic fascia. Between this external and the internal spermatic fascia and the cremastic fascia, you are going to have the ilioinguinal nerve and the lymphatics. The lymphatics are going on the most outwards. The ilioinguinal nerve is not inside, but it is the outside. And when you come to the next layer between the cremastic fascia and internal spermatic fascia, you are going to have the genital branch of the nerve and the cremastic artery and cremastic vein. And inside the canal, and you are going to have all other things, the testicular artery, testicular vein, and pambriform plexus. And this is most important because when you are dealing with a spermatic cord, you must know where these structures are there. Only when the testicular artery is much deeper in the central position, and when you are coming outside the ilioinguinal nerve. Another important question we asked in the examination is layers of spermatic cord differs in the inguinal canal and in the scrotum. In the inguinal canal, there is no external spermatic fascia. So we have all the other layers are true in the inguinal canal inside the spermatic cord. And when it comes out, only the external spermatic fascia comes. And this is a one difference question. Normally you ask the examination, the layers of the the coverings of the spermatic cord outside there. So you must know there are three fascias, external spermatic, cremastic, internal, three arteries, and you have cremastic artery, testicular artery, and then you have three veins and three other structures, and these all are the component of the spermatic cord, because what the surgery in the hydrocele or the surgery in the scrotum involves that you are going to talk about the dealing with the spermatic cord, which is the most vital structure, and the how it is going, and always should know. So when a patient comes with a swelling in the scrotum, and we have a few, when we are approaching that, we have a differential diagnosis or how we are approaching depending upon that. There are a few questions you need to ask. Can you get about the swelling of that swelling which is there? Is the swelling is transluminant, and is the swelling is, can you identify the testis, palpable the testis separately, and is there is any tenderness or the pain is complaining is there? And with these four findings that you will be able to differentiate and what kind of swelling and what kind of thing you are going to deal with that. And suppose if the swelling is not confined to the scrotum, it is extending beyond the upper border of the scrotum, then you need to subject the patient for a few tests, which is a cough impulse, reducibility, whether the testis is palpable separately or whether it is a transluminant positive. And if all of them are there, and then you need to talk, it is only a hernia. When there is a cough impulse is there, and you are able to reduce. But on the other hand, the getting about the swelling is not positive. The swelling is not confined to the scrotum, but there is no cough impulse, it is not reducible, and the testis you are not able to palpate separately, and it is transluminant, then you should think it's an infantile hydrocele. And that is again one way. Normally we say all the hydrocele, the getting about the swelling is positive, but not for the infantile hydrocele. Infantile hydrocele getting about the swelling may not be positive because it is going up to the inguinal canal. On the other side, if the swelling is confined to the scrotum, and we need to do the test whether apart from the swelling, you are able to palpate the testis and epidermis separately, or you are not able to do that. And if in case
that you are able to do the testis and epidermis not definable or not palpable separately, again you are going to do the testing. And if it is a transluminant, it is only, we are going to think it is a vaginal hydrocele. The testis is not palpable, epidermis is not palpable separately, but the swelling is transluminant. The diagnosis, obviously, it is going to be the hydrocele. But on the other hand, if the swelling is not the testis you are able to feel, and the swelling is not much the transluminant, and then the question comes whether you are going to deal with the swelling, of it is a acute swelling or a chronic swelling, or with the tenderness or the pain. And if you are thinking it is a non-tender, again it is a non-specific inflammations, or either it could be a hematocele or the chronic infection. But if it is a tender, and the most importantly, you need to think in terms of the torsion testis. So acute swelling, the testis is palpable, but the transluminance is negative, and you are going to have a tenderness, and you are going to think in terms of the torsion testis. That is one of the most important and the vital diagnosis we need to make when you are dealing with the swelling with that. On the other hand, if the testis and epidermis is definable, and you are able to swelling, and it is transluminant, you can easily say it could be a vaginal hydrocele, it could be a epidermal cyst which is coming from that. Not tender, you will be thinking in terms of not transluminant, it could be a possibility of the tumor or other lesions with related to that. So in this talk, we are going to talk with a few important topics of the headings which you are going to deal on is on the torsion testis, because it is an acute condition. The second common will be the hydrocele, and the third, I'm going to talk a few things on the varicocele, and the very few points on the testicular tumors. The first and foremost is very important, because we miss sometimes in the swelling, and considering it is an hydrocele, we will leave and take our own time, then it will be always dangerous. So we know something about the torsion testis, because this is very important for us to identify early. And all the problem is, if we can identify early, then definitely we will be able to salvage the testis, and if not, that the patient is going to lose the testis. And why the people are going to get the torsion testis? This is a normal anatomy where you are having the vaginalis or the tunica vaginalis, which is going to not entirely covering the testis. It is only covering the posterior, the part of the anterior part of the testis only is being covered by normally by the tunica vaginalis. But in a rare case where we call it as a bell clapper anomaly, where there is entire testis is covered by the tunica vaginalis, and almost by virtue of that, the testis will be having a slightly an oblique view or the horizontal view. And this anomaly of anatomy, if it is happening, if there is a testis is entirely covered by the tunica vaginalis, those people and those person will be more prone for developing a torsion. Most of the time we say that when it's after strenuous exercise, he goes to the bed and gets up with a torsion, or when there is a trauma, you can get a torsion. There's all aggravating factors, but the main factor which is involved is the anatomical abnormality, whether how much area is covered with the tunica vaginalis. If it is entirely covering, they are more prone for that. And again, in the torsion, there is two types of torsion, because what we say extravaginal torsion or intravaginal torsion, because this is very significant, because extravaginal torsion usually happens in the pediatric age group, younger age group, and where it is easily you can bring that into the knowledge, because the twist is happening outside the testis, where here the vaginalis is here, and the twist is happening outside that there, and then it is called extravaginal. But some cases where you are going to intravaginal, within the tunica vaginalis, it is going to happen. This is what the type commonly we have in an adult, because of the bell clapper deformity, and it goes for that. This is not symptomatically, it may not be feasible or see it outside. It is a little difficult. They present little late, and when the time they come to you, and by the time the testis should have been gone back. So these two things, and you need to divide whether it is a extravaginal or this can only do by an ultrasound, because what is in a Doppler, it says, in the Doppler, usually inside the testis, the intratesticular blood flow will have a low resistance and high flow. Outside the testis, you will have the high resistance and the low flow. And when you are checking the blood flow, and we will be able to see whether there is a circulation, the blood is only inside the testis or outside is affected, and that you can be able to diagnose. And what is this pathophysiology of the torsion? It goes for a twisting, it's fine. How much it is going to twist? Even the symptoms can start with just a 90-degree twist. But to say it is a complete torsion, it needs to be at least a 360 twist. But sometimes we get cases where it goes for 720-degree twist. So they are very, very damaged. By this twisting, the venous edema and arterial ischemia develops and hits in. And when you are going to clinically examine the case, and when the patient presenting with the testicular swelling, the hard testicle, no cremasteric reflux, the high riding testis, and nausea, vomiting, this is called the scoring for twist score. This scoring is used to assess and whether you are going to deal with a torsion testis or not, and the points where when there is a testicular swelling, we give 2 points. When there is a hard testis, it is a 2. Again, the cremasteric, we will come to this later, the cremasteric reflux and the high riding testis and nausea and vomiting to that. So if the duration of the torsion is less than 4 to 6 hours, the possibility of recovery of the patient is very good, but it is more than that, it is very difficult to do that. So what are the clinical signs you are going to do? Commonly we say the front sign or the testicular elevation sign, because one of the commonest differential diagnosis is going to be acute epidermoarthritis. How you are going to differentiate, elevate the scrotum. As you are elevating the scrotum, because then the scrotum is going above the level of the heart, the blood flow to that arterial blood flow will be less, so the pain will be aggravating. In the case of epidermoarthritis, which is due to the venous congestion, as you are elevating the scrotum, the veins will have, due to the gravity force, the drainage will be more and the pain will be decreasing. The front sign, the negative, is a feature in favor of acute epidermoarthritis, but it is not a diagnostic feature for torsion testis. But this test will be able to tell you to differentiate it is not an epidermoarthritis. But this test, the cremasteric reflux test, is more in favor of a torsion test. We know that when you are scratching on the medial side of the thigh, the testis will be pulled up. That will happen only in a normal thigh, a normal testis. And if the testis has gone for torsion, it will not produce the cremasteric reflux. The absence of the cremasteric reflux is more in favor of torsion, and the front sign is more in favor of the epidermoarthritis, which you are going to deal with that patient. So this acute epidermoarthritis. So this is a one picture slide I just want you to concentrate, because the three things, the patient with acute pain of the testis, it could be acute epidermoarthritis, it could be the testicular torsion, or it could be the torsion of the appendix of the testis. And the front sign will be positive. In case of epidermitis, the pain will be decreasing with, right? But the testicular torsion, the cremasteric reflux will be absent. In the blue dot sign is a feature of the testicular appendage, or when we are torsion of the testicular appendage is happening, you will have the blue dot sign. So these three are important signs which we see: front test, cremasteric reflux, and the blue dot test, and each is significant for each, and that is going to tell you and what you are going to deal with that. What is the difference between torsion and volvulus? And this is again a postgraduate question we ask commonly. What is the difference between torsion? We talk about the volvulus of the intestine, a torsion of the testis. So torsion is a twisting on its own axis, or the long axis twisting. The volvulus, which goes for a short axis twisting, but it is not twisting along the direction of the vessel. It is on the mesentery. It's the root of the mesentery. That is along the short axis. So that is a difference. We don't interchange the word. Torsion is when the twisting is taking place on the long axis, on the axis of the organ, and that will be called as a torsion. When it is happening in the short axis on the root of the mesentery, and that is called as a volvulus for that. And what is the management? As you all know, when we are able to deal with that, less than 6 hours, and then orchidopexy can be done because testis is intact. But if it is gangrene, you need to do only an orchidectomy. This is again a glimpse of the map, all that features, and whatever we talked about torsion. One is the important thing is a testicular scoring. If you do the testicular scoring, if it is the points, if it is 1 to 4 points, it is more in favor, or it is the less than that, it is high index, low index for the torsion. More than that is going to be the high index for the torsion. And similarly, and the timings, and when you are going to do the surgery, we must know. I'm not going to the details because for the undergraduate it is not much needed. Then the next important thing we are going to have is a hydrocele, and this is again a very common question. But one thing in an undergraduate examination, what we expect is in a hydrocele and a hernia, you need to say everything almost right, because it is a must know for all of you in talking of the case of the hydrocele of the hernia, and mistakes are not, accepted in the hydrocele. So as I discussed earlier, the hydrocele is a collection of fluid between the two layers of the tunica vaginalis, which is the visceral layer and the parietal layer when the fluid contains. And what are the etiology? Why there is a fluid accumulating? There are 4 reasons normally we say. One is a defective absorption of the fluid by the tunica vaginalis, because it go for the damage and endothelial infection, infertilial scarring, and you are going to the defective absorption, or you have an excessive production. And because it's a constant stimuli, you can go for an excessive production. And the third, an interference between the drainage, and your drainage is blocked, because lymphatic is what is going to take, and the lymphatics are blocked, it can be there. Or if there is a communication with the abdominal cavity. So these are the 4 reasons, the different kinds of hydrocele you can get. Either it is increased absorption, decreased absorption, increased production, the blockage of the tube, or there is a communication for that. So depending upon that, you are going to divide that into a primary hydrocele or a secondary hydrocele. Again, the primary hydrocele is going to be divided into, it is a communicating and non-communicating. So what are the component? What are the different types of the primary hydrocele? And one is a congenital hydrocele. It is connecting with that because the pattern processes vaginalis throughout the carrot. Here you will be able to feel the testis is coming. The testis may not be palpable fully. Here it is communicating from abdominal cavity to down. The next is a funicular type. The funicular type has a connection with abdominal cavity, but it stops short just above the testicular level. But the next is the most important is the infantile hydrocele. The third, what we are seeing is the infantile hydrocele. So that is a peculiar type because it is extending up to the deep inguinal ring. The swelling will be extending up to the deep inguinal ring. So you are going to have a inguinoscrotal swelling, and the swelling will cover, it comes and cover here. But the funicular type, there is no hydrocele is coming in the tunica vaginalis part, but it is here you will have like a congenital hydrocele, it comes, but the process vaginalis get close at the level of the deep inguinal ring, so there is no communicating. So congenital hydrocele is a communicating hydrocele, infantile hydrocele is a non-communicating hydrocele you are going to get. Then you have if there is a 4th variety is an encysted hydrocele. There is a connection blocked at the level of the deep inguinal ring, but there is a collection only in between the cord structure encysted hydrocele. The vaginal hydrocele, which is one of the very common thing, which is the most common type of hydrocele, is going to have the vaginal hydrocele. The rest two, the bilocular hydrocele or the hydrocele enbisag, is where you are going to have a fluctuating swelling. One is on the scrotum, one is either in the inguinal canal or in between the layers of the muscle, anterior abdominal wall musculature. That will be a cross fluctuation is there. That is going to be the hydrocele enbisag. And the 7th type is a hydrocele of the hernial sac. So these all are the different types of the primary hydrocele. And features of the primary hydrocele, you know, it will be cough impulse will be negative, get above the swelling will be positive, it will not reducible, the consistency will be tensely cystic, the translumination will be positive, fluctuation may be positive, testis is not felt separately. All these are a feature of the primary hydrocele. There are few important questions. There comes in the primary hydrocele. One is a diurnal variation. And a congenital, especially in a congenital hydrocele, the swelling may not be there always. The complaint of the mother will be the patient was apparently, the child was apparently normal. When the night, when he is waking up in the morning, when goes for the play and come back in the evening, and there is a swelling is appearing. And why it is happening? Similarly, the swelling, you will not be able to reduce the swelling, but though it is communicating, you will not be able to reduce the swelling. But when you are making the patient to lie down and sleep in the morning, when you are getting up, the swelling will be reduced. And that we call as an ink bottle effect. It's just something like that. What you are having a ink bottle or a Coca-Cola bottle, when you are pouring it down, the water will not flow as a gust of a fluid. It will come as in a slow phase. It will come. The similar effect, because the cavity communicating is very low, it will only produce a ink bottle effect. So there will be a diurnal variation in this swelling. If the mother complain about swelling, there is no swelling in the morning and there is a swelling in the night, and invariably your diagnosis could be the congenital hydrocele. The cross fluctuation, if there is there, when the patient says there's a cross fluctuation, or during examination that you are able to demonstrate cross fluctuation, it is bilocular hydrocele or hydrocele NBSOG. If the traction test is going to positive, when you are pulling down the testis, if there is a swelling is also coming down and tense, and that is definitely a sign of saying that it is an ancestral hydrocele. And if you are getting above, it is a sign of an infantile hydrocele. So among this different type of hydrocele, what you are going to have in the primary hydrocele, but putting these few important tests, and you will be able to differentiate and what kind of hydrocele you are going to do, the complications of hydrocele, all of you to know. And then it's a type called secondary hydrocele. Because of the infection of the testis, or because of the tumor in the testis, whether it could be filariasis, it could be tuberculosis, it could be syphilis, the testis will enhance, stimulate the tunica vaginale to secrete more fluid, and that you are going to get a collection in the fluid between the layers of that. What is the peculiarity? This is not a very big as a primary hydrocele. This will be not very tense, it will be more of the time it is lax. And here obviously you will be able to palpate the testis separately. And the fluid may not be a clear fluid. This is not a big one, there is a lax one. So tumor of the testis can produce hydrocele. The testis tuberculosis can produce a hydrocele. So all this infection that we call as a secondary hydrocele. And this is a difference between the primary hydrocele and the secondary hydrocele. The defective absorption is a feature of the primary hydrocele, and excessive production is a feature of the secondary hydrocele, and the different size it reaches that. And there is a separate variety called hydrocele of the canal of the neck. Hydrocele of the canal of neck is nothing but a hernia in a female, and it is occurring at the site of the inguinal canal, at the superficial inguinal pouch. You have a swelling. It is most of the cystic swelling, though it is called as cystic swelling. There will be condensed like ovarian tubes or ovary can be there, and this we call hydrocele of the canal of neck. And this is a bilocular hydrocele or the hydrocele NBSOG, but I told earlier there will be a cross fluctuation will be there. It will never recur spontaneously. Spontaneously resolve. So you need to do a surgery. There's another carriage called hernia, hydrocele of the hernia. The hernia contents are there. It is not reducing, getting obstructed hernia like features or irreducible hernia. From that hernia, the fluid can secrete or more fluid will come. That will form a separate collection that is called hernia of the hydrocele. But equally we have, this is all hydrocele of the hernia. Equally we have hernia of the hydrocele when the large hernia, what we see here, there is a large hernia which extends through the dartos muscle, and the swelling is coming out, that we call the hernia of the hydrocele. What you are going to see here is a hydrocele of the hernia. So this is a two terms which is must be all different. So congenital hydrocele, filial hydrocele is another term which we see especially in our practice, especially in the coastal belt. We see 70 to 80% of the hydrocele. What we are seeing is a filial hydrocele. So these are the few important tests which you know that when you come for the examination, we are not going to rest all the features, but if have you done these tests is very important. Getting above the soli, holding the cord structures above the testis is the getting above the soli. Doing a translumination, this is a one test all of you should be able to know. But one of the fallacy which there when you are putting the torch in the posterior aspect of the scrotum, the testis will obstruct and you may not be able to see the light. It should be always in a transverse direction. Your vision and the light should pass through the same line, and this is the one test we should do. And the fluctuation test, this is a very important, and when you are eliciting, and when we ask the undergraduate, most of the time they don't do. It is something like you hold the testis, the scrotum, fixing the scrotum with your two fingers, you fix it, and put your finger here, and if you press here, it should go up. That finger should be lifted up. When you are pressing here, this finger should be lifted up. The fixing, making the swelling tense, fixing the scrotum is the most important first test in the fluctuation test. So you can use two fingers to fix the swelling, then use the next two fingers from here. Compress on one end, you will see this finger is lifted up, and compress on this, you will see this finger is lifted up. And without making the swelling tense, and you can never do the fluctuation test. And if you can do the properly the fluctuation test, that will definitely give you a lot of good. The hydrocele fluid, you know. But again, this is another problem what we have. What is congenital hydrocele? What is congenital hernia? Both are same or both are different. They have the same etiology. They have the same treatment. Then why we should have two names? For that, you should know the definition of the hernia. Hernia is a protrusion of the part of the whole of the viscus. Hydrocele is only the collection of fluid. So though there is a communicating, there is a cavity. If only fluid is coming and accumulating, you call it as a congenital hydrocele. If there is an opening, if there is a condensed bowel or condensed the abdomen is also coming, we call it a congenital hernia. Because this is very significant, because even if you make a diagnosis the congenital hernia, the treatment is going to be herniatomy, and even if the congenital hydrocele, the treatment is going to be the herniatomy which we are going to do. Is it children? Is the surgery is mandatory, and especially when communicating a cavity with a communicating type, if you are having the congenital hydrocele, definitely you need to do a surgery. But if it is non-communicating type, in first year of age, you are seeing it is confined only to the scrotum. It is a vaginal hydrocele, non-communicating type. There is no need of early surgery. But congenital hernia, you need to operate early because strangulation and obstruction are more common with the congenital hernia. So not like an adult, we will not wait for that. Once you diagnose it as a congenital hernia, it is important of that you need to do the surgery immediately. If it is a congenital hydrocele, the primary hydrocele, if it is a congenital variety of communicating, yes, you need to do the surgery. If it is not communicating, we can still wait for that. You know the different types of surgeries, all of the surgeries you know. Next important one is epidermal cyst. What is the difference? Hydrocele is in the anterior part, epidermal cyst in the posterior part. It produces a brilliantly transluminant cyst, and if the cyst is more in the posterior part, you need to do the excision of that cyst. The next commonly is a varicocele. May not be the case, will be kept for the undergraduate, but unless it is a very high-grade tumor, high-grade type, that is a type 3, when it's a large visible gross enlargement, we may keep you for that. This picture you must know how the pampiniform plexus goes. The multiple pampiniform plexus start here, it comes through the superficial wing, it will be 5 to 6 veins will be there. When it comes to the deep inguinal ring, it will have only 2 veins, it goes up and connect there. And once you make a diagnosis and you need to do a surgery depending upon for what purpose, if it is the pain or for this is a bag of worm appearance. For the people like this, either you can go for a surgery can vary from this, but nowadays embolization is being done as a thing. What is most important? And you need to differentiate whether it is a primary varicocele or a secondary varicocele. How you are going to differentiate? Primary varicocele will be there only when the patient is on a standing posture. Secondary varicocele will there even when he is lying down. So both in a standing posture and lying posture, if you are able to demonstrate the varicocele, that means it is a secondary. What is a secondary? It could be due to the retroperitoneal tumors. It could be due to the other causes of it could be from especially when you have a varicocele on the right side, or when you say that varicocele is a secondary, you need to do investigation and you need to do the surgeries for that. So these are the commonly the tumors and swellings which we are going to get there. Testicular tumor is one aspect where the undergraduate, we don't keep the case much, but only when, please remember the testicular tumor is a variant, it can present like anything. But in a age group of a second or third decade, when you are having a swelling, you need to, depending upon the weight, depending upon the sensation, you need to make a diagnosis for that, on that. Finally, you must also remember when you are dealing with the testis or the scrotum, watering can perineum. This is one feature which the gonococcal infection can produce. Second is a sinus in the scrotum. When you are presenting a case, don't routinely say there is no sinus, no fistula. You will never see a sinus or fistula. In modern days, it is very difficult to see a sinus. If at all you are going to see a sinus on the anterior part of the scrotum, it could be a syphilitic. But nowadays we don't give a syphilitic testis because anteriorly the tuberculosis is the testis is the last part of the body to be affected in tuberculosis. If there is a sinus in the posterior part, it could be a tuberculous sinus because epidermis is what is involving. But when you are going to have a multiple sinus and you are going to have the gonococcal infection or other strictures, because once the urine is coming out of the urethra, it is covered with the Colles fascia, it can come through multiple holes, you will be able to get through that. Though we say that scrotal swelling is always a very simple swelling to deal with, to make it a difference. difference, whether it is what type of hydrocele, whether it is an torsion, whether it is an epidermoarthritis, whether you are dealing with a tumor, it is needs an active and the intervention and active participation, active way of diagnosis then, and definitely you will be make a difference in your treatment part of it. Thank you very much for your patience here.
Thank you, sir, for enlightening undergraduate and postgraduate students. As an anesthetist, in an anesthetist point of view, most of the scrotal cases we take under regional anesthesia, except for lab varicocelectomy, we take the case under general anesthesia, sir. Thank you, sir.
Thank you, sir. That was an interesting session filled with interesting, important key points. With great esteem, I request the chairpersons to felicitate our honorable speaker, Professor Dr. J.A. Jayalal, sir. Thank you, sir. Thank you, ma'am. Now, I kindly request Dr. Anita, ma'am, Assistant Professor, Department of General Surgery, to honor our chairpersons. Thank you, ma'am. Once again, we express our sincere gratitude to the speaker and the chairpersons.
We are going to have a very short lunch break for 15 minutes. Kindly, you can go down, have your lunch and rush fast. 15 minutes lunch break.
மனசுல திங்கள் வந்து காயும் போது என்ன வண்ணமோ நினப்புல வந்து வந்து போகுதம்மா எண்ணமெல்லாம் வண்ணமம்மா எண்ணங்களுக்கு ஏத்தபடி வண்ணமெல்லாம் மாறுமம்மா உண்மையம்மா உள்ளதனும் சொன்ன பொன்னம்மா சின்ன கண்ணு தென்றல் வந்து தீண்டும் போது என்ன வண்ணமோ மனசுல திங்கள் வந்து காயும் போது என்ன வண்ணமோ நினப்புல ఎవరూ சொல்லாமல
சௌக்கியமா நான் இங்கு சௌக்கியமே உன்னை எண்ணி பார்க்கையில் கவிதை சுற்றுது அது எழுத நினைக்கையில் வார்த்தை முட்டுது உந்தான காயம் யாவும் தன்னாலே ஆறி போகும் மாயம் என்ன பொன்மானே பொன்மானே என்ன காயமான போதும் என் மேனி தாங்கிக் கொள்ளும் இந்த மேனி சங்காது செந்தேனே எந்தன் காதல் என்னவென்று சொல்லாமல் எங்கு அழகு வந்தது எந்தன் சோகம் உன்னை தாக்கும் என்றென்றும் போது வந்து அழகு நின்றது மனிதனுனது கொல்ல இது மனித காதல் அல்ல அதையும் தாண்டி புனிதமானது அபிராமியை தாலாட்டும் சாமியே நான் தானே தெரியுமா சிவகாமியே சிவனின் நீயும் பாதியே உனக்கு புரியுமா சுபலாலி லாலியே லாலி லாலியே அபிராமி லாலியே லாலி லாலியே ஓஹோ கண்மணி அன்போடு காதலன் நான் எழுதும் கடிதமே பொன்மணி உன் வீட்டில் சௌக்கியமா நான் இங்கு சௌக்கியமே உன்னை எண்ணி பார்க்கையில் கவிதை சுற்றுது அதை எழுத நினைக்கையில் வார்த்தை முட்டுது லா 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 லா
Good afternoon. We hope you're all excited for our next session because we most certainly are. We now like to introduce our esteemed chairpersons for this session.
Dr. Jayalal Sir, Professor and HOD of the Department of General Surgery from Government Kanyakumari Medical College.
Dr. Rajkumar Sir, Associate Professor of the Department of Surgery at Tirunelveli Medical College and Hospital.
We are privileged to have such distinguished professionals with us today. Sir, please come to the dais. For this session, our very own postgraduates will be presenting cases that they've overseen under the guidance of our dignified surgery department. Let's welcome them to the stage.
Hello. Good afternoon to one and all. Myself Asha and Sindhu, third year postgraduates from TKMCH, presenting a case of gastric outlet obstruction. A 55-year-old gentleman, farmer by occupation from Sayalgudi, belonging to lower socio-economic status, according to modified Kuppasamy scale, presented with chief complaints of abdominal pain for the past 3 months and vomiting for 3 months. History of presenting illness. The patient was apparently normal 3 months back. Then he developed abdominal pain in the upper abdomen, which was dull, aching in nature, insidious in onset, non-radiating, not referred, not related with food intake. History of vomiting for 3 months, which was non-bilious, non-projectile, containing undigested food particles, initially 1 hour after food intake and then which progressed to immediately after taking food. He has history of postprandial fullness and history of early satiety. No history of ball rolling movements, no history of abdominal distension, no history of hematemesis, no history of melena and altered bowel habits. History of loss of appetite and loss of weight with significant weight loss present. History of easy fatigability, no history of jaundice, no history of hemoptysis. Past history, no history of...
Present history, what are the salient features? You said there's loss of satiety, early satiety.
Yes, sir.
And there is no ball rolling movement.
Yes, sir.
And the vomiting contains the undigested food particles.
Food particles.
So with these three, what do you think that is a problem? Where is the problem it is there?
Probably obstruction case, sir. And it is non-bilious, so it is about before the pyloric region.
Yeah, there is obstruction you said, but
yes,
there is no ball rolling movement you are saying.
Yes, sir.
So how do you explain that? And suppose you are saying undigested food particle.
Yes, sir.
Where is the level of obstruction? Is it outlet obstruction or inlet obstruction?
Outlet obstruction.
Okay. So what is the appetite of this patient?
So his decreased appetite, sir. Loss of appetite also present.
So how will you differentiate decreased appetite with early satiety?
So even a small amount of food intake, the patient was feeling fullness.
So that means he is able to take food.
Okay, sir.
So is there his appetite is good or bad? Okay. So what does it indicate? The early satiety. What do you mean by the word early satiety and what you are inferring from that point?
Even with a small amount of food, patient was
Fine,
not...
I know that. But
the thing is, initially the patient used to take some volume.
Yes,
now
sir.
the volume has decreased.
Decrease, yes, sir.
You're telling the patient is feeling satisfied.
Yes, sir.
what is the reason?
What is
Some
the reason?
outlet obstruction.
No, that is not the reason.
Outlet obstruction will not produce, there is no need to produce.
Discomfort, he might be feeling discomfort, so he's
That is different. You told satiety, early satiety. There's a physiology in the stomach. Receptive.
Sorry, sir.
You get satisfied? there is adequate distension,
Distension
of the stomach.
yes, sir.
Receptive relaxation of the stomach.
Okay, sir.
So that is lost.
Okay, sir.
So what is the reason for that?
The invasion of the mucosa, submucosal layers,
Mucosa, it is beyond that.
beyond that, sir, muscularis layer can affect the distensibility of the stomach. As such, stomach is a distensible organ, but according to when we think in terms of carcinoma, it can affect the distension and invasion into the muscle.
When you have an outlet obstruction, will the stomach be distended or contracted?
Distended.
Distended.
Yes, sir.
Then there you can take normal enough amount of food you can take. You will not feel the satiety will not be lost. You will lose the appetite. Only when it is infiltrating into the muscle, especially when the mid part or the fundus that you are going to get, you will get more of a early satiety.
Okay,
Can you get early satiety other than carcinoma stomach? What is other causes of early satiety? So when you have gist, there is
Yes, sir.
nothing is there,
Lymphomas,
it is compressing, or external compression can also there. Even a
Pancreatic.
left lobe of the liver
Yes,
can
sir.
compress on the stomach. So
Stomach.
whenever there is a distension of the stomach is restricted, you are going to get an early satiety for this patient.
Okay, sir.
So this case, because you say there is early satiety, there is no ball rolling movement, the problem is not more on a outlet obstruction. Probably that lesion may be involving the body or the antrum above. What was other findings? What is your diagnosis by the history?
So probably gastric outlet obstruction due to
So that also probably. Gastric outlet obstruction is also probable diagnosis. So that means you are having some other diagnosis. The reason for gastric outlet obstruction may be a probability.
Okay, sir.
But you are dealing with, because you have a vomiting,
Yes,
you
sir.
say that is, now you are dealing with a case of a
Gastric outlet obstruction, probably due to malignant cause.
why?
Malignant cause because the patient's age is a male, 55-year-old male.
Is it a common age for a carcinoma stomach? Is the age is criteria to say is a common age? Why not it is a peptic ulcer? 55 years man can also, because you get a benign lesion to produce an obstruction, it takes 20 years.
Shorter duration of symptoms.
Shorter.
3 months duration. He's having fatigability, loss of weight, loss of appetite, vomiting, and discomfort.
So you want to put this in favor of carcinoma?
Yes, sir.
Okay, go ahead.
No history of similar illness in the past.
Come
no
to the examination. What is the word you said? What you said? No history of similar illness.
Sir.
In the history you thinking it is a carcinoma, do you mean to say carcinoma stomach will come again and again?
No, sir.
This is where the postgraduate needs to be extremely careful.
Okay, sir.
Don't make such a mistake.
Okay, sir.
You say carcinoma stomach by a probable diagnosis and come and say there is no history of similar history in the before. You never will have that such of history.
Okay, sir.
Emphasis on risk factors associated with carcinoma.
Okay, sir.
Okay, what are the risk factors?
Sir, intake of smoking, intake of spicy food, canned food, smoked food, spirit, alcohol intake, pernicious.
Can you say what is spicy food? What is spicy food? Is the spices are good or bad? What are spices? Is it a spicy food is a feature of a carcinoma stomach? Or how do you say that? Always crumble, that is pepper, all are spices. Clove, all are good for health.
What other protective factors?
Smoked fish and nitrosamines containing
Nitrosamine.
foods.
Protective factors.
Protective factors.
Reference.
Vitamin E and selenium.
Antioxidants.
Antioxidants. Okay, right.
So nitrosamine, what is the reason? What is the mechanism of nitrosamine? What are the sources you are going to get nitrosamine?
Smoked fish and preservatives added foods.
What is the role of salt? Is it salt is good or bad?
Bad
Bad for
stomach.
stomach. What is the pathogenesis of that? So remember nitrosamine is the central compound. Most important, one is salt, which is a nitric acid, which is increasing the development that the refrigerated, unrefrigerated food that is going to that. Protective factors, your vitamin C or the fruits which are going to produce. Smoke, it is again going to produce an nitrosamine compounds. Your alcohol, it is also going to produce an nitrosamine compounds. So when you talk about the potential damage, pathogenesis of the carcinoma stomach, these nitrosamine compounds play a major role. So you must find out what are the reasons, how it is increasing, what are the factors is going to reduce the nitrosamine compound formation.
Any other infections?
H. pylori.
Also Epstein-Barr.
Can you say morphology of H. pylori?
Gram negative.
Very good.
Spiral organism.
How it survives in the stomach? Stomach has an acid medium, no?
How it lives in the acid? Where does it live?
Pylorus.
So what is the protective effect of H. pylori? It induces carcinoma of stomach, but it protects on carcinoma. It produces achylourhydria. It reduces the reflux esophagitis, Barrett esophagus, and esophageal carcinoma. So it indirectly has an effect on less incidence of esophageal carcinoma, but more you are going to have the carcinoma of this. So you should know the mechanism, how it secretes urease, how it creates an environment to survive, how it is able to live even inside the acid media.
Personal history is a chronic alcoholic and smoker, consume mixed diet. Family history, no other family members had similar history of carcinoma, any other carcinomas.
Go slow.
Summary, 55-year-old male patient, farmer by occupation with lower socioeconomic status presented with chief complaints of abdominal pain.
How do you know he is from the lower socioeconomic status?
According to modified Kupasamy.
What criteria?
Education of the head of the family.
Have you worked out?
Sir?
Have you worked out?
Yes, sir.
Or just haphazardly saying that? When you use this term, low socioeconomic status, the modified Kupasamy scale, all the 5 criteria should be put out in your case sheets. That is evidence to say that you are working out. You are asked that and you are saying that. Don't say just like that.
Sorry, sir. Presented with chief complaints of abdominal pain in the upper abdomen, which was insidious in onset, dull, aching in nature, non-radiating, aggravated with food intake, relieved with vomiting, which was persistent, which usually happened 30 to 60 minutes, a few hours after food intake. No significant past and family history, probably a case of gastric outlet obstruction.
So, but your history says there is a food aggravates the pain. You know? So,
Carcinoma.
is it a feature of carcinoma?
No, sir. No association with food intake.
But your history is in favor of that. And you are expecting the pain is not radiating. Where you are expecting the pain to radiate?
As it was in upper abdomen.
Where do you ask? Radiation? To where?
Infiltration to the
posterior aspect, if there is any infiltration of
into the pancreas or other. You can radiate the abdomen pain to back. So there was no radiation.
He has a vomiting, but there is no melena.
No, sir, no.
Again, that is in favor of malignancy or gastric ulcer?
Gastric
ulcer.
Okay, go ahead, we'll see.
General examination was carried out after obtaining a proper informed consent, adequately exposing the patient. ECOG 2, patient was conscious, oriented, thin-built and moderately nourished.
What is ECOG?
Eastern Cooperative.
Expand it.
Eastern Cooperative.
No, omission is better than commission in surgery. If you are using some words, some statements, you must know that. Without knowing what is the expansion of ECOG, if you commit, then that gives a very wrong picture on you. Your foundation is weak. Go ahead. How do you come to the conclusion as ECOG 2?
Patient is able to carry his daily activities.
Then ECOG 2 it is? Is it ECOG 2?
ECOG 2 is patient is comfortable at rest and not able to carry out his daily work
What is that
activities.
ECOG? That comes only ECOG 1. What is the Kornowski? What is the correspondence of the Kornowski score? Okay.
Patient was conscious, oriented, thin-built and moderately nourished, afebrile, comfortable at rest with mild dehydration.
You have a photo of the person? You have the photo?
Sir,
You have the patient's photo is there?
Abdomen photo.
Now, how do you come to the conclusion he is thin built?
Photo.
How do you make? He has what criteria you use to say he is a thin built?
BMI.
What is built?
Medam circumference can be. Medam circumference.
That is nourishment. Just because he is a patient of a carcinoma, he doesn't need that he has to be a thin built. In a scientific term, built is a skeletal architecture. Somebody who is morphon, somebody who is a dwarf, somebody who is a phocomelia, then you have that built is abnormal. Nourishment, how do you make out?
Medam circumference.
In adult, Medam circumference, okay, Medam circumference. Then you must know what is the normal Medam circumference. What are the areas you look to see the nourishment? Supraclavicular fossa, the palm, the dorsal of the hand, where the tendons will be very prominent and burrowing of the space. This space, the supratemporal region. These are the regions where you will see the hollowness. Then you must look for all the vitamin deficiency, all that, then only you want to commit on the nourishment. This is not a statement just like that you are going to say in the postgraduate examination. You must have a criteria to say that what is the built and what is the nourishment of the individual.
Palar plus, no icterus, sinus, clubbing, generalized lymphadenopathy or pedal edema. So by patient vitals, BP is 110/60, measured in right upper arm, pulse rate 88 per minute, regular with normal volume, respiratory rate 14 per minute, abdominal girth is 84, BMI is 20.1.
So you are expecting a carcinoma stomach, no? Have you looked for any cutaneous manifestation of the carcinoma stomach?
No.
What are the cutaneous manifestation?
Migratory thrombophlebitis.
Migratory thrombophlebitis for carcinoma stomach is very, very rare presentation. Anything can happen, but that we say more for a pancreas and type of tumors, you are going to get a migrating thrombophlebitis.
Acanthasis nigricans, lesser Trellard syndrome.
Lesser
Patient have
Trellard
erythema.
syndrome. Very good.
Erythema over the palm.
Acanthosis nigrans. So where do you look for it?
The
neck.
Neck. Very good. So all this, when you are suspecting that, the cutaneous manifestation, you should look in the general examination because you know you are suspecting this and you are going to look for any obvious manifestations of the GA malignancy is there. Good.
So per abdominal examination, inspection, patient examined in supine position, fullness seen over the epigastric region, umbilicus and midline inverted and no nodules around the umbilicus.
So what was your position? Patient was in supine. You are?
The standing right side of the patient.
So where was the patient? Patient is the bed or patient is the examination table?
Examination.
Good.
All quadrants moves equally with respiration. Skin over the abdomen was normal. No VGP or VIP. Hernial orifice free. External genitalia was normal and left clavicular fossa, supraclavicular fossa was free.
No, how do you
have a fullness in the upper abdomen more than the umbilicus? What should be mentioned in relation to umbilicus?
Obviously the distance is
seen, but they are saying what
they have to say.
They have to say that.
And your picture hides all the inguinal regions. And you said hernial orifices are free. How? With that cloth cover. Examined? hernial orifices, femoral canal? Because I don't think that with this picture you can see the femoral canal. Okay.
Umbilicus, what you should say? Whether it is in relation to the fullness in the upper abdomen.
Umbilicus not moved down.
Midline position of the
Midline is whether it's
not
not
shifted
to
to right or left.
That is
Yes, sir.
It will never get shifted.
Okay. More than that,
Slit. Shape of the
no, whether it is above or below, where it is exactly located.
What is tennial sign?
cranial side. Sir, in the case of any swelling in the upper abdomen, the umbilicus will move down. Whereas in the pelvic swellings, the umbilicus will be.
I was asking the same.
What is the inspection? What is the shape of the abdomen? You have not mentioned about the shape of the abdomen. What is the shape of the abdomen? That is the first sentence you need to say then.
Flat. So the fullness was present in the epigastric region.
So it is flat. Something else full. I don't know. Mathematically, flat means everywhere it should be flat.
Distensions in the upper abdomen.
Okay, sir.
And you said all quadrants moves equally.
Proportion.
Is it normal? Is it equally all quadrants moves? When you have something in the abdomen, large swelling, it moves equally. You must only use the word, sir, I said, proportionately it is moving. It's not equally.
Okay, sir.
What movement? Up and down and up, side to side. What is the movement you are looking for?
Up and down.
Up or down?
Up and down.
Up. Are you going to look the up movement? In the thyroid, what movement you are going to look?
Deglutition.
That is up or down?
Up and down.
Not up and down.
Up.
Down is not we are going to.
Moves
It is
up.
moves
Moves
up.
up. Yes, sir.
But abdomen? So moves
out.
down. You are not going to see the moves up is not important. When you are inhaling the breath, then how much it is moving down. That is what proportionately it is going to do. So abdomen is moving down. Thyroid it is moving up. Okay.
Palpation, abdomen warmth, tenderness present over the epigastric region, a vague mass of size 5 cross 3 cm noted over the epigastric region, 2 cm below xiphisternum, 3 cm from above umbilicus and 1 cm right of midline and 1 cm left from the midline. It has an ill-defined margin, surface of the swelling is smooth, it is firm in consistency and moves with respiration. Upper border is palpable and it is able to insunate fingers below the costal margin by finger insunation test. An intrinsic mobility, it moves both vertical and horizontal direction, no guarding or rigidity and no organomegaly present.
What do you mean by abdomen is warmth? Is it normal or abnormal? Normal or abnormal?
Rise in temperature should be mentioned.
No, that is fine, but you have said it is a warmth. So it is normal. All of us are warm-blooded animals. So abdomen warmth is a normal phenomenon. There is nothing wrong in saying abdomen is warm. But it is wrong to say abdomen is not warm.
Okay, sir.
But if you want to say the temperature, you must say only the local rise of temperature.
Okay, sir.
And what is epigastric region?
Just
What do you mean by epigastric region? You have said that the mass is in the epigastric region. No?
Yes, sir.
So what do you mean by epigastric region?
Therefore, the abdomen is divided into 9 quadrants.
That I don't know. Only the boundary. For the epigastric region, boundary.
Right and left mid-clavicular line and
transpyloric.
above the transpyloric line.
What is the transpyloric line?
The ninth, the tip of the ninth costal rib, the line joining the tip of the ninth costal.
The swelling is only in the epigastric region? And the second sentence you are saying it is 3 centimeter above the umbilicus. So the distance between ninth intercostal and umbilicus is so much. So be careful, epigastric region and right hypochondrium regions are very small regions. The swelling cannot, when you see such a swelling, it cannot get to that. You might say primarily occupying epigastric region and extending to that. For a postgraduate, for heaven's sake, don't say 2 centimeter from there, 3 centimeter from here. All that is not needed. It is going to alter your diagnosis or your if you say it is epigastric region, that is fine. All of the examiners know the boundaries of epigastric region. So please mind to that, like hernia or this, don't come and say 5 centimeter from this line, midline, 2 centimeter from, that is not needed in a postgraduate examination. Go ahead.
Percussion, liver dullness not obliterated and no shifting dullness present. Auscultation,
Liver dullness
not present, sir.
not present.
Liver not
No,
obliterated.
No, liver dullness not obliterated and no shifting.
Are you dealing with an acute abdomen? Is it your case is an acute abdomen?
No, sir.
The liver dullness obliteration is a feature of acute abdomen to rule out perforation.
Air and diaphragm.
Here your intention is not whether there is a perforation or not.
Liver span.
Liver
What all you have to say? You should say the
Liver span.
Liver span. How do you do?
So percus from the second intercostal space downwards in the midclavicular line, and
A dullness overheard from the fifth intercostal space. A dullness is heard over from the fifth intercostal space.
and it becomes the dullness is
No. Next what you are reached up to the fifth intercostal space. There you are seeing the dullness.
dullness till even if the dullness is continued below the costal margin.
How will you do liver dullness or the liver span? How will you measure? Is it on a vertical direction or it is going to be an oblique direction?
Vertical.
There's nothing wrong in vertical, but please remember when you are going for a vertical, the span is very low. It will come to 7 or 9, but original liver is like this. We need to measure in an oblique way. So from the fifth intercostal space on the midclavicular line where you are getting the node, you need to go towards anterior axial line. The percussion should go towards the anterior axial line. That distance you should measure as a oblique span. It is not the vertical span of the liver. Liver always you measure by the oblique span. That is what you come up to 12 or more than 13, you are going to say it is enlarged.
Okay, sir.
Auscultation, bowel sounds present, succussion splash heard, and auscultar percussion, greater curvature lies 2 cm below umbilicus, and left supraclavicular fossa is free.
What is supraclavicular fossa? What do you
It is
mean by left
between the
supraclavicular fossa?
two heads of sternocleidomastoid.
So what is in the posterior triangle? That is not supraclavicular fossa? So what is your intention? Are you going to see the supraclavicular fossa or between the two heads of the, what is that space? Or what you are going to do then?
To see for the nodes, trochus and Virchow's node enlargement.
So you are going to look for Virchow's node.
Yes, sir.
So you are going to say that this Virchow's node is not free. When you say supraclavicular fossa, this node, Virchow's node belongs to what group?
Fourth.
4B. In a carcinoma's breast, you can get 5 also. So that is also supraclavicular fossa.
Okay,
Here you are thinking in terms of stomach, you are going to look only for the left Virchow's node.
Digital rectal examination, normal sphincter tone, no mass or no nodules palpable, normal fecal staining plus.
What was the sphincter tone? Which sphincter you measured?
External.
You said sphincter tone,
Normal external sphincter.
external sphincter. What is the tone you measure? What is the resting tone? What is the squeezing tone? No, both tone you need to measure. You need to see the resting tone and squeezing tone. That is by the external sphincter. So internal sphincter is going to for the resting tone. So which tone you measured or not measured? Or not done PR? Okay, go ahead.
So other systems, normal S1, S2 heart, respiratory system, bilateral air entry plus, and CNS, normal function.
Okay. What is your diagnosis?
Diagnosis: a gastric outlet obstruction, probably due to carcinoma stomach, without any evidence of.
So how do you say it's gastric outlet obstruction? Have you done any other test?
Try any other test. You are told that it's marking the stomach below the umbilicus.
Auscultar percussion.
So it is dilated, obviously.
Yes,
Any other thing you did to say that there's obstruction?
You said no ball rolling.
Ball rolling
movements.
movements.
Then have you done any test?
Succussion.
Have you done it?
Yes, sir.
You have not mentioned. You have mentioned?
Did you take?
Okay, okay.
That is mentioned.
Suction
Did you
plus
take
head.
Any effort to demonstrate that VGP?
Giving 1 liter of water.
What has happened to VGP?
Sir, VGP.
Present or not? No, you have mentioned that somewhere.
Yes, sir, before.
VGP?
No VGP,
No VGP.
No VGP obviously, but did you take any, did you give water and see?
Yes, sir.
So what is the inference you are going to get? You say obstruction, no VGP. How will you explain?
And the stomach is also dilated.
What is VGP?
Visible gastric peristalsis.
From where to where? What do you? I'm not
From
asking
left
expansion.
to from left to right.
So it
sir.
starts in the left.
Left.
Then
And ends at the growth. Where the growth is, it.
then what
ends at-
happens?
Again,
No, what is happening to that after that?
forcibly pushing to that lock.
Yes.
After that, what happens? What happened to the waves?
It cannot
No,
disappear.
no.
It cannot disappear. What is happening there? So it's you said already the stomach is dilated. It is slowly diffused back here.
Okay.
Back and then it disappears again to
Distending
restart
the-
again.
So VGP is good or bad?
Function is?
A patient who comes with obstruction with a good VGP. Another patient like this having no VGP. Whether it is good or bad to have a good VGP. VGP is always a good because VGP says the muscles are intact.
Intact, yes, sir.
It is not infiltrated into the muscles.
Muscle, okay,
So you must be happy with that VGP.
Okay, sir.
When the muscle is infiltrated, the dilatation is in a question mark. That's
Yes.
what I'm asking still. Are you sure it is extending
Dilate.
below the umbilicus?
Yes.
So what is your, we have, time is over. What is the, how do you manage quickly?
So first I would like to confirm the diagnosis by upper GI endoscopy, sir. And then as we are
You do ultrasound first or endoscopy first?
Sir,
You do,
confirm the diagnosis, sir.
no, no.
Endoscopy.
Will you do ultrasound or, so suppose if the ultrasound shows it is a, so you have only a feature suggesting there's something is there obstructing.
Okay,
It could
sir.
be a cyst, it could be a pseudopancreatic cyst, something can obstructing there.
Okay, sir.
So always the original thought, 10 years back we were saying a hollow viscous, you must do upper GI or colonoscopy. Now the this accepted is, first is ultrasound. Ultrasound is your stethoscope for a surgeon.
Okay, sir.
So always go with an ultrasound, then you are going for your
Endoscopy.
Upper GI
GI
endoscopy.
endoscopy, sir.
okay.
And,
What was the finding in your case?
sir, growth was present in the pyloric region, and biopsy was taken. The biopsy report was.
Describe the growth, circumferential or only the wall, outlet obstruction,
Describe the what type of growth?
whether it is able to pass or not able to pass.
What is the pathological type? Is it a proliferative growth, ulcerative growth,
Ulceroproliferative lesion.
ulceroproliferative lesion?
Uh,
But severe ulceroproliferative has no melena. Okay. So you are done. Then what do you want to do? You have done a biopsy. What is the next level? You have done now. Confirm the diagnosis as a carcinoma of the stomach. Then
Staging.
staging.
Staging, sir. For that CECT abdomen to see the extent of the tumor and to see whether it has incision with the surrounding structures,
Other
nodal
than
involvement.
ultrasound, what is the other finding the CT is going to give to you? You already done
No.
ultrasound.
Yes, sir.
Adjacent structure, infiltration to the adjacent structures.
Extent of the
That ultrasound can also tell you whether the liver is involved.
extent of the tumor.
That's the only indication we do is peritoneal metastasis.
Okay, sir.
All other things, two things. One is peritoneal metastasis. Second one is isoechogenic node. That is quite rare, but you can say isoechogenic node ultrasound may not pick up. But peritoneal metastasis, the ultrasound may not pick you. CT can help you. But the final diagnosis, laparoscopy.
Lead.
Laparoscopy
Yes,
is
sir.
going to be there. So what do you do for the confirm? What is your staging? What is the stage of your? You have done all the investigations. What is the stage? You're not done.
CT, there is no finding. What is the finding in the CT? No ascites, no liver secondaries, nothing is there?
Sir, investigating.
It is still under investigation.
Yes, sir.
So what is your plan? Now it is an antral growth, ulceroproliferative. But suppose it is a stage 3 tumor.
Adenocarcinoma.
Adenocarcinoma, stage 3.
Sir, we have to go for a D-lab first, sir. So,
For what?
so operability of the tumor first be
No.
seen.
No, not for operability.
Peritoneal
metastasis.
So you must do the peritoneal
Peritoneal.
toileting, and because most of the time it is the stage T3 lesion, it will upgrade. So that is going to help you. So the D-lab is mandatory for T3, T4 lesion to assess the grading, upgrading the lesions or not. Okay. What do you mean by operability?
Any mets in the liver. If
Nowadays, everything is operable. There is nothing called resectability is different, operability is
Operability.
different, curability intent is different. So what do you mean when you say operability means what?
if it is fixed to the surrounding structures, or if there is a mets.
So you go there, there's a surrounding is fixed, then what you will do?
If it is patient in an obstruction, we should do
Palliative procedure.
palliative drainage procedure.
So if patient is not in obstruction,
Palliative procedure.
why do you want to do palliative? Nowadays we have a plenty of good drugs. You have a monoclonal antibodies, you have a good chemotherapy. So pre-operative
Downstage
neoadjuvant therapy you should
and
stop.
downstage the tumor.
So I would have expected happily if you say stage 3, you'd say I will go for a pre-operative neoadjuvant therapy. Now like a breast, stomach also pre-operative neoadjuvant therapy is a mandatory requirement. You put the patient, then go back and do a surgery. So what surgery you will do?
find trauma. In a case of handlebar injury of pancreatitis, we can see contusion in the epigastric region. Then any protrusions, an obstructed hernia caused with abdominal pain. Any signs of trauma, bruising or swelling may be there, abdominal distension may be there. So sometimes child may complain pain in a case of herpes zoster. We have to strip off the child, we have to look for any other pustules in the abdomen. Another thing, most common thing in an 10 to 12 age group is rectus sheath hematoma. The child will go for exercise or like silambam and the pain will be classically localized to the infraumbilical region. We have to suspect rectus sheath hematoma, which is missed in ultrasonogram. But if we elicit the pain, it will be there. Renal anomalies are issues, then only we have to do it. Otherwise, nowadays textbook says routine digital examination is not allowed because they say that it is a violation of privacy in your children because they cannot consider. Only if you suspect any other things, we go to digital examination. Special tests, there are number of special tests for each differential diagnosis. Investigation, blood investigation, they all give to the clue. If the total count is elevated, you have to suspect any some maybe. This eosinophil elevation is a very important. No other finding will give. Eosinophilic gastritis is there in children. Eosinophilic colitis is there, and eosinophilic cystitis is there. If eosinophil is elevated, we have to look for absolute eosinophil count and treat accordingly. We can treat it easily. Antihistaminic and steroid will do that. Then X-ray abdomen. This is more important than ultrasound abdomen in a pediatric surgery age group. Because supine X-rays are allowed. We have to see multiple air. We can see multiple air fluid level. Dilated bowel can be seen. Bowel wall thickening may be seen, and the pneumoperitoneum can be seen. So X-ray abdomen is extremely important. Ultrasound abdomen, we all know it is the first screening examination. Here the catch is about mesenteric adenitis. In all children with abdominal pain, they are called mesenteric adenitis. When the mesenteric adenitis, it is very difficult to differentiate between mesenteric adenitis, appendicitis, and terminal ileitis. These are all comes under a single group because RIF pain will be there. When you send to the sonologist, they will give probe tenderness. They are eliciting a tenderness using a probe. There is no difference between hand and ear. They won't give any clear-cut diagnosis. So what is mesenteric adenitis? At least 5 millimeter node must be there along with edematous ileum of 3 millimeter length for 5 centimeter distance without which of inflammation. This is mesenteric adenitis. Once mesenteric adenitis is given, we have to look for the cause. The causes may be bacterial, viral, protozoal. Here one point is, the main point is, Western countries and in advanced economies, the most common cause of mesenteric adenitis is first viral, then only is Yersinia enterocolitica. This Yersinia enterocolitica is oral antibiotics. We have to admit the child and give aminoglycosides. Then only Yersinia recover. So the pain is very severe in that affluent age group. We have to sometimes admit the child and treat the abdominal pain. Another common cause is all bacteria can cause. Streptococcus, Staphylococcus, H. influenza, Salmonella, all can cause this mesenteric adenitis. Then contrast study. This contrast study is useful to rule out GERD, any obstruction, malrotation. Sometimes in the case of barium enema, in the case of Hirschsprung disease, which may cause abdominal pain and abdominal distension. The contrast study may not be useful to rule out ultra-short Hirschsprung diseases, which is clinically suspected. Then MRI, the role between CT and MRI. In children, it is easy to take MRI because it needs doesn't need a restraint. Child won't sleep. For a child to be taken to the MRI room, it has to be sedated. So it is very difficult easy to take an MRI. So pediatric surgeon usually rely on ultrasound and X-ray only. Then this is a flow chart. This is to rule out symptom. If fever, there is you have to suspect infection. Then according to the localized pain, you investigate. Then if it is left-sided pain, it may be constipation, ovarian torsion, mid-segment pain. Then if it is hematuria, we got to suspect renal calculi, renal trauma, urinary tract infection, like that. Then this is the most problematic region. This is called functional abdominal pain. This is very common in children. Almost 50% of the child presenting to the OPD will be abdominal pain, will be the functional abdominal pain. Functional abdominal pain is a very common disorder. Around incidence in the Western countries is 15%. In our country, around 15 to 20%. It will be mostly in 10 to 12 year group. These people will be, there will be stress will be there, or there will be emotionally unstable children. This may be. This appears to be sensation of the normal physiological sensation resulting in visceral hyperalgesia. There is an axis called gut and brain axis. The brain localization in the brain is in the post-central gyrus. The neuron will be hyperactive there, so it may be sensing even very trivial sensation like taking food, mild abdominal distension, some small bloating. This is very, very common. Another, it is commonly found in females who are emotionally unstable. Subtypes of functional abdominal pain include IBS, functional dyspepsia, abdominal migraine. Then what is IBS? IBS is difficulty in bowel movements, whether constipation, diarrhea, or both, along with bloating, along with crampy abdominal pain. This is irritable bowel syndrome. These are all vague diagnoses. It's very difficult to diagnose. If there is no other complaint, we have to go for this type of diagnosis. There is no child comes repeatedly to the OP. The Rome 4 classification says IBS, I think 3 months intervals, 3 pains, I think. The 3 episodes of pain every month for 3 months, I think. Then if the pain is episodic, associated with headache or migraine-like feature, photophobia, nausea, we got to suspect abdominal migraine should be considered. These are all very, very rare diagnoses. Sometimes mothers will say, வயிறு வலி வந்தாலே பையன் வந்து சுருண்டு படுத்து முகத்தை முடிக்கிறான் அப்படிம்பாங்க. Then we have to suspect this abdominal migraine. Management of functional abdominal pain. We have to give selective serotonin reuptake inhibitors or fluoxetine, tricyclic antidepressants like imipramine and amitriptyline. These are all last line of management. First, we have to give anti-spasmodic medications such as dicyclomine, hyoscine. Now, drotaverine is there. Non-dietary and non-pharmacological approaches plays a major role. They are cognitive behavioral therapy. We have to ask the child and send the child to ask the child and explain about the causes of abdominal pain. Then hypnotherapy may be there. The biofeedback therapy may be there. This may be useful in dyssynergistic constipation or functional constipation. This biofeedback therapy is important. Then lifestyle changes, stress reduction, osteopathic manipulation. This osteopathic manipulation is nothing but massaging. Good massage relaxes your muscle, then the child becomes normal. Yoga and meditation. Another point about this medication. Some papers say for this vague abdominal pain, we have to give drotaverine, which is a phosphodiesterase 4 inhibitor for a very long period of time. They say that to prevent recurrence, we have to give that drotaverine for 2 to 4 weeks time. Then only the child will respond. So we have to think that the medication may be needed for a long time. Then the Rome criteria, diagnostic criteria for functional abdominal pain, at least 2 months, 4 times per month. Episodic or continuous abdominal pain that occurs solely or during physiological events such as eating or menses. Insufficient criteria for other GI disorders including IBS, functional dyspepsia, and abdominal migraine. This functional dyspepsia is the pain associated food present within the epigastric region, and tenderness in the epigastric region is functional dyspepsia. After appropriate elevation of the abdominal pain cannot be fully explained by any other pain. எதுவுமே இல்லைன்னா functional abdominal pain. அவ்வளோதான். Then key points. These are all very important. determine if the abdominal pain is acute or chronic. இன்னைக்கு வந்ததா தொடர்ந்து சொல்றதா அப்படின்னு பார்க்கணும். Then abdominal pain is acute, surgical or benign. Surgery needed or not. If it is not an surgical emergency, what are the condition? Whether we give antibiotics or antispasmodic or simple analgesics. First, if the child is pain, first line of treatment is simple paracetamol. Give paracetamol. If it is not responding, you just evaluate. This is the first step is give paracetamol. Then any red flags present. Red flags are bilious vomiting, hematochezia, hemodynamic instability. Then the child becomes restless and child becomes inconsolable. These are all red flags. Then I acknowledge I have taken many points from Land Pediatrics, from the Department of Pediatrics website, free website, and also some few papers. Thank you. You can ask any questions. This is a very, very big topic. I try to present it in a nutshell. So, any questions?
So, it's abdominal pain is a very vague. So, like the topic also very vague. So, to precisely present it is very difficult. So, sir has done a very excellent job in covering all the points. And even though he has quoted as open pediatrics, many points has come from his experience only. We can understand many of the points he has come from experience. And it was a very useful topic for pediatricians for us. So thank you, sir. Thank you for such a wonderful presentation.
Thank you, sir. I once again thank Rakesh sir for giving this opportunity.
Thank you for breaking down such a challenging subject with precision and compassion, making it easier for us to approach pediatric cases with more confidence, sir.
I now request the chairperson to facilitate the speaker.
Sir, mesenteric adenitis simply, appendix must be normal. 5 millimeter nodes must be there. At least some say, there are many classifications. 3 nodes of 5 clusters, some say. 5 nodes of 6 clusters, some say. But 5 millimeter nodes must be there. Another point is thickening of the ileum 3 millimeter for a distance of at least 5 millimeter. This is the definition for mesenteric adenitis. So appendix is normal. There is no need to do appendicectomy. The most problematic part is acute terminal ileitis. If the terminal ileum is thickened, right iliac fossa pain and tenderness is there, there is no need to do appendicectomy. Because the terminal ileitis may recur. If you remove the appendix, if it recurs, it will be very difficult. But another point is, for this type of inflammation, terminal ileal inflammation, steroids help, but it is out of syllabus. Steroids definitely help there.
Sir,
தொழில் ரகசியம் இல்லை appendicectomy we should do. Second, doing appendicectomy in a normal appendix is not advised because appendix is used in conduit in many diseases. It is used for conduit as a ureter. Sometimes it is used as a conduit for urethra. It is also useful to do appendicovasectomy in Mitrofanoff procedure. So appendix must be preserved at any cost.
Sir, only as sir said, many of the scans given as mesenteric adenitis, adenopathy, and they are giving 10 millimeter or 12 millimeter, but they are not mentioning anything about the ileal or appendix. Appendix they put it as normal, but if you do ultrasound scan for 10 babies, I am getting almost 4 to 5 babies mesenteric adenopathy.
9 babies.
9 babies, what else? See, all the babies, so appendicectomy means we have to do appendicectomy for all the babies doing scan.
Sir, appendix, if we suspect appendix, we have to do CT abdomen with IV and oral contrast. CT abdomen and IV oral contrast is 90 to 98% sensitive for appendicitis. If the CT does not say it's an appendix, we should not operate. That CT is the investigation of choice for appendix.
CT also mesenteric adenopathy means?
Mesenteric adenopathy, we have to rule out the cause for mesenteric adenopathy. This may be bacterial or viral, sometimes protozoal, sometimes also mycobacterial. So if it is mycobacterial, if the child takes raw milk like that, Mycobacterium bovis, we have to treat with the ATT. It is like that only, sir. If it is a big node, so other signs of tuberculosis are present, we can do tubercular antigen test. If it is positive, sometimes we have to give ADT.
Thank you for your professional secrets.
We're extremely glad and we thank Professor Venkateswaravan. Actually, I was amazed. Approach to pediatric abdominal pain is a big hit. Actually, I was here but he touched each and every area. Being a panelist, I wish to ask one question reverse question to our senior regarding mesenteric adenitis. Whatever the point told by Professor Venkateswaravan is already given in the slides and he talked elaborately over that also. Professor Devanand sir was not attentive at that time. So he was again asked that question to you. Once again, thanks for clarifying it to him personally also. Anyway, it's a big opportunity and that's why he told
They won't have persistent abdomen pain.
Sir, another point,
That's why I'm asking the valuable practical points to my PGs. They are going for their practice very soon after December.
well taken the question from the professor.
Sir, another point is
thank you for kindling us.
Another point is mesenteric adenitis pain will not resolve within 2 to 3 days. It will last for 10 to 15 days. It won't resolve easily. It will take a long time for a mesenteric adenitis pain to resolve.
கேட்க நிறைய சொல்றாரு பாரு, ஸ்லைட்ல கொஞ்சம் தான் சொன்னாரு.
Information is wealth for your yes, definitely, including the down table steroids. Okay. Any more questions from the floor? An excellent presentation, Venkateswaravan. Extremely happy.
Thank you, sir. Thank you.
And thank you the surgery. We all thank the surgery department for giving us the opportunity to chair this session also. Thank you all. Have a great day. Thank you.
Thank you,
Thank you,
Dr.
thank you.
Venkateswaravan, sir.
I now request the chairpersons to felicitate the speaker. I now invite Dr. Praveen Kumar sir, Assistant Professor, Department of Surgery, Government Thuthukudi Medical College and Hospital, to felicitate the chairperson. Before moving on to the next session, I'd now like you all to engage in a small activity. Guess the spot. I'm now handing my mic to Anushree Reddy ma'am.
Good afternoon, everyone. October is a month of holidays, right? So holidays means vacation. So here are a few spots in Thoothukudi which are worth visiting, okay? You'll have to guess the spots through the pictures. Anyone who guesses it correct will get a chocolate. Please stand up and answer. Here is the first spot. One person, please. Okay, correct. Next. Please stand up and answer. This one. Yes, sir, you are correct. Okay. Next. This one. This one. Any guesses? Correct. Next one. This one. Okay. Everyone said it correct. Next. This one. Anyone, please stand up and answer. It's correct. Please, someone stand up and answer if you want this chocolate. Okay, correct. Thank you.
Thank you all. Now I am excited to announce the next session, panel in colorectal malignancy.
Now we call upon the panelists.
First, we have Dr. R. Devanagam sir, Professor and HOD, Department of Radiation Oncology, Government Tirunelveli Medical College. He has 17 years of experience as a radiation oncologist and is currently working as a Professor and HOD in Department of Radiation Oncology in Tirunelveli Medical College.
Next, we have Dr. Gandhimati ma'am, Associate Professor and HOD, Department of Medical Oncology, Thuthukudi Medical College. She did her MBBS in Tirunelveli Medical College, DMRT in Madras Medical College, DM Onco in Madras Medical College, worked in various medical fields and currently working as an Associate Professor and HOD in Department of Medical Oncology, Thuthukudi Medical Oncology. She also won the National Best Doctor Award for CMCHIS performance.
Next, we have Dr. D. Amudan sir, Assistant Professor, Department of Surgical Oncology, Government Thuthukudi Medical College. He did his MBBS and MS in Stanley Medical College and MCH at Government Roypet Hospital, Chennai. He published 2 papers in PubMed Index Journal. He is currently working as Assistant Professor in Department of Surgical Oncology in Government Thuthukudi Medical College.
Next, we welcome Dr. Karthikeyan Mahalingam sir, Assistant Professor, Department of Surgical Gastroenterology, Tirunelveli Medical College. He did his MBBS in Tirunelveli Medical College, MS in Tirunelveli Medical College, MCH Surgical Gastroenterology in Madras Medical College. He worked in various fields and currently working as an Assistant Professor in the Department of Surgical Gastroenterology in Tirunelveli Medical College. He also published
Next, we have Dr. Anis sir, Assistant Professor, Department of General Surgery, Government Thuthukudi Medical College. He did his MBBS in Tirunelveli Medical College and MS in Madurai Medical College.
The panel discussion will be moderated by Dr. Dhanavalan sir, as MS Assistant Professor in the Department of General Surgery, and Dr. Sugan MS sir, Assistant Professor in the Department of General Surgery.
We welcome the panelists and the moderators to occupy the dais.
I request all the postgraduates to occupy the front seats for the panel discussion. Postgraduates who are staying outside, please come inside and occupy the front seats.
Good evening, sir. Here is the first case, sir. A case of 35 years old male presented to the OPD with the complaints of passing blood and stools for the past 2 months. History of early morning diarrhea plus and history of tenesmus present. There is no history of pain during defecation. There is no history of loss of weight or appetite. So we would like to get an opinion from different judges here. The first thing is, what will be the probable diagnosis based on this scenario from a general surgeon, Ani sir?
I'd like to proceed with clinical examination and abdominal examination, rectal examination to be done. After that, I'll come to the diagnosis.
What are the things you will have it in your mind, sir?
Maybe malignant, So without examination, I can't tell the diagnosis at the first shot.
Yes. On examination, the patient is performing well. The patient has pallor and per abdomen has no findings. And PR, we find an ulceroproliferative growth 1 centimeter from the anal verge, completely encircling the whole circumference, and upper border could not be made out. It is firm to hard in consistency and bleeds on touch. So how to proceed? As a
To start with, from the basic investigations, ultrasound abdomen and pelvis, the first thing I'll order, and proceed. Any other, like liver mets or something else is there.
Okay, sir. So now we have done an CECT with a rectal contrast. We have found a heterogeneous mass extending 2 centimeter from the anal verge and 15 centimeter upwards, and fat planes are preserved. On colonoscopy, there is an ulceroproliferative growth 2 centimeter from the anal verge up to 15 centimeters. Lesion is all along circumference, and scope is able to negotiate past the growth, and on biopsy it has come as a moderately differentiated adenocarcinoma of rectum infiltrating into muscularis propria. So what will the treatment plan from?
So this patient is
Yes, sir.
and the 55-year-old male, and the lesion is almost 2 centimeter from the anal verge, and you have done a CT. In CT, it is a long segment tumor. Have you done an MRI?
Yes, sir. MRI was done. It was a T2 hyperintense lesion in the rectosigmoid with a maximum thickness of 31 millimeters or a length of around 67 millimeters. Mesorectal tissue appears free. Distance between the lower end of lesion and anal rectal angle is 25 millimeters. No enlarged lymph nodes in mesorectal area. Subcentimetric T2 hyperintense lesion noted in the right lobe of the liver. Cori metastasis choresis.
So as per MRI report, the lesion is extending up to the rectosigmoid junction. The lesion starts from the rectum. It's a lower rectum. So almost up to 5 centimeter, it should be considered as a lower rectal tumor. But rather than MRI alone, it is the clinical examination. Combined clinical examination and MRI is going to decide the lower extent of the lesion. So we can take this as a case of lower rectal adenocarcinoma of the lower rectum, and it is a moderately differentiated adenocarcinoma. It is not fitting into mucinous and signet ring, because the three types of tumor, the response will be somewhat different. Adenocarcinoma, mucinous type and signet ring. Here the conventional adenocarcinoma, and as per MRI report, there is no enlarged nodes in the mesorectal space. And one more suspicious finding is, there is a suspicious lesion in the right lobe of liver. So with this, before starting any treatment, since non-obstructive lesion, I would like to go for a PET CT, because here there is a suspicious lesion in MRI. So we have, even then, if you do a PET CT, if it is negative, then we can take this as a case of a non-metastatic disease. Suppose if the lesion is PET positive, then it is a oligometastatic disease. It's only one lesion. But we don't know whether after doing a PET CT, we may get some other finding also. But anyhow, so with this clinical background, young male, lower rectal tumor, conventional adenocarcinoma grade 2, with this suspicious lesion in the liver, I would like to get a PET CT report before deciding any type of treatment.
Going back on this, sir, ma'am, would you explain a little bit about endocoil or a pelvic phase array MRI? Would it be better at delineating the anatomy, or a plain MRI will be sufficient?
Actually, sir, endocoil or a pelvic array MRI is useful in determining T stage, like layers of involvement, but it is not routinely used because of the cost and the availability, and moreover, mainly for T2 and T3 lesion, difference between T2 and T3 lesion. But we have to fill the gap, the rectum with some gel before taking that. If it is compresses the mesorectum, then definitely the differentiation cannot be made out between T2 and T3. So it is not routinely used. Our MRI is more than enough to detect the T stage, or endorectal ultrasound also can give the layers of a T disease. We can know with endorectal ultrasound. So not it routinely used.
And I would like,
Yes, sir.
see, previously they thought that endorectal coil will increase the sensitivity so that we can know whether it is a T1 or T2 or T3 like that. So though there is an advantage with the endorectal coil using this T1, T2, T3, but the concept of surgery in a rectum is total mesorectal excision. So this endorectal coil, if you use endorectal coil, the mesorectal fascia cannot be clearly demonstrated by MRI because of compression. So nowadays, most of the institutions, they are not doing endorectal. And one more point, this MRI also, you can take a contrast enhanced MRI or plain MRI. Some institutes prefer plain MRI, some institutes do contrast MRI. But you can do with a plain MRI of the pelvis.
Okay, sir. Sir, we would like to put
one more point.
Yes, sir.
So recent studies, the last 10 years, there is no need of endorectal coil. So it is an outdated one. We are not using this one.
So we would like to put a same question to the surgical gastroenterologist, Karthikeyan, sir. So how do you approach a patient when the patient is presenting to you with a bleeding PR in your OPD?
Any bleeding PR patient, first I will do the clinical examination, complete clinical examination, perrectal examination. If you consider this patient, perrectal growth, if you felt, your digit will not will be an accurate one. So I know this is going to be the lower rectal tumor. As R said, it is than 5 centimeter. So every workup we have done so far is good. One thing is missing is a CT chest is always there in a metastatic workup of any colon or any GIT tumors. So CT chest, CECT abdomen and pelvis, and any rectal malignancy, MRI pelvis. So everything has been done. CEA is missing, I think. A tumor marker CEA is missing. Yes, sir. There is a doubt in solitary liver lesion, a SOL lesion in liver. I will go for CT. There is two indications for PET CT in colorectal malignancies. One is high CEA. When the CEA is very high, 40, 50, you can do a PET CT, it is indicated. And there is a suspicious lesion in liver. There may be another metastasis in lung or brain. So PET is indicated.
What is the role of metastectomy in this patient, sir? Is there any role?
Definitely. Nowadays, there are so many reviews and meta-analysis. They say that if the metastatic disease is operable, definitely by doing an R0 resection, definitely there is an advantage. But there are so many approaches, whether to do chemo first or surgery first or liver first or like that. There are so many different sequences. There will be a variation in sequences depending on institutional protocol, depending upon the patient general condition. But in an oligometastatic disease, a resectable metastatic disease, role of metastastectomy is to be considered.
So what would be the criteria, sir, if it is involving the liver?
So see, if it is the one indication for PET CT, the routine PET CT is not indicated in CA rectum in this patient. But definitely, as Karthikeyan told, you have to take a contrast enhanced CT chest, CT abdomen and MRI, pelvic MRI. See, by doing MRI abdomen and pelvis is not enough. You have to do a CT abdomen also, because CT abdomen is more sensitive in picking up peritoneal metastasis or nodal disease like that. But when you are having metastasis in this routine investigations, definitely we have to go for a PET CT, because in a routine investigation you may see only one metastatic site, but in a PET CT you may get some other sites. So if the metastatic disease, whether it is liver alone or liver and lung, if they are operable, definitely we have to consider surgery at one point in time. But I already told that whether it is a primary upfront surgery or surgery after chemo, it depends upon the patient general condition and institutional protocol. But in this patient is having a locally advanced rectal disease. Suppose if the PET is positive and only this suspicious site is positive, then it is definitely resectable. So in this case, Considering his age, the sequence may vary. I will give neoadjuvant chemotherapy, CTRT, then I will do surgery for a rectum, then I will do surgery for the liver. But during surgery for the rectum, if the general condition is feasible and if it is everything is okay, you can do surgery for liver and rectum in the same sitting. But it depends upon the individual.
What would be the treatment plan if the patient is having a lung metastasis?
So now this patient both liver and lung metastasis.
If on doing a PET CT, if you are getting a lung metastasis, what will be the plan?
Then liver metastasis
Yes,
also,
yes.
both lung and liver
Both liver and
metastasis. So before going to that, lung metastasis multiple or a single?
It's a while we have proceeded with the MRI, it was a single lesion.
Madam கேக்குறபடி அது ஆபரபிள்னு எடுத்துக்கலாமா lung metastasis?
Yes, operable.
So if the patient, as sir already told, if the patient general condition is good and he is ready for surgery, if it is resectable, we can very well go with it. It is no nodes, only
No nodes.
T1 or T2 lesion, T2 N0 M1. So if the general condition is good and is young age 35 years, if it is operable, I will opt for surgery first, because the difficult situation is whether we won't know the response of chemotherapy, and if it is progresses and if it go to obstruction, then it will be advanced stage, and also if it is not responding, it will be progress. So if it is a single solitary lesion in the liver and lung, if it is operable, we can go with upfront surgery, or we can proceed with neoadjuvant chemo RT followed by surgical resection of the primary and distant mets.
So I prefer to go with the neoadjuvant chemo RT, as ours told. Sometime with the chemotherapy, the lung and liver metastasis may disappear. So subsequent PET, there won't be any metastasis, only the local disease. So one advantage, madam. It is not the symptomatic primary. There is no obstruction.
No symptom,
Colonoscopy
non-symptomatic.
entered up to the ileum. So symptomatic primary, deal with the primary. Asymptomatic primary, you can deal for the metastasis.
So what would be the ideal margin of clearance in this case, sir? Generally.
In this
General discussion.
So generally, after neoadjuvant chemo RT, the ideal distal margin will be 1 centimeter, and circumferential resection margin, CRM, should be negative, normal, and approximately 5 centimeter, if you say, is good.
If you are not doing neoadjuvant chemo,
No neoadjuvant chemo RT, distal be 2 centimeter. Any added points?
But it's once again, it's a controversy. Ideally, for upper rectal tumor, if you are able to get a 5 centimeter of distal margin, it's well and good. For a mid and low rectal tumors, some centers say even if you get 1 centimeter of tumor-free margin, it is okay. But that is to keep the patient's sphincter, that is preserved. Otherwise, no role. But in that 1 centimeter, if you are preserving only 1 centimeter, if you are giving only 1 centimeter of distal clearance to keep it intact, better you do a frozen section.
What are the indications for neoadjuvant chemoradiation in rectal malignancies?
This proved metastatic disease. First, you're doing the PET scan. Okay, PET. Then we see you're showing the solitary mets. We proceed for the solitary metastatectomy. Then is also locally advanced LABC. So you proceed with the neoadjuvant chemoradiation, undersize the tumor, and proceed with the further radiations. This is the treatment of choice.
For all tumors with any locally T3, T4 disease, nodal involvement is an indication for chemoradiation, neoadjuvant chemoradiation.
Bad biology, madam. The neurovascular invasion.
And I would like to add further indication also. It is a classical indication. The classic standard indications are already told. for a surgeon's perspective, if the lesion is in the lower rectum, suppose if it, say for example, it's 4 centimeter like that, if that is the distal lesion, by giving neoadjuvant chemoradiation, even though it is a T2, by giving neoadjuvant radiation, there is a possibility of preserving the sphincter. So in that case, this is an additional one. The second one is threatened mesorectal, that is CRM, circumferential resection margins. That threatened circumferential resection margin will be given by MRI. So in the MRI, suppose if the disease is very close to the mesorectal fascia, so in that case, you can give preoperative neoadjuvant chemotherapy. So these are additional indications for surgeon's perspective. Otherwise, the classical indication is node positive more than T3.
What would be the procedure you would like to do in this case, sir, for the scenario in which it was?
Post-neoadjuvant chemotherapy, sir.
So indication for APR, lower rectal tumors where you can't preserve the sphincter, one. Involvement of sphincter complex itself, and rarely the patient is not having sphincter function, proper sphincter function, where your anastomosis will do bad. So another thing is anal melanoma, it's a rare indication, and any dysplasia in ulcerative colitis. So for PGs, number one, lower rectal tumor or less than 5 centimeter from anal verge. I will do AP, I will go for APR. And the sphincter is involved, the external sphincter or sphincter involvement, again I will go for APR. Anal melanoma, and sphincter function is not there. Patient with poor sphincter function, you can go for APR when if you still give adequate margin. Ulcerative colitis with a severe dysplasia in the biopsy, I'll go for APR. Yes, sir. Sir, the ultra-low AR and the intersphincteric dissection are only selected centers are doing, sir. The results are very bad. The centers which are doing, only very few having the good results. So our institute, we go for APR. We are not attempting coloanal anastomosis. They behave very poor. The anterior resection syndrome, the LAR syndrome, if they develop, it is very difficult to control them, very difficult to manage them.
What are the complications of APR?
So the main complication will be the pelvic wound complication. We usually surgeon and rarely we call the plastic surgeon to do a flap cover. Otherwise we used to do primarily, and any spillage, other thing. So the perineal infection going to be the most common complication. And the second one is your autonomic nervous system. Any nerve injury, you will have the urinary disturbances and sexual dysfunction, and other thing like DVT, lung infection, other complications.
So, as usual, any surgery, perioperative, postoperative. Perioperative, the most important one is try to preserve the plexus, nerve plexus in front of the sacral promontory. Otherwise, there is a possibility of sphincter, that is urinary bladder disturbances. That's very common. And the other one is pelvic wound complications. We have to be very aware. This pelvic wound complications you have to manage aggressively. So perioperatively, absolute hemostasis, everything you have to follow.
Any special care during surgery, sir?
Nothing.
What is the role of pelvic excenteration in advanced rectal cancers?
So pelvic excenteration, actually ideally most of the time this pelvic excentrative procedures are done for recurrent tumors. Upfront pelvic excenteration is only in selected cases where there is a fistula like that, is the bladder fistula like that. But otherwise, this excenteration is reserved for locally recurrent tumors. But there should not be any pelvic side wall involvement. Suppose if the tumor is extending onto the pelvic side wall, this excentrative procedure will not be feasible. So there is no pelvic side wall extension, the lesion is localized and it is recurrent, then we can do a excentration, provided non-metastatic.
What will be the follow-up protocol in management of rectal cancer, ma'am?
Following completion of treatment, patient has to be followed for initially up to 2 years. Every 3 months, patient has to be general examination and proctoscopy up to 2 years. Up to 2 years, every 6 months, we have to do CCT abdomen and X-ray chest. After 2 years, we have to do yearly, annually for up to 1 year. We have to watch for any recurrence or metastasis.
Role of biomarkers, ma'am. Role of biomarkers in follow-up, ma'am.
Mainly we have to do in colorectal malignancy, we have to do MSI instability to know the prognosis and response to chemotherapy. So there are mismatch repair genes like MSH1, MSH26 and all. It's XR mutation. If there is any mutation in the mismatch repair gene, there will be, the results will be MSI high. So MSI high means there is mutation in the mismatch repair. So we cannot proceed with 5FU alone, single agent 5FU or capsule. For example, in colon malignancy T3N0 with high risk features, we can give single agent capecitabine or 5FU based. So we cannot give single agent 5FU based therapies in MSI high patients. So we have to add multiple chemotherapies like combination chemotherapies like Capox or Folfox. And that is mainly for assess the response to my.
What will be your advice for the family member screening, ma'am?
In rectal cancer.
Rectal malignancy.
In rectal malignancy, okay. There is no genetic mutation like in rectal cancer only. In colonic malignancy, we have expect 20% of the colonic cancers are in familial incidence. So we have to, we have to do mutation for all metastatic disease. We have to do the mutation analysis and we have to look for this. If there is a mismatch repair gene mutation, there may be a associated Lynch syndrome and all. So we have, if the patient had a malignancy with if the less than 50 years, the family members, one positive family history, if there is one positive, first degree relative is
bore cannula to line or wide bore cannula to do the hydration part. So correct electrolytes and give broad spectrum antibiotic because we have the septicemia. So take the blood culture, start the broad spectrum antibiotic like meropenem, then get the culture report, you can de-escalate. And if there is a nutritional thing, you can start the TPN or albumin. So, anything to add?
One more thing, clinical examination you have written as ICTRES, but imaging there is only one solitary lesion. So it's contradictory. Whether the patient is in sepsis, I don't know. Definitely if the patient is in sepsis, definitely the ICTRES will be there. So we have to intensively resuscitate the patient. At any time, any point of time, this patient may need a emergency procedure. So ideally, for disease like this, for a disease presenting in an acute condition, one size does not fit all. It should be a tailored treatment. So suppose if you are able to optimize the patient hemodynamically, then you can plan something. Suppose if you are unable to optimize the patient even with your great care, then definitely you have to go for some procedure. So in that case, the least toxic procedure is a diversion. The second one will be a Hartmann. The third will be the primary resection and anastomosis, with or without covering ileostomy or a colostomy. So already ICTRES, patient is 65, definitely we have to do LFT and we have to mainly see the albumin level and bilirubin level. If the patient is in sepsis, try to resuscitate, try to achieve hemodynamic stability as early as possible. You have to do surgery if the patient is not improving. Suppose if the patient is wonderfully improving, then you can plan electively, otherwise you have to go for an emergency. During emergency, depending upon the situation, if the patient is hemodynamically fragile, just to do a colostomy. Suppose the patient is okay but not very fit, you can do a resection of the tumor with the Hartmann procedure. Suppose you are able to achieve hemodynamic stability, patient is okay, and if you are confident, you can go for a primary resection and anastomosis with or without colostomy. So in this case, you have given the small intestine also dilated. So that means this is not a case of closed loop obstruction. So when you are doing surgery for a closed loop obstruction, you have to be very careful. Suppose if the cecum is dilated more than 10 centimeter, sometimes you may have to do a extended right hemicolectomy, removing the colon also. So during surgery, during emergency surgery, depending upon the patient condition, you tailor your treatment. There is no blanket rule.
Is there a role of vitamin K in this patient, sir?
Yeah.
Is there a role of vitamin K in this
You
patient?
can give vitamin K. Before that, you can do a PT-INR, the coagulation profile. That is okay, no need of vitamin K. You can proceed.
Treatment we have discussed. Sir, in an obstruction, can a minimal invasive surgery can be tried, or what are the results?
So definitely minimally invasive is better than open surgeries in stage 0 to 3. It is evolving everywhere. Only the availability matters, the endostaplers, this is the thing. So first thing, the patient will feel less pain. So early recovery, less hospital stay, and DVT, surgical complications are less. But when you ask the oncological outcomes, it is similar to open surgery. Morbidity and mortality similar to open surgery. So minimally invasive, yes, will give a better results. Not oncological outcomes or not with the morbidity and mortality, but it is better for the patient and yes.
What are the principles of
This patient, Anish is asking, I will do a lap colostomy. Patient is fragile, emaciated, icteric, and obstruction which can't be relieved. So I will do a loop transverse colostomy for this patient with a lap, with a small port will do that. So I will come out. Yes.
For this patient, as Karthikeyan told, suppose if the patient is anesthetically, if the anesthetists are giving anesthesia and the patient is hemodynamically unstable, a lap colostomy is it will give less stress to the patient than an open colostomy.
you are planning colostomy alone.
So what are the current guidelines regarding the chemotherapy in a metastatic disease?
So it's a metastatic, colonic metastatic cancer.
Colonic
So in metastatic disease, we have to do mutation analysis like KRAS, NRAS. If there is no mutation, that is wild type KRAS and NRAS, we can add monoclonal antibodies like panitumumab or cetuximab along with chemotherapy. And also we have to do MSI. As already told, if it is MSI high, we can use combination chemotherapy along with MAB, like FOLFOX or CAPOX. We can, along with, if it is wild type, we can add MAB also.
Any role in
Regarding radiation, sir, as madam said, the chemotherapy management, in these situations, radiation plays only palliation only. Whether it's pain palliation or you know, bleeding, okay, with the stipulated doses, with the shorter interval, you are giving the palliative doses. No, otherwise, no help to the patients.
So when there are multiple lung metastases, whether any chance of a radiotherapy for a multiple lung metastasis?
Pardon?
For this patient had multiple lung metastases, sir. Will radiotherapy can be given for such a wide field?
No, so we are giving only the palliative doses only. There's no use we are giving in the full dose in metastatic setup.
For a single, if there is a widespread pulmonary metastasis, we cannot give radiotherapy, so whole field. If it is a single metastasis, all it's like in liver, it is we can try with a single liver lesion. It's a single liver lesion. So we can try with stereotactic body radiotherapy. It's a high dose, it's a conformal radiotherapy we can give. That's all only palliatives. It's a metastatic disease. If it is, we give chemotherapy, if there is response, there is only a single lesion. If it is less than 3 centimeter and superficial tumors, we can try with this ablative procedure or SBRT.
Sir, any hemostatic RT for a bleeding rectal cancer who is not operable?
Yes, we can proceed, sir. We can proceed up to 30 gray in dividing doses. It can be useful. Then, we added some points in solitary medicine, liver, already madam said, that give metastectomy or ablation. That helps more useful. Then the SBRT and SRT, that's a stereotactic radiotherapy and stereotactic radiation there. Using stimulator simple 3 or 4 radiations in given setups, a place that is ablation gives 80 to 83% of the good results. So this is added points to that. Okay.
What will you do if you have a single solitary lung met, sir, in this case?
That's ablation means it ablate the tumor minimal dose up to 3 centimeter in and around and the micromets to ablate.
Radio frequency ablation we can give and chemoembolization. We can give the 5FU chemotherapy with the intra-arterial chemoembolization or radio frequency ablation we can try with single liver lesion. As already told, less than 3 centimeter superficial tumors and oligometastasis we can get, and the lesion should not be close to the vessels.
What is the role of surgery in lung mets, sir?
See, it's the same. Suppose if the lung mets are operable, definitely surgery is the best treatment. You have to achieve R0 resection. But the sequence, I told you the sequence, chemotherapy first, surgery next, or sometimes surgery first, chemotherapy next. But that is in liver, not in lung. But isolated lung metastasis is almost rare in the case of colorectal tumor. So most of the time it may be associated with the other metastasis. If the metastasis is resectable, there is a role for surgery. Definitely there is a role for surgery, but the sequence may vary. Whether it is a primary surgery chemo or chemo followed by surgery, it depends.
Sir, what about the role of an endoscopic stenting, sir? Is it better than an emergency procedure, or it's?
As a surgeons, we prefer to do surgery than endoscopy. Already they are taking lot of our domains. So I prefer surgery, but there is a role for endotherapy. When the patient is not fit for surgery, very fragile, he is on triple inotropes or in supports. So surgery has less role. That case you can do the self-expanding metallic stent. You can put for the temporary measures to optimize the patient. It is very easy to do in the left side. Technically difficult on the right side colon. You have to go a long way. The tumors reaching is very difficult. So there is a role when the patient is surgically not fit, and the endotherapy unit you can do.
See, it is the bridge to surgery. It is the bridge to surgery.
Okay, sir. Sir, thank you, sir. It was a eye-opening session for a lot of us.
Sir, I have one doubt with the surgeons and surgical oncologists. Sir, if we are doing, as you told, the Hartmann procedure, like simple resection for any fragile obstructive disease, if it is after simple resection, we are giving chemo RT or chemotherapy. After that, if we are doing imaging and everything okay, there is a possibility of definitive surgery after Hartmann's or simple resection.
We have to surgery. See, when we were reversing the Hartmann, we have to do it properly. But the one thing is, reversal of Hartmann procedure is very difficult.
decision decided by the tumor board is compulsory in oncological management. In the CARICOM message this, in this colorectal malignancies, radiation. Okay, radiotherapy supplies was you are giving only neoadjuvant or adjuvant or palliation. Neoadjuvant and adjuvant for radical management or conventional management for curative management. One. Then is the adjuvant palliation extremely locally advanced or metastatic, whether proven. When solitary, we going for solitary metastectomy, then followed by adjuvant management, giving the full dose. If patients proved the multiple meds, we only giving the radiotherapy for palliation. Palliation means of pain management, then as well as the bleeding disease. This is the carry home message regarding the colorectal malignancies by my setup.
Thank you so much, sir. So there was a wonderful discussion from the panelists. There was an eye-opener on about colonic cancer and rectal cancer. We had two cases. Actually, we had four cases, but for want of time, we had to cut short it at two. So we'll continue with these discussions in the near future too. Thank you so much, Anish. Thank you, Karthikeyan. Thank you, Amudan. Thank you, madam. And thank you, sir.
Sir, one comment about the TKMC general surgery team. So organ specific approach going to be the future in all the medical field. So a general surgery department focusing on colorectal malignancy, I am really surprising. So a good leader can do this. So we are really jealous about this department because they took our area, our surgical. So I congratulate the team. The general surgery team of the CMC Vellore, first and second unit, they do complete stomach and esophagus work, sir. They do complete esophagus work. Their work is internationally accepted. And the general surgery department of the AIMS is doing the transplant, the urology department doing the robotic work. So if the general surgery going for the organ specific, each unit focusing on one, that will shine. So this is my humble suggestion. So my teacher, Dr. Rakesh, Dr. Nirmal sir, and Dr. Rajkumar sir, and my friend Moses and other friends are there. So thank you for this opportunity, sir.
And one more, last but not the least, டியூமர் போர்டே எதுக்கு இருக்குது அப்படின்னா, நாட் ஃபார் த ஸ்ட்ரெயிட் ஃபார்வர்ட் கேசஸ். எந்த ஒரு கேஸ் வந்து காம்ப்ளிகேட்டடாக இருக்கோ, எந்த ஒரு கேஸில் வந்து டெசிஷன் எடுக்க முடியலையோ, அதில் தான் வந்து வி ஹாவ் டு டிஸ்கஸ் இன் திஸ் டியூமர் போர்ட். தட் இஸ் அ மல்டி டிசிப்ளினரி மீட்டிங். So you take a decision in the multidisciplinary meeting for the interest of the patient, discuss with the family members, then you decide the treatment, you document it, you are medically safe. Otherwise, it's difficult.
Yes, sir. Actually, sir, our institution policy also we can take. Actually, in Omandudar, we took one institution policy and it was legally questioned, and we simply said it is our institutional tumor board policy. Then everything was okay. So it's a medical legally also we will be safe if we are doing the medical.
So thank you all. And to finish the comment on Dr. Karthikeyan, the Department of General Surgery as a leader with no title, because everyone is a leader in this department. As we start from now. Thank you so much for coming out. So next we have the prizes award ceremony for the offstage events. That will follow with this, and with that we sign off.
Now, I request Dr. Dalabalan sir to felicitate Dr. Gandhimati ma'am.
Now, I request Dr. Sugan sir to felicitate Dr. Devanayagam sir.
Next, I request Dr. Dalabalan sir to felicitate Dr. Amudan sir.
Next, I request Dr. Sugan sir to felicitate Dr. Karthikeyan sir.
I request request Dr. Dhanabalan sir to felicitate Dr. Anish sir. Now I call upon all the panelists to felicitate the moderators Dr. Dhanabalan sir and Dr. Sugan sir.
I request all the quiz participants to come to the stage.
Next is the prize distribution. Prize distribution team, kindly get ready with the prizes for the offstage events. Participants, quiz participants, come to the front, please. Yuvaraj Arumugam Uma Mageshwari, Priyanandani Pavitra Samiksha, make it fast. Pavit Muttupandi Sharan, Muttu Vijay, Sharan.
evening, everyone. So this is time to wake up. Now let's move to the interesting part of today's session. Final aspect of Surgifest quiz. So, so regarding the quiz of the Surgifest 2024, yesterday we conducted a preliminary round. Out of 8 teams, the best 3 teams selected for final round today. So now I like to introduce the teams. Team A, Yuvaraj Armugha Uma Mageshwari. Team B, Priyanandini Pavitra and Samiksha. Team C, Pavit Murali and Shah. So totally we have planned for 6 rounds. So without wasting time, let's proceed with the first round. The first round is direct hit round. So I'll tell the rules now. Next slide. Each team will get 2 questions. Correct response gives you 20. Wrong answer, penalty 5 points. Can pass the question to other team if you don't know the answer. And not answering the question, no marks. Other teams answering correct gives you 10 points. And time limit is 30 seconds for each question. So shall we proceed? Team A, next slide. Team A, your question is, name 2 syndromes associated with gastric lymphoma, and your time starts now. Yes. Your time is running.
Viscott-Aldrich syndrome.
Time up, and let's see the answer. Next slide. So Viscott-Aldrich, one answer is correct. Klinefelter, that is the second answer. Lee-Fromeny is not the answer. So I'll give you 10 marks for team A. So now this question to team B. What is T4A in carcinoma stomach? Your time starts now.
Tumor spreads to adjacent structures like portal vein.
Be louder.
Sir, tumor spreads to adjacent structures.
T4A.
Like portal vein.
Yes, wrong answer. Question passes to team C. Metastasis to? Be louder. You're not audible.
Involvement of adjacent structures with resectable.
Be clear.
Adjacent.
Yes, serosal involvement. That is correct. So 10 points to team C, minus 5 to team B. Now next question. Team C, your question is, what is bulimia? And your time starts now.
Bile leak in blood vessel.
How?
erosion of the bile duct, bile from the bile duct enters into the systemic circulation.
Yes, the answer is correct. 20 points to team C. The answer is intrahepatic connection between biliary and venous system. So now question to team C. This comes in this direction. 20 points to team C. Yes. Questions like what is TACE? Your time starts now.
Sir, we pass the question.
Okay. To team A. Team A.
Transarterial hemoembolization.
Yes, the answer is correct. 10 points to team A. Answer is transarterial chemoembolization. This is done for liver metastasis. So chemotherapeutic agent is targeted in that particular site. Yes. Now, the question to team B now. What is the treatment for Zenker's diverticulum? Your time starts now. Your time's up. So 0 points for team B. No, this question passes to team C now. You want to attempt or no?
Diverticulectomy with
Diverticulectomy. No. So -5 to team C. B loader. Yes, I'll give you 10 points to team A. The answer is cricopharyngomyotomy. And what she has told is correct. Next slide. So this is a question to team A. What is meant by care sign? Your time starts now.
It is in splenic injury, pain in the left shoulder region.
Yes, the answer is correct. Left shoulder pain in splenic rupture. So 20 points to team A. Now next slide. So this is a question to audience. So audience, you have to raise your hand. You are not supposed to answer without raising your hands. Name 2 scoring systems that is followed in appendicitis. Please raise your hands if you know the answer. Yes. One more? Anybody wants to tell the second one? If you know the answer, just raise your hands. Yes. Alvarado scoring mnemonic da mandrels. Yes. Okay, anyway, gift to that particular girl. The second one is Ripasa. Next question. So this is again to audience. What is Fitzhugh-Corty syndrome? If you know the answer, raise your hands. Team member, yes. Bill, use your mic.
violin string adhesions between liver and abdominal organs.
Yes, very good. But you will not get points, you will be getting the gift. So it is the inflammation of liver capsule with violin string adhesions. This causes right upper quadrant pain. Okay. So now it's time for points. So at the round 1 is over. At the end of first round, team A scored 50 points, team B -5 points, and team C 25 points. Now let's move to round 2. Round 2 will be hosted by Dr. Anita.
So round 2 is surgical snapshots. So this will contain a series of picture quizzes. So you have to identify what it is. So the same rules apply for round 2. The right answer will carry 20 marks. The past one will carry 10 marks. If you answer it wrongly, it will be -5. So the first picture. So for team A, so what is marked here? It is the accessory appendicular artery. What is the other name of it? Team A. Very good. 20 marks to team A. So what is the significance? It is the only artery that is named after an Indian surgeon. So he was a surgeon from Bangalore. So the next question, team B. So can you try to identify the first picture? The second one shows the treatment of the condition. Can you identify which organ it is? If you want to attempt, you can attempt, but you will get negative marks. Time up. Does anyone want to try the next team? It will be passed to team C.
Watermelon stomach.
Very good. It is watermelon stomach. Can you display the answer? So it is watermelon stomach. 10 points to team C. So next question. So next question goes to team C. So what is this procedure? So the first picture will give you a clue. There is a thoracotomy and a laparotomy. Time up. So the question passes to team A. Do you want to attempt? Team B. So can we display the answer? So you want to attempt, but you won't give. No, but you won't get any negative marks. You can try it. So can you be more specific? Ivor-Lewis esophagectomy. No marks will be rewarded for this. Next picture for team C. So what is this equipment? So if you have really good eyes, you can even see what is written in that picture. If you are able to make it. Told that answer. What is it? What is it? It is a tester used to detect what? Yes, it is to detect the H. pylori. It is a helioprobe. Can you display the answer? So it is a non-endoscopic urease test for to detect H. pylori. So it can be used in children. That's why. Next question. For team B. What is the answer? Very good. See, the answer is Peutz-Jeghers. The 20 marks to team B. So next question passes to team A. So the X-ray shows the picture. Can you answer it loudly? Distal.
Esophagus.
Is it corkscrew or anything?
Esophageal spasm.
Diffuse esophageal spasm. It is just a, the answer is diffuse esophageal spasm. We'll give 10 marks to them. So audience question. So what is this? So be very specific. We even want the indication for this condition.
For anteroperitoneal resection, PER.
Can you give a complete answer? What is it?
End colostomy.
Yeah, very good. It is an end colostomy. Ileostomy. Okay. But she said colostomy, I think. So it is wrong. Anyone else who wants to try it? So it is a picture of end ileostomy done for total proctalectomy. It is a Brooks end ileostomy. Okay, so shall we pass to the, so it is a Brooks end ileostomy done for total proctalectomy. So next will be round 3. Audience question. So we'll have one more audience question. So what is this? So someone,
Tick ring links.
so can you stand up and tell?
GRD links.
Links, yes, it is the links. It is used for what? Very good. It is for GERD patients. It is a laparoscopic technique by which a link system can be inserted in the OG junction. So we'll move. So the points at the end of round 2. So team A has scored 90, team B 45, and team C 35. So quiz. So for the next round, we'll have a round of identifying the surgeon. So this round will contain memoirs from famous surgeons. You have to identify the surgeon. So 3 clues will be given to each team. So if the answer is answered in the first clue, 30 marks will be awarded. If it is answered in the second clue, 20 marks. With the third clue, it will be 10 marks. So the question won't be passed over and there are no negative marks in this round. So can we display the first book? Yeah, for team. So this is a book, Master Surgeon, a biography of Dash. So this book contains a memoir of a famous surgeon. So the first clue will be, next slide. So clue number 1 is, so what is this? If anyone can identify what this instrument is, it is a carbolic acid spray. So what is the other name for carbolic acid? Yeah, very good. So can you guess someone who might have used this? So we'll move on to clue. Can we give a clue number 2? So second clue, please. So this is what? Can you guess this? It is a urethral dilator. It is named after him. It is still relevant, is still being used. If you want, we can move to the third clue. So third clue, please. So he is known as the antiseptic surgeon. So it is pretty straightforward. You can tell who the person is. Can you guess of someone who used antiseptic? Mike. So it is Joseph Lister. So 10 marks to team A. So the answer is Joseph Lister. So we'll move to question number 2. So next book. Next slide. So the life of Dash. He is a surgeon, author and teacher of surgery. Again, this book contains a memoir of a very famous surgeon. Let's move to the next slide. So the clue number, first clue will be, when he was a surgery resident, he had to undergo amputation of the left index finger. If you want the next clue, we can move on to it. Next clue. He suffered from mental illness for which he was on treatment with lithium. This was following the death of his son. So next clue will be very, very straightforward. Before displaying it, it is a famous He is a famous surgeon who co-authored many books. It is a book that is still read by UGs and PGs. And it is not SRB.
Bailey.
Yes. Next clue. Clue number 3. So he co-authored 3 most famous books that are short practice of surgery. As you know, it is Hamilton Bailey. So 10 marks to team B.
Previous slide. That book you display, no?
Can you go to
The answer, let me see. அதிலே answer இருப்பாங்க. Go to the, no, previous.
Sir, Humphreys தான். Memoirs தான்.
No, go to the previous one. See, so it also was a test for your observation power. Huh? Can you see there the life of Hamilton Bailey written on the side? So it was a double quiz for you all.
மட்டும்தான் பார்த்திருக்கேன். Sir, but our HOD doesn't get extra marks for this. So we'll move on to the next question. So this is Hamilton Bailey. So he has co-authored the 3 most famous books still in use. Next book. So Dash and the World Revolution of Dash. So the first clue. So he described total colectomy with ileoanal anastomosis for familial polyposis. Do you want to try or can we go to the next clue? Next clue. So he is a famous surgeon who operated on Einstein for an impending abdominal aorta aneurysm. Next clue. So he was the orchestrator of the abdominal procedure for severe GERD. There is a procedure named after him. So you can try. Yes, you are almost right.
Listen.
Yes, it is Nissen. It is Rudolf Nissen. So the answer is Team C, 10 marks. So it is Rudolf Nissen. So we'll go for an audience question. So again, this is a memoir of a famous surgeon. So the first clue will be, so he explained about chimerism. Can we move to clue number 2? So again, so this gives a clue what kind of surgeries he could have done. He made research on chimerism. He started using cyclosporin and tacrolimus. So it is related to what kind of surgeries? PGs, anyone wants to try? So the next clue. So he is the father of liver transplant. So someone from the PGs. Very good. So it is Thomas Stars. So that is a famous quote by Thomas Starzl. History tells us that procedures that were inconceivable yesterday and are barely achievable today often become a routine tomorrow. So he is a famous person behind liver transplant. He had done nearly 200 liver transplants in dogs before he attempted a transplant in a human. So the points at the end of round 3, Team A 100, Team B 25, Team C 45. So next round will be conducted by Dr. Anas.
So now come back to round 4. This is a connection round. And the rules for this round is, next slide. and it is similar to round 2. Okay, and you'll be getting penalty mark if it is a wrong one. Team A, your slide is. Yes. Your time starts now.
Umbrella sign.
Okay, very good. The answer is correct. In which condition this is seen?
TBC come.
Very good. So the answer is correct. 20 points to team A, inverted umbrella sign. Now the question to team B. Be louder.
Gooseneck deformity.
Yes, the answer is correct. Gooseneck deformity.
It is also seen in ileocecal teeth.
Very good. So 20 points to team B. Team C, your question is? Your time starts now. Your time's up. Team A, you want to attempt? Team B, you want to attempt? Audience? Yes. Yes, actually he also found out, but he is not able to answer properly. The answer is Wim Silverman needle. So now the question comes in this direction. Team C, your question is? Others, please keep quiet. Let them try. Your time started. Yes, your time's up. Question passes to team A. Yes, the answer is correct. 10 points to team A. The answer is capitonage. This is a treatment option for hydatid cyst. Yes, next question to team B. The time started.
Sister Mary Joseph.
Yes, it's an easy question. The answer is right. Sister Mary Joseph's nodule. So 20 points to team B. Now, question to team A. Yes, the answer is right. Okay, 20 points to team A. Now, audience question. A simple question. Very good. It's a teapot deformity. So at the end of round 4, the points are Team A 150 points, Team B 65 points, Team C 45 points. Now for want of time, we'll skip the dumb charades and we'll move to the last round. Yes, next. So this is rapid fire round and the rules are, so each team will get 4 questions. Correct response gives you 10 points, wrong answer penalty 5 points. No response, 0 points. You can't pass the question to other teams. Time limit is 1 minute. Okay? Next slide. Now the question to team A. Are you ready? Okay. The question slides are. The questions are Karman meniscus sign, Dialophi triad, Hartmann's procedure, Eros protocol.
Malignant.
Don't expect more for my response. You keep answering.
So Hartmann's procedure, proximal end colostomy with distal end Hartmann's pouch. It is used for a toxic patient in certain conditions like for colonic cancer.
You can tell it in a single word. No need to
ERAS enhanced recovery after surgery for colorectal cancer.
You want to attempt Dialophi triad? Yes, time's up. So team A has answered 3 answers correctly. So 30 points to team A. So first one is mucosal fold pattern in malignant gastric ulcer, Carmen meniscus sign. The second one, dilophoid triad is seen in appendicitis. And the triad is hypersensitiveness of skin, McBurney's tenderness, and reflex muscle contraction. And Hartmann's procedure is the answer is right, colostomy with rectal sealing. And last thing is ERAS protocol is followed in pre and intra and post-op period. Yes. Next slide. Team B. Are you ready now? Yes, your question slides are Wangenstein procedure, Alkmaar technique, notes, TME with CAVL. Your time started now.
So rectal prolapse. Notes natural orifice.
Please don't help. Ten more seconds.
Natural orifice transesophageal surgeries.
Trans? Esophageal. Okay, your time's up.
Endoscopy.
So what your answer is Alkmaar technique is done for rectal prolapse. You are partially correct. What is that? But you have not answered properly. And notes also a wrong answer. -5. So Alkmaar's technique I give you 5 points. So that 5 minus 5 is 0 for you totally. Your answer slides are Wangenstein procedure is done in intestinal obstruction. This is nothing but gastric suctioning is as effective as enterostomy. And the second one is Alkmaar's technique is perineal rectosigmoidectomy. So this word I expect from you, and this is done for full thickness rectal prolapse. And the third one is note, it is not transesophageal, it is transluminal endoscopic surgery. Okay. And last one is TM with CVL. Already that thing was discussed in the panel discussion. So I think you could have answered total mesocolic excision with central venous ligation. Okay. Now to team C. Are you ready? Yes, your question slides are Carney triad, Caroli's disease, Duhamel procedure, poem.
Duhamel procedure is done for Hirschsprung's disease. Hirschsprung's disease.
Peroral endoscopic myotomy.
Carney's triad is seen in gastrointestinal stromal, GAST, gastrointestinal stromal tumor. Carney's triad consists of gastrointestinal stromal tumor, then paraganglinoma, multiple enchondromas.
Five more seconds. Okay, time up. Carney's triad, your answer is not correct. It's not the, okay, the answer is adrenal paraganglioma, mucin adenoma, and dilated main pancreatic duct. Your answer is wrong. So -5 for that particular question. And Caroli's disease is segmental dilatation of large intrahepatic bile ducts, udinatum. And the third thing what you are told is correct in Hirschsprung's disease, doing coloanal anastomosis without removing rectum. And poem, they're also correct. Per oral endoscopic myotomy. So totally 20 minus 5, 15 points to team A. So every round is over. Now I request our beloved Professor Rakesh sir and Professor Nirmal sir to come and declare the results.
So I thank the quiz masters Anish and Anita for having conducted a wonderful quiz. That was a real mind-boggling questions they had put up for you. The The connections were enjoyable. And thank you, Anish and Anita, for having done this. So, Team A has stopped with 180 marks. And there's a huge difference between Team A and Team B. Team B has come down with 65 points. But Team C has given a tough fight with 60 points. Anyway, it's not about winning or losing. It's about participating. Congratulations to all of you. And may I call upon Team A on stage for the prize, please. I request Professor Nirmal Kumar sir to hand over these gifts.
Team B on stage, please. Thank you. We move on to the prize giving ceremony for the offstage events.
Okay, now we'd like to distribute the prizes for the offstage events. We're going to start from the first event, pot painting. We'd like to, from pot painting, we'd like to invite photography. For the first event, we'd like to call upon Dr. Shaheen ma'am to give away the prizes. The first place goes to Dr. Anupama ma'am. Please come to the stage. The second place goes to Dr. Mohammad Marzouk sir. The third place goes to Dr. Brahmaya sir.
would like to announce the winners of vegetable carving competition. I invite PG Dr. Nivas sir for the prize distribution. The first place goes to Team 7, Samrita Shri and Ritika Rajini. The second place is backed by two teams. Team 3, Sasimadini and Anita. Team 5, Rahini and Kamesh. The third place goes to Team 9, Sharon, Jesslyn and Gayatri. Give them a big round of applause. The third place goes to Team 9, Sharon, Jesslyn and Gayatri. Let's give them a big round of applause.
Moving on to the next event, we would like to announce the results for pot painting. I would like to call upon Dr. Asha ma'am to give away the prizes. The first place goes to Team 2, consisting of Shweta SP and Shalini. The second place goes to Team 4, consisting of Rakshita and Amrita. The third place is backed by Team 10, consisting of Megha Varshini and Subhashri. The third place goes to team number 10, Megha Varshini and Subhashri.
Next, we have the prize distribution for the competition Art from Waste. Now I invite our PG Dr. Jhansi ma'am to the stage to give away the prizes. The first place goes to Team 4 consisting of Vetrivel and Dharani Dharan. Join me in giving them a big round of applause. The second prize goes to Team 6 consisting of Ramya and Jebisha. Let's cheer them up. The third place goes to Team 3 and Team 7. Team 3 consisting of Mary Winslet and Vembaraj. Team 7 consisting of Malavika and Nandini. Let's give them a big round of applause. I request the participants of every competition to be ready.
For the first event, pot painting, we'd like you to assemble near the stage in the order of your names. We request Dr. Mahindan to approach the stage to distribute the prizes for the following. The first participant is Shiva Vignesh, Durai, Shivani, Aarti, Ram Prasad, Yogesh Meena, Kirtana, Komal, Shalza, Shrikaran. Om Karshan, Aditya, Sri Mehta, Kavya, Priyadarshini D, Priyadarshini M, Varshini and Tarunika.
I request the participants to assemble near the stage.
Okay, we'd like to call Dr. Shaktivel sir to give away the prizes for the next event. Sir, Mahinda sir first. Okay, the next few participants, Sharmita, Balashruti ma'am, Velvili, Ashima, Selvam, Kanimoli, Aarti, Shalini Mary, Janani, Bhairavi. Please come onto the stage to collect your prizes. I'd like to call the names once again. Sharmita, Balashruti, Velvili, Ashima, Selvam, Kanimoli, Aarti, Shalini Mary, Janani and Bhairavi.
The participants of vegetable carving event. Team 1, Shanmugapriya Sharanya, Muthuselvi Angel, Jarshini Kantalakshmi. Please come onto the stage to receive your prizes. Vasima, Supriya, Kavipriya, Aishwarya, M. Shanmugapriya, Rohit, Ravina, Lynette Jose, Rubadarshini, Shivita.
I invite Dr. Mazuk sir to give away the prizes.
Participants of pot painting event. Siva Vignesh, Durai, Shivani, Aarti, Ram Prasad, Yogesh Meena, Kirtana, Komal, Shalza, Sriharan, Omkar Harshan, Aditya, Sri Mehta, Kavya, Priyadarshini D, Varshini, Darunika.
Next, I invite Dr. Guhan to give away the prizes. Asha, Sindhu, Mazuk, please. Next is Gohan.
Okay, for the final event, Art from Waste, I would like to call upon Dr. Sindhu ma'am to distribute the prizes. Niveda, Niranjani, Ganapati, Ganga, Ganesham and Vignesh Pandey, please come to the stage to collect your prizes. Niveda, Niranjani, Ganapati, Ganga, Ganesham and Vignesh Pandey, please come to the stage.
I request all the participants of the offline events, Surgifest 2024, to come onto the stage to receive their prizes. If anyone left, kindly I request you to come onto the stage to receive your prize.
Okay, the next few participants, Nafia, Nafisa, Priyadarshini M, Priyadarshini D, Kirtana, Sankirtana and Sita. Please come to the stage if your name is called. Nafia, Nafisa, Priyadarshini M, Priyadarshini D, Kirtana, Sankirtana and Sita. Okay, ma'am. Okay, we would also like to call upon Sneha, Meena, Magdalene, Shankar, Safin, Hemapriya and Kavya to the stage.
Yeah, Dr. Kannan, come to the stage. Any participants haven't received? Any participants left out? Anybody?
Thank you all for staying with us till late this evening, maintaining your silence, participating actively. Thank you so much. Please wait till we all take a photo together. Before that, I would like to honor our sponsors, many of them, but only 2 people are available now. I'd like to call the Aristo Pharma, Mr. Anush, am I right? Mr. Anush? Mr. Satyanathan from Sun Pharma is available? Satyanathan? Yeah. I request Professors Nirmal sir and Devanathan sir to honor them with a shawl. So these 2 people are from Aristo Pharmaceuticals. They are with us since yesterday. They have been providing us with snacks non-stop since yesterday morning until whatever we had today was provided by them. Thank you. Thank you so much. Thank you. Thank you. And Mr. Satyanathan from Sun Pharma. They have sponsored a part of our lunch in the afternoon. Thank you so much, Mr. Satyanathan. Thank you. Last but not the least, this 2 days of entertainment with audio and video was done by Mr. Peter and his team. More than what they have done today was as you would all witness, was a splendid display. They kept us lively with so many displays, non-stop upstreaming of live surgeries. You know from where? 500 kilometers apart, from Coimbatore. We had 2 live surgeries going on, side-by-side screens continuously. Everything was seamlessly provided yesterday. It was just not video, we were interacting with them at every step of the surgery. So that was made possible by Mr. Peter and his team. Mr. Peter, come. More than the technical part of it, what I would most love in this man is his smiling face. I've been associated with him for the last 10 years. He has been doing live workshops for us for so many years. He always keeps smiling and he never says no to anything. Whatever we can tell him anything, you do this, you do that and all. He'll never say a no. Thank you, Mr. Peter. And Mr. Peter will never say a no, and he'll also not say no when I'm going to reduce his bill today. Thank you so much.
Yeah, invite our registrar, Dr. Meena Ranjani ma'am, to honor the quiz masters, Dr. Anish and Dr. Anita, with this memento. Thank you. So pages kindly arrange for the group photo. So please, all of you stand. from this end, we will take the photograph. UG, stay back for the group photo. UG, stay back for the group photo.